nasopharynx. And on CT, we can see the near total opacification of the left maxillary sinus on the frontal scan, and then in sagittal scan and axial scan also, with central hyperdensity in the left maxillary sinus. The diagnosis is mycotic maxillary sinusitis on the left side, and procedure will be supraturbinal antrostomy on the left side. So you can switch the screen in operating theater.
Victor? Hello.
Hello.
Yes.
Good morning, everybody.
You can
Can
start,
you hear
please.
me?
Yes, we can.
So we have the lady, 52 years old, which was introduced by Vicky and Chapáček. And we will start with endoscopy. On the right side, we use the vasoconstriction with adrenaline. The patient is in the supine position on the back. And here we are on the right side. So there is no pathology to Frida. And at first, we should start with rhinoepipharyngoscopy. So as you know, we can see the inferior turbinate. Here is the inferior meatus. So if we do the lavage of maxillary sinus, we use this approach. And during the endoscopy, we continue parallel with inferior turbinate to the posterior part of nasal cavity. And now we are in the epipharynx. If we use the suction tube, and I can put the suction tube through the second side, through the left side, so you can see the remnant of lymphatic tissue, adenoids tissue in the epipharynx, and here is the entrance to the Eustachian tube on the right side, and you can see the torus tubarius. If I change the position of endoscope, I can see the Eustachian tube orifice on the left side and torus tubarius. So there is no pathology, just only a little bit lymphatic tissue on the posterior wall of nasopharynx. So it's the first step of rhinoepipharyngoscopy. We can also check the roof of Coan, which is important if we are interested for sphenoid sinus, and we can examine sphenoethmoidal recess, but here is a little bit spin on the nasal septum, so I cannot go upper. I can see just only part of sphenoethmoidal recess. And now we see the tail of middle turbinate on the right side, and here is the head of middle turbinate. There is a little bit blood, and it's a third step of rhinoepipharyngoscopy. So as I mentioned,
Viktore, can I interrupt you, please? Můžeme ten pohled na pana profesora, abychom viděli celé jeho tělo? Ne ten detail, zevní pohled, ale abychom viděli, ano, thank you. It's better, maybe, možná i ukažte, kde je obrazovka, ukažte, co tam jde vidět ze zevnějška. Děkuji.
So now you can see my whole body, and you can also see the whole body of nurse. This nurse is called Sonia, and I am very happy to be here with her. And we can see on the screen the head of middle turbinate. And if we make a little bit medialization of middle turbinate, we can see the middle meatus. And there are very important structures as an uncinate process, which is here. And here is the bulla ethmoidalis. And between them is hiatus semilunaris. And there is a primary ostium of maxillary sinus. If you check this region, you can see a little bit edema here in the upper part of middle meatus. And this structure, where is the connection of middle turbinate to the lateral wall, is called operculum. And behind this structure, there is an orifice of frontonasal duct. So it's a normal anatomy on the right side. So if I conclude, we have here a little bit deviation deformity of the nasal septum, the spina, and we have a little bit edema in the upper part of middle meatus. But there is no pathology, so we will not continue with the surgery on the right side. Chapáček. And we will continue on the left side. So you can see the entrance to the nasal cavity. So there is a hairs, which is called vibrise, and we remove the vasoconstriction package. And jsou dvě? Ne. Tady, teď je druhá. Sání. And we can continue with the rhinoepipharyngoscopy. So very important is the anatomy of lateral wall, as I mentioned before. So the first structure which you can see is a head of inferior turbinate, which is here. And if you go parallel to the inferior turbinate, you are in the koan. Here is the roof of koan. And after, we are in the epipharynx, as we saw before. So here is the adenoid tissue a little bit. Here is the Eustachian tube on the left side. And we can continue with the endoscopy. Now we can suck a little bit mucus from the sphenoethmoidal recess. I can wash the tip of the optic. And there is a little bit edema and small polyp, which are medially to middle concha, okay? So there is a little bit pathology. And here is the head of middle turbinate, middle concha. And we can make the medialization of this structure. Poprosíme toho Frýra. Sometimes we can find the pneumatization of the head of middle concha, which is called concha bullosa. And if we make this elevation, we can see the middle meatus. Here is the uncinate process, which is here. There is a little bit edema. And we can start with the resection of uncinate process. So there is described a lot of approach how to remove this process. And you know that uncinate process consists from two parts. The first part is vertical. Poprosíme ten sepek. And the second part is horizontal. So I will try to clean the optic. And we use the special knife. And here is the vertical part of uncinate process. And we can start with incision. And we should cut the mucosa and also the small bone. And we elevate this structure to medial position. So this is the resection of vertical part of uncinate process. And during this surgery, we have not touched the operculum, because if we destroy this superior part, we can make the stenosis of frontonasal duct, and during several years the patient can have the mucocell of frontal sinus. Chapáček rovnej. Tak. And if we remove the vertical part of uncinate process, we should make the rotation to the lateral position, because during this motion, sání rovný, we didn't damage the superior part. So now we did the resection of uncinate process, and we will remove this remnant, which is here. And, okay, sání. So we can see a little bit thick mucosa. So it's information about the inflammation. Here is a remnant of this mucosa, chapáček. We remove it. And the second step during the supraturbinal antrostomy is opening of ethmoidal bulla, which is a little bit posteriorly. And ethmoidal bulla is the first ethmoid cells. So just now I opened the anterior wall of ethmoid bulla, and it's recommended to go down, because if you go up, you can damage the roof of the nasal cavity, and here is a skull base. So if you open the bulla, you should know that the roof of the bulla can be also the frontonasal skull base. So now we are in the bulla. We remove this part. There is an edema, chapáček.
Victor, may I ask?
Yes, of course.
Do you think it's necessary to open the bulla during supraturbinal antrostomy?
So if we have no inflammation in the bulla, we can preserve the bulla. But here I can see the thick mucosa, so I think it's better to open the bulla. Zahnutý sání. Zahnutý sání. So I clean the optic. So to střední. So now I use the banded suction tube, and we will try to go to the maxillary sinus. So if you use this suction tube, it's very important to go very nearly to inferior turbinate, and now we are in the maxillary sinus. So if you go here in the upper part, you can damage the orbit. So prevention of damaging of orbit is follow the inferior turbinate, and now we are in the maxillary sinus. So you see the posterior wall of maxillary sinus. Poprosíme o stroma, to je ten zpětný štípák. And we will continue with supraturbinal antrostomy with special back forceps. And we put this forceps into the nasal cavity and open just now. And we cut the medial wall of maxillary sinus. And here is very important that we cannot go more anteriorly than is the head of middle turbinate, because you know that in this position is nasolacrimal duct. Poprosíme široký sání rovný a odsajeme si to všechno. So if we have bleeding in the nose, we can use the larger suction tube, and it's recommended to use the straight suction tube and make the suction in the whole nasal cavity and also from the epipharynx. I try to wash the endoscope with the water. I use the suction tube, and now we suck from the middle meatus. So, and now you can see the white tissue, which is the mycotic infection, 45 chapáček. So they wanted to use this specimen for scientific examination. So I will remove this mycotic infection from the maxillary sinus, či to je na těch lahviček, sání. A přehodíme si to teď na sání, to široký zahnutí. So we clean the optic and we will continue with supraturbinal antrostomy. So as you know, the mucociliary transport from the maxillary sinus goes to the middle meatus. So nowadays we don't use the infraturbinal antrostomy, and we use the supraturbinal antrostomy. Tak chapáček rovnej. So here is a little bit mucosa, I remove it. A široký to sání zahnutý. So we try to preserve the middle turbinate. And now I use the larger suction tube, banded suction tube, and we will try to put it to the maxillary sinus. And now we remove the specimen of mycotic infection, 45 chapák, ten větší, and we will send it to examine, to je 90. Okay. So now we remove this mycotic infection. Ještě to sání. Ty zbytečky dávejte na to vyšetření. So we are in the maxillary sinus and we are removing the mycotic infection just now with the suction tube. Tak, ten chapáček, rovnej. So we have this infection in the entrance of nasal cavity and we put this specimen for examination. Okay. So I have the question to the Petr Matoušek, which research do you make with this infection? So what is the main goal, the aim of this study? Rovnej chapáček.
The aim of the study is to find out what caused hyperdensity in CT scans, what kind of minerals it is. And I think that you have Dr. Polášková on the operating room, which is a PhD student who are interested in this topic. She will have a presentation about that problems, about mycotic sinusitis, I think tomorrow.
Okay, so it's nice that we will hear this presentation. So as I know, you cooperate with the Technical University in Ostrava during this research?
Yes, yes. For electron microscopy and spectroscopy, what kind of chemical agents are there.
Okay, so now I remove this specimens from the maxillary sinus. So yeah, I use the 30-degree optic and we remove everything from the inferior part, and there is a little bit in posterior part. And she asked me also to take the biopsy of mucosa from the maxillary sinus. So can I have this biopsy from the posterior wall, or do you prefer any other part of maxillary sinus?
I think it depends on you. Mucosites, we want to know if it's invasive or non-invasive mycotic infection. You mentioned that you are using 30-degree endoscope. Yes. You are looking up now, yeah?
So now I am looking up and I want to make the supraturbinal a little bit larger. So I use the back forceps and I remove this part. So if I have the small specimen of mucosa, can I use it for the histological examination?
Yes.
Because I need better view to this part, and you can see that there is a more specimen of mycotic infection, as you see.
Nicely seen here.
So I try to remove rovnej chapáček. So you will have a lot of specimens, so you will have a lot of presentation. Tak, a 45 velkou. So we remove also this part. So very important in this case is to cooperate with stomatologist, with dentist, and ask them if the etiology of this disease is from the teeth. So we have in the audience Jürgen Abrams. So he's also medical doctor and stomatosurgeon. So what is your opinion about the CT scan of this lady? Is there any pathology in the tooth?
Good morning, Victor.
Hi.
Yes, I just look at the CTs, only one slide, but normally you cannot decide from the slides if there is a dentogenic infection of the maxillary sinus. It is not there's not too much information on this one slide, and I think normally the slides we get from the CT scans is normally slices from 1 millimeter, and I by myself do also most cone beam CT with 0.4 millimeters, so then we can decide if there is a dental, if the dental situation is responsible for this situation here. I cannot even say who the dental status is here. So we just have a look in the mouth afterwards, if you can do, and then we can get a little bit more information.
So we will check the mouth with the endoscope, and I will show you at the end of the surgery, okay?
So, and do you think that it's a strong connection between this mycotic maxillary sinusitis and dental procedures or dental pathology?
It's not a strong relation, but we often see this more often. And I was a little wonder a little bit about the research about the material or the metal is responsible. It's zinc. We know this in this fungus here, fungus ball. It's zinc. We know this because it's mostly from filling material from the roots, and now we can see this here. Oh, she said she has no dental treatment before, so that cannot be from this teeth here.
The thing against is that fungus ball we can see even in sphenoid sinus, for example. Yeah, no connection to the dental roots.
Yeah,
it's zinc oxide. That's responsible for the shadow in the CT scan.
So now I will use the lavage of maxillary sinus, to zahnutý sání a tu vodu. To nejširší zahnutý sání, ne rovný, zahnutý. Půjde tam dát? Ne, zahnutý sání. Tak. To tam nedáte? Tak. So I have the suction tube and I have the water and I will put the suction tube to the maxillary sinus, and we clean this maxillary sinus with the water. So you can see a lot of water, but it's very important for široký sání rovný, for cleaning of maxillary sinus. I clean the optic because we should preserve the mucosa of maxillary sinus during this approach. And now, after lavage, you can see the remnant of the fungus ball. So we can remove it very simply. And we have more specimens for examination. Now we clean the nasal cavity. Here is also a remnant of this fungus infection. So it's really nice case. Lepší to sání, potřeba by to odsámalo. To druhý je širší, ještě to rovný, nebo tohle je nejširší? Tak, dejte to nejširší, to rovný. And we use the suction tube, very large suction tube, for removing this specimen. And during few minutes we will finish with the surgery. And maxillary sinus, I think, will be clean. So we did the endoscopy of both nasal cavities. We did the resection of uncinate process.
Victor, here's Jürgen. Did you use a 70 degrees endoscope?
So we can use it. Ještě to široký
because then you can see at the bottom from the maxillary sinus here. And where?
So we should ask the Petr Matoušek if it's possible to use the 70-degree endoscope in this operating theater.
I think yes.
So here is the remnant of the
45 we can.
You have 45, okay? Ještě jednou bude ten výplach. So you can see that there is more pathology, or I will try to remove it.
I think the better view you will have if you rotate the endoscope and you look down, because...
I do it. I am doing it. I will try it. So at first we use the lavage. So we use the lavage of the maxillary sinus again with a lot of water just now. Odsajeme široké rovné sání. Tak, teď máme ten ostrý směrem dolů, jako na to oštípávání, co chcete. Ne.
Ožírátko dolů.
Ten voďoubálák, jak si tomu říká.
Ožírátko dolů.
So we have a lot of instruments for surgery in the nasal cavity. And this is the sharp instruments which we can use for removing of mucosa in the inferior part of antrostomy. I think that this instrument was established by Daniel Simen. He is from Zurich, and he developed this instrument for removing this part of inferior part of supraturbinal antrostomy. So if we are talking about the first single surgery, fast surgery, which is supraturbinal antrostomy, rovnej chapáček, we should know that we can make different window, I mean different large of this window, and in the literature are described 3 different sizes. The type 1, it's a small, type 2, it's a middle, and type 3 is a very large supraturbinal antrostomy. And if we do this surgery, to zahnutí sání, we should preserve anteriorly the nasolacrimal duct. So it's important to know that nasolacrimal duct is more anteriorly than is the head of middle turbinate. So in this region is nasolacrimal duct. So if you use the ostrom, which is the back sharp forceps, don't continue with this removing of tissue anteriorly than is the head of middle turbinate. So the second board is inferior. So if you go down, you can damage the inferior turbinate. If you go up, you can damage the orbit. So please follow the roof of maxillary sinus. And if you go upper, you can damage the orbit. And the last but not least is the posterior part of supraturbinal antrostomy. And if you continue posteriorly, you can damage the branches of sphenopalatin artery, which are here. So don't make the supraturbinal antrostomy larger to the posterior part. So now we check the maxillary sinus. And I will remove all mycotic tissue. At first we clean the optic. And now we will see the whole maxillary sinus. So there is no pathology on the posterior wall. There is no pathology on the superior wall. If I change the 30-degree optic, I can check this part. And here is a remnant of mucus and mycotic infection. So we have to remove it. So široký sání. So we will continue with surgery. So it's the really nice case with nice pathology. So a lot of fungus.
Victor, it's actually a question for in between. You just mentioned the different sizes of the middle meatal antrostomy, so type 1, 2, 3. Do you have any gut feeling or personal experience that you need like a minimal size accomplished during this type of surgery to prevent recurrence? Or do you tailor your approach exclusively on the need to get rid of the fungus?
So it's really nice question, and I can divide the question to two parts. So the first part is approach to the maxillary sinus. So if you need the approach, you should have supraturbinal antrostomy larger. So it's a first point. And the second point is the function of maxillary sinus after surgery. So if we make very large supraturbinal antrostomy, there is a question if we have mucociliary transport in this way. So somebody recommended to preserve one part of the primary ostium, which is important for mucociliary transport. So we can discuss this topic, but for me, just now it's budeme ještě vyplachovat. It's an approach to the maxillary sinus because we have to remove all fungus from the maxillary sinus, and you can see that we have a little bit problem on the lateral wall. So probably we will have to remove small part of supraturbinal antrostomy, or we can use this lavage, and during the lavage some specimens can go out from the maxillary sinus. So what is your opinion, Jürgen, about the size of supraturbinal antrostomy? Do you use different size during your surgery?
Yes, a different size. Stamberger said that you don't have the whole round. You have to leave, as you told here, a part of mucous membrane intact from the natural ostium. But what I do here in this case, I would more rinse with nasal decongestions. That sometimes it's a better overview. And if the hole becomes too great and I cannot look at the bottom of the maxillary sinus, I remember that I operated 35 years ago through the lower meatus and first identify the lacrimal duct, and I do a little hole in the lower meatus, and then I see at the bottom of the maxillary sinus. And that is not so. For me, it's better to do this because it doesn't hurt so much mucosa if you do this hole as we do it in earlier times, and it's also good for the drainage of the maxillary sinus.
Okay, thank you, Jürgen, for this comment. And I have information from the second operating theater that Professor Komínek is ready with surgery of nasolacrimal duct. So we can switch to the second operating room, and I will finish this surgery with cleaning of this remnant of mucus from the maxillary sinus. You see, and here is also small remnant. So now you can switch to the second operating room, and if we have time, I clean it and I will show you clean maxillary sinus, okay? Thank you for your attention.
Thank you very much, Viktor, for a nice surgery.
Thank you, everybody.
And we can switch to the operating room 7.
Dáme si široký sál.
Pavel, can you hear us?
Yes, that's me and Dr. Červenka. We have prepared child, I think that 1 year old, with congenital nasolacrimal duct obstruction. Can you hear me?
So we introduce the patient, yeah? So
yes,
wait a
okay.
second,
Okay,
please.
so we are still waiting.
The next case is number 17, the child with congenital nasolacrimal duct obstruction. It's a 1-year-old child who has had epiphora, it means excessive tearing on the right side, and recurrent and frequent inflammation of the conjunctivitis, and repeated massages and probing without effect. So this is a child, And the test fluorescein dye disappearance test results 2-0, and ProBank encounters a soft stop at 24 millimeters. So intubation of the nasolacrimal duct is indicated, how we can see in the operating theater number 7.
Okay, we have introduced the patient, so we can switch to the screen.
I would like only to precise that probably...
Second, please. Yeah, now we have a...
Introduced. So it is child with bilateral congenital nasolacrimal duct obstruction for bilateral intubation of lacrimal system. So Dr. Červenka will do now probing of lacrimal system.
Yes. We have been using Bowman probe. You can see it. First step of dilatation of lacrimal puncta inferior superior. Now is Bowman probe inserting into the lower canal. Here I feel lacrimal bone, such a hard stop. Probe is changing the direction into the nasolacrimal duct. And here I feel obliteration and it's perforated. We can measure the distance. Distance is at about 25 millimeters. It's in children the end of the nasolacrimal duct. The second eye, dilatation of lower and upper puncta. Inserting Bowman probe. Via lower canaliculus. Here feel hard stop changing the direction into the nasolacrimal duct. And here also we feel obstruction, it's perforated. Now it's necessary the comfort position of the probe from the nose.
Yes, now we go into the nose. Usually we do it after probing and suction.
Velký obraz na endoskop, prosím.
Příliš veliký. Aha. And now we do nothing. And can you give me a sondu probe? And it is inferior meatus, and we insert this probe in inferior meatus, and if it is, and we feel the second probe, the Bowman probe, and we say so-called metal to metal. I don't feel it quite well, so give me respiratorium, and we push the inferior concha medially to have there more space.
Kind of endoscope do you use, Pavel? Are you using?
I don't. Once more.
What kind of endoscope? Normal, 4 millimeters, or
30 millimeters, 30 degrees, 2.7.
2.7.
Méně zahnuté. Oh. Asani. It's bleeding now. It's pity. Usually.
Due to anesthesiologist, I think.
Can you... vidíme sondu.
Vidíme.
Yes, it is there, yes. Usually it's not necessary to be there with endoscope because we feel, it's our feeling metal to metal when we touch this probe. Malý proužek s sanorinem. Proužek. And so we can go back to the left side and we insert there some vasoconstrictor for a few minutes. No. Dejte, Jana. No, to je pincetu nějako nemáte. No, dejte. Ne, to jsou už. Ne. No, tak dejte lamenou pincetu nosní, když tak. To je na houbě toto. Nosní pincetu nachystejte ještě. Yes, okay. Okay, now we change the position and now we will do intubation.
Ještě tady jsme to nepotvrdili.
Zase změňme prosím pohledy na zevní velký a endoskopický.
Probing once again for conformation of the end in the nose. Yes, okay.
Tak, pojď se přehodit.
Endoskop velký, prosím.
Dejte mi sondu. Now again I insert this probe to the inferior meatus. I again don't feel it now, but I would prefer not to do now anything, and we can do it after insertion of the probe. Once more.
I don't feel it, so pojďme endoskopicky.
No. Sáni?
There. Under the mucosa.
Sáni, mějte.
Dej mi červené sáni, jo?
Jano, očistěte.
Under mucosa, yeah.
It's mucus or because the probe can be inserted under mucosa, can be inserted in the mucosa of inferior meatus sometimes, but it's not quite common, but it can be, yes. Můžete přepnout. No. Ještě jednou očistěte.
To je jedna podslíčně a jinak já tam chytám z kořetu. Já to cítím.
Já bych to přesondoval, Stando.
Pojď, klidně znovu.
We think it's under the mucosa.
Yes. So we do it again. We try to repeat it. It can happen.
And I mean, for like all the participants, especially the younger ones from Germany, because I know how less frequent we are able to see this kind of excellent endoscopy done by Professor Kominek in this extremely narrow space. And if you try to do that, if you are, at the beginning of your tremendous career, you'll see that it's really, really tight. And to see something and then the bleeding starts is really a challenge. So I think it's a wonderful moment for us to see it relaxed, okay, and observe, and not being the person responsible to have to achieve the goal of getting the probe through. But be aware that this is really a challenge in terms of, getting there. And it's wonderful to have one of the European top leaders doing surgery.
So if I can interrupt you, the probe was there visible now quite well?
Yes, the probe was about 25 millimeters that in the end of the nasolacrimal duct, and there were vertical membrane between nasolacrimal duct and nose. That's such a buried probe.
So now we can continue with intubation. We start on the left side and we insert the
intubační.
On the left side, yes. Where was this vasoconstrictor?
We have been using intubation sets. We can see it. It's bicanalicular intubation set, two probes and silicone tube.
Detail nebo endoskop, prosím pěkně, aby jsme viděli ten set.
Yes. Two probes.
So there are two metal probes, and it is connected with silicone tube with lumen. Yes, it is automatic connection of the metal and of silicone.
Yes.
These probes are from FCI. It's France company. From this company, it was produced in Czech Republic by LACS company, but it was not. They didn't continue with the production due to some restrictions, administrative restrictions, yes, of European Union. So these probes, these sets are not so good. The material of metal is too weak and is not good. The manipulation with this probe is much harder than with our Czech.
Yes. The probe is inserted via inferior canalicculus, lacrimal sac, nasal lacrimal duct. Okay, and now it's necessary to remove.
Can we do it on the both sides?
It's
yes,
possible.
We can. We will do it on both sides.
Yes.
Pincetu, počkej.
It's the same.
Pincet tady. Pincetu.
No. Inferior.
Počkej.
Canalicculus changing the direction. And now,
for removing it is yes, again challenge because the space is narrow. We have been using special sling for it. Can you show me? It was made. It is handmade. Yes. I don't think that it is allowed.
Endoskop velký, prosím.
Endoskop velký, what can I do?
Endoskop velký znamená endoskop velký obraz.
So this thing is approximately 0.05 millimeters wider than the probe. So we can go to the nose again. I don't see now. It is necessary to see the probe. Yes, yes, I can see it there, but it is not optimal view because there is too much blood. Ten stůl, můžete mi snížit ten stůl trochu, to je celé vysoko na mě. Trochu snížit. Dobrý. It's more posteriorly than usually. Now I don't see the tip of the probe, still don't see. It is going well, it is operation for 3 minutes, yes, nothing more. If it is bleeding, it is not so easy. You know.
Tohle zkusíme trošku odtlačit od té boční stěny. Já to nemůžu ušitat jinak.
Dejte mi, Jano, tenčí. Ať mi to nepadá, Jano. To táhne tady, ať to nepadá. No, dejte ten. Yes, you can see it now.
Yeah, we can see.
Now
nice.
Yes. And now we remove it. It one step on one side, the first probe. We do the same on the opposite side. So it is inferior meatus. Now we are inferior concha. We are on the right side. Again, sling. it is necessary to train. I see that it is not much better than a few minutes before. Okay, the second one, and now we insert the second probe in via superior meatus. Počkej, ja to natočím. No.
Yes, the probe intubation set via upper canaliculus, the same sac nasolacrimal duct, and the same here, right eye.
It is not difficult operation. Yes, from my point of view, it is not difficult. But if you are not familiar with this surgery with children, when it is bleeding, it is much harder, and I think that operator must be nervous from this situation. We perform every year approximately 100 children with this operation. Očistíme. And every year we perform approximately 50 dacryocystorynostomies plus 20 conjunctival cystorynostomies.
But we have performed more than 4,000 intubations, monocanalicular, bicanalicular.
Zpátky stando. Dobrý. Sání. Suction. Ještě jednou. There is blood, so the picture is not good. Sání. Endoscopic picture is not good. To vlákno mi vytáhněte někde.
We are sorry, we introduced you a different patient. The surgery was performed before, and we haven't seen it. So that's another patient with both eyes. Yeah. Sorry for that. Number 18. 18.
Well, we do the same procedure on the opposite side. Ja, natáhněte mi to. So we are now on the left side, yes? If you,
we can see.
You can see it, and now we are in the inferior meatus. Yes, there is the probe. Zpátky, Staňo. Zpátky musíš, a nemůžu tak dolů.
Jo, je to vidět.
Sání. And now in some children it is from technically point of view it's not possible to perform the intubation, and so we transform the operation directly into endoscopic dacryocystorynostomy, also in these small children. And it is because it is done under one general anesthesia. It is not many children, but there are some. I don't see the probe. Is it correct? Insert it. Yes.
Can we ask, you had also a stent which was used only to inferior canaliculus, so
yes,
do you use it
have.
still or not?
Yes. I think
yes,
that you can you otevřete mi monocanalicular.
Yes.
Yeah? We show you monocanaliculaar.
The success rate of monocanaliculaar and bicanalicular intubations is the same. We can use bicanalicular intubation. Now you can see it, and monocanalicular via upper or lower canalicus is the same.
Yeah, no,
so which one is your preferred one?
By canalicular, we do it. We do it mostly. Janos.
Chcete potom vyfotit, jo?
Ne, trhneme to. A tam jim to chci ukázat, protože už nebude příležitost.
The problem with bicanalicular intubation that the patient can dislocate the cannula after the surgery if you with a finger, for example, yeah, that's one problem. And you can use monocanalicular intubation if you can't use, for example, upper canaliculus if it's obliterated or not developed.
From my point of view, I am the ophthalmologist. Cannulas are removed after 3 months. Monocannular intubations, monocannulas are removed. It's easy. From my point of view, monocanalicular intubation I would prefer. But now it's problem with material. We have these bicanalicular sets.
You can see that the silicone is not on the tip, is not on metal, and it's problem now to insert it.
So the silicone is dislocated a little bit from the probe.
Dislocated, yeah, yeah, and you have to have there this metal. No, nevidím, I don't see.
But we have the same experience with stents which are available nowadays, that the attachment is not very fixed.
We have, yeah. Yeah,
perfect.
So we have a huge number of silicone stents from LACS company, Czech Republic, and záběr, prosím vás.
Aha. Ano, vidíme na stole.
We spare it for future.
Nevidíme teď, nevidíme.
Detail. Stando, pozor.
Ano, vidíme.
I don't see.
We can see.
Can you switch the? Aha.
We can see.
You can see. Yes. I don't know what you see. So we
make a knot.
Knot it with 3 knots.
3. Okay.
And that's all.
Pavel, if you find probe in the middle meatus, what will you do?
In middle meatus, so I think that it is. I don't believe that it works. Endoscope. It works, so it is not. We would perform endoscopic dacryocystorynostomy in this case, but because there must be something wrong. Yes, it is not normal that. So maybe it can be mistake of ophthalmologist or of the doctor doing the probing, but in middle meatus it shouldn't be.
Here we can see silicone loop between both lacrima puncta, and how I said, silicone tube will be there 3 months, and after it will be removed in local anesthesia in outpatient.
We remove it so that there are 2 options. You can give children in in anesthesia, but we remove it usually under local, so that this loop is pushed, so that we see through the inferior or superior canaliculus, we see the knot, and then we can cut this loop. Now I would like to show you, the question was what monocanalicular set, if we use it or don't use it. It's the same. Can you see it? The same. It's metal probe. The advantage of it is that it is longer. It is better for manipulation. It is one thing, yes. And the second, that there is on the silicone tip, it is special tip. And it is created. We
can see on endoscope. Endoscope visit.
It is self fixing in canaliculus and in punctum. Yes, so it has special shape, and this part is lying on the lower vichko, or on the lower
eyelid.
Vichko. Eyelid. Yes, so it is the tip. The price is similar. Yes, so it's same. I don't know. It is not a question of money. Yes. So now to this child, it was a little more difficult than we had expected, but I think that now the child will be okay.
The surgery was very nice. Thank you.
Most people are better tearing immediately one day after the surgery. But the result is evaluated. The final result is evaluated after removing the tube, and we control, because we have some statistic. We do this control also after 3 months and again after 3 months to have some message from patient, from parents.
Pavel, a question, because it was not that easy. Are you going to use like dexamethasone eye drops or some auxiliary topical treatment to help with avoiding restenosis, or are you just believing in the stenting and that's it?
Yeah. Now there is stent, and the children, they use eye drops where is some corticoid also, antibiotic plus cortisone. But I don't think that it is the most important thing. I think that this stenting is much more important than this dexamethasone. The approach to these children, it differs country to country, and it depends on the situation. Generally, the children shouldn't be touched if they don't have severe problems at the age under 1 year. But in some children, if they have dacryocystitis and they have some severe problem, we perform this surgery earlier.
Pavel, thank you for a very nice surgery.
Thank you.
Any questions from other? Yeah, one.
Yeah. Thank you. Normally, in my opinion, we do some of these operations. We don't do a tube inside. I have some pictures here for someone will look for it. We rinse the canal after dilatation with Fluorescein. And then I go in the nose and I put up the lower turbinate and look for the Hasner's valve. And I take a sickle knife and open it, and all the fluid goes out. It's all what we do. You can see some pictures here. I did it several times. No probe, nothing. And we combined it with an adenectomy, and that's the best thing you can do for this. No probe, because the children don't have any probe in the nose for other things. Only do it, rinse it with a Fluorescein, look under the lower millimeters, take the Hasner's valve. You can see that's very good to see here. You take a sickle knife, do it open, and rinse it again with Fluorescein. That's all what we do.
We do it in adults sometimes. Yeah, if we can, if we find there is some pathology in inferior meatus, but in children we prefer to intubate and put their stent to.
But in my opinion, it's wrong, because you don't have a problem of the canal. The canal is sane. There's nothing in the canal. It's only in the Hasner's valve. You can look at my pictures, different pictures here. You can see You have alone to open the Hasselhoff valve. Anything or you do harm to the eyelids and so on. That you don't do this.
Yeah, but
and
this, in this site in
you open the Hasselhoff valve. Anything.
Yeah?
Yeah.
So
only the Hasselhoff valve, and that works.
Yeah.
Yeah. Okay. I can show the pictures here.
Okay. Thank you very much for comments. What about another operating room, Victor? You finished? Okay. So we can continue now with the lecture. May I ask Dr. Katia Balova, turbinate surgery, an overview, please?
Good morning, ladies and gentlemen. Please let me tell you something about a turbinate surgery. It will be a brief overview. I will comment on different possibilities how to perform inferior turbinate surgery. The indication for inferior turbinate surgery is, of course, mucosal hypertrophy in patients in which conservative measures failed. Conservative measures meaning local corticotherapy and saline solution rinsing of the nose. The goal is not only reduction of the volume of the turbinates, of the hypertrophic inferior turbinates, and thus removing, thus reducing nasal obstruction, which is the main complaint of the patient, of course, but also maintenance of nasal functions, considering the physiology of the nasal cavity and aerodynamics. This is not a desirable result. This may result, removing too much may result in empty nose syndrome with dryness of the nose and crusting and repeated epistaxis. So the goal is to remove not too much and not too little. There are basically two possibilities what you can do and what you can combine. You can address the hypertrophic mucosa, or you can perform surgery on the turbinate bone. Sometimes it is combined. What you can do, turbinate out fracture and then perform something on the mucosa. There are numerous possibilities, and there is no clear consensus on which method is the best. This is probably a little bit a historic procedure. We do not perform it in our department anymore. It's a simple cold steel mucotomy when you just have cutting instruments and you cut the hypertrophic mucosa. It is performed preferably in general anesthesia, and it's not really it's a very invasive procedure, and the healing of the structures intranasally, it usually takes quite a lot of time, and there's a lot of crusting, and if you perform septoplasty at the same time, there can be synechia. What we do, what we perform here, we perform microdebrider turbinoplasty, which is submucosal. That means the surface of the mucosa remains intact. And we perform it in general anesthesia. Well, preferably in general anesthesia. Of course, you can do it in office, but we prefer to do it in general anesthesia. What you can see here is the rotating blade inserted inside the submucosal space, and here you can see that it reduces the submucosal tissue, and there should be no harm to the surface of the mucosa other than the incision through which you insert the rotating knife. This type of turbinoplasty, radiofrequency-induced thermotherapy, is what we perform probably the most frequently. It's again a submucosal reduction with the probe that is inserted through several points, usually 5 or 6, like this, on this picture, and it can also be performed in local anesthesia in office. Here there's a video. As you can see, the first step we do is to lateralize the inferior turbinate, and probably you noticed that there was a slight out fracture of the turbinate too. And as you can see now, we have the probe, and usually we start from the posterior part of the turbinate to avoid the blood obstructing the view. And if there was sound, you could hear that it burns the tissue and it goes beep beep, and then you know that it's coagulated enough. So if you have other coagulation tool, there's no signal that it is enough. So this is a big advantage of this tool. Other type of procedure, what can be performed, laser turbinoplasty. Here at our department, we can perform it with the diode laser or thulium laser. Here you can see that it can be performed in office. We use a Hirsch solution, that means cocaine. And again, it's a submucosal coagulation. Of course, you can perform it in general anesthesia too. As you can see, there are cotton swabs with the Hirsch solution. And as you can see, the patient and both patient and the physician, they have protective glasses. Although the laser is contact, this is to avoid damage to your eyes if there's some reflection from your instrument. So here you can see that the endoscope is facing down. So we are looking, it's a 30 degrees endoscope. And here on the screen you can see the fiber of, this is a thulium laser. And the fiber is inserted into a curved suction. That means you coagulate and at the same time you suck the blood and also the steam. So there's some technical problem, okay. But I will show you the endoscopic video. So here, this is a diode laser, and you insert it inside the submucosal space and perform coagulation of the submucosal tissue. So, and just to mention this, that there is a possibility, and maybe it will be discussed also by other participants, piriform turbinoplasty, which is a resection of the anterior part of the bone of the inferior turbinate, which is indicated in certain cases where the bone is the main problem causing the obstruction. So, thank you for your attention. Questions for discussion? Is there any other method that you prefer in your departments? Anyone?
I would like to take over, because Professor Matuszek has left for the OR. Question, is radio frequency available to your sites? So because we are from, different countries, perhaps you just raise your arm if you have the possibility to use radio frequency back at your department, just to get an impression. Okay, I'd say about 50% roughly. And how about the laser? Probably most have some kind of laser available. Again, just raise your arm to get an impression. Okay, so it's a minority in comparison to radio frequency. Thank you very much. These were wonderful videos, Dr. Kabalova. And I think the turbinate surgery, whenever somebody develops any technical device, it will be first used on the turbinates to have the publication out how I do it. And afterwards, 10 patients, why it is successful. And the next one will be why it is a failure to use this new technical device because it makes trouble. Now, I'm very happy to thank you again and hand over to Tanja Hildebrand from Freiburg, and she will do exactly as I told you how I do it. Thank you, Tanja.
Thank you, Achim. Thank you, Pavel and Peter, for inviting me to be here and to be able to speak to you and to join in my experience with turbinate surgery. Some of what I will show you is a repetition of what you've just heard, but I think there's some important points that are actually okay if I stress them again. These are conflicts of interest, but they won't influence the content. As you've heard before, there's different techniques for turbinate surgery, and you can actually classify them into mucosal sparing techniques and non-mucosal sparing techniques. You've heard about the lateralization of the turbinates, the anterior turbinoplasty, partial maxillectomy or piriform turbinoplasty, radiofrequency and microdebrider turbinoplasty, and the advantage is that they actually spare the especially medial part of the mucosal surface. And then there are the non-mucosal sparing techniques like conventional turbinectomy, laser turbinectomy with CO2 laser, or electrocautery. And I would say that these are actually considered obsolete because because they destroy the mucosal surface. So for turbinate surgery, I think it's really important to preserve the mucosal surface, especially in the medial part of the inferior turbinate, to preserve nasal function. We don't want to see, and it's a similar picture as you've seen before, pictures like these where most of the inferior turbinate, middle turbinates have been cut. And so we don't want to see any radical resection of turbinates. There is no real one-fits-all solution for turbinate surgery for all the patients. So it's important to consider the anatomy and also the pathology of the individual patient. And it is also important to consider the nasal cycle when you examine your patient, because in some cases you will see a hypertrophic turbinate and the next day it will be okay. A fairly easy technique that I use for almost all of my patients, either as a single procedure or in combination with other techniques, is the lateralization of the inferior turbinate. So you take either a Fries dissector or Cottle dissector, and what you do is you fracture the turbinate laterally. In some cases, it's easier if you medialize it first, because then it breaks easier, and then the lateralization can be more effective. Another technique that actually nicely preserves the mucosa of the inferior turbinate and that treats the submucosal layer, you saw this before, is the radiofrequency turbinoplasty technique. The radiofrequency needle is inserted. With this technique, it's very important that you insert the needle deep enough, because otherwise you will have injury to the mucosal surface again. So what I do, I usually push the needle along the turbinate bone to make sure that I'm submucosal enough and that I don't injure the mucosal surface of the inferior turbinate. Usually 3 or 4 points along the inferior turbinate are enough. If the turbinate bone needs to be reduced as it protrudes into the nasal cavity, the anterior turbinoplasty is one possible technique. There's different types of insertions. What I usually do is I make an insertion along the inferior rim of the inferior turbinate and then along the head of the inferior turbinate. And then you dissect the mucosa of the turbinate bone, which you can see here. That's the turbinate bone. That's the mucosal layers that have been dissected of the turbinate bone. And then you can use a Blakesley to break and reduce the turbinate bone, as you can see here. The mucosal layers are then folded back when the resection is completed, and you can use a vicryl suture to adapt the mucosal surfaces. In some patients, the frontal process of the maxilla, which you can see here, protrudes into the nose and narrows the anterior part of the nasal cavity. In these cases, the frontal process of the maxilla can be reduced in the so-called partial maxillectomy technique, or the piriform turbinoplasty, as it's also called. The incision is made about 1 to 3 millimeters above the insertion of the inferior turbinate to the lateral nasal wall, and it's continued along the frontal process of the maxilla for until about 5 millimeters anterior to its visible bulging. The mucosal flaps are then dissected off the bone inferiorly and superiorly, and the bone of the frontal process of the maxilla and of the insertion of the inferior turbinate to the lateral nasal wall is exposed. You can see this here. That's the insertion of the inferior turbinate, of the head of the inferior turbinate to the lateral nasal wall, and this is the anterior, the frontal process of the maxilla. This part of bone is then chiseled off tangentially, and in some cases this will also involve the medial part of the bony canal of the nasolacrimal duct, which is then exposed, which you can see here and here as well. That's not a real problem if you stay tangentially, because it then won't hurt the duct. The duct can even be freed from its bone completely to reduce even more bone if necessary. And the flaps that you've raised before are then repositioned and sutured with a vicryl suture as well. And the nice thing is that you can combine this technique with different other techniques. You can lateralize the inferior turbinate, or from the same incision, so you don't need an additional incision. You can resect part of the turbinate bone, or you can use a through-cutting Blakesley and you can resect part of the submucosal tissue. And if necessary, you can reduce a very small strip of mucosa and then suture that together, and you still have an intact medial mucosal surface of the inferior turbinate. So the points that I think are important for inferior turbinoplasty are that we should actually use mucosal sparing techniques. We should prefer these to be able to preserve nasal function, especially in the medial part. So no radical resection and no disturbance of the medial surface of the inferior turbinate. We should always evaluate and also consider the individual anatomy and also pathology of our patients, and also the nasal cycle. Because in some patients it will be enough to reduce the submucosal tissue, but in other patients it is essential to reduce a bit of the bone as well, because otherwise it will still protrude into the nasal cavity. And we can also always combine different techniques to get the best result for our patients. So thank you. And are there any questions or comments?
if there aren't, I take the opportunity. Now, the question is this very nice technique. How do you select your patients to be in favor of this approach rather than, one conventional turbinectomy, and when do you decide to use like several of those? So what is like your inclusion criteria?
I usually look at the patient when they're not, they didn't have any decongestions in their nose. What we then also perform is we measure the nasal flow with rhinometry. Then the patient gets decongested, and I look into the nose again and see what has changed, like if it's more like a mucosal or submucosal problem, or if the bone still protrudes, or if the the frontal process of the maxilla protrudes. So it's essential to have rhinoscopy, anterior rhinoscopy, endoscopic evaluation of the nose, and decongestion of the nose. And also rhinomanometry can help you to see if it's more a mucosal, submucosal problem, or if it's actually a bony problem.
So, well, if you have a CT, does that add to your decision making? I presume that you're not, specifically performing a CT scan, but, if in times of sinus surgery and you think about improving nasal obstruction, does a CT scan help you in terms of, measuring the thickness of the bone, or?
It can add some information because you can actually see the inferior turbinate bone if that is if that is the problem. But I think even the look into the nose is very important. Any more comments or questions?
Apparently not now, because Dr. Vodicka is in the OR.
I'm very sorry. I had a comment, but at the same time I had to check the OR. I called there just a few minutes ago. They're not ready yet for another surgery. So maybe it's a question for the auditorium. For the patients, because you answered it already, for the patients that you indicate for turbinate surgery, do you do you perform rhinometry or rhinomanometry in your department every time, or just specific cases? Or how do you check, is there any objective method that you check that you helped your patient with the nasal obstruction? Or do you base your results on the questionnaires?
It's how we do it. You get thousand results. It depends how we do it. Rhinomanometry is not objective. There is no objective measurement of. That's the feeling of the patient. And if you see, you must not first go with an endoscope in the nose, only with the speculum and look first. And then I think, second, afterwards you can do discongestion or vasoconstriction in the nose. And you will see the result. If the patient says it works wonderful, then I do it. I did rhinomanometry before Corona crisis, but afterwards it was so expensive for us and the results were so bad so that we stopped it. We have to clean it and to do other things and single-use instruments, and so that's not what we don't want to. And the patients are very convenient with this method. It is really a subjective feeling, and you cannot organize an objective measure of the subjective feeling for me. That's my sense.
I agree. I totally agree. But in our department, we rely both on the questionnaires. In every patient, we have SNOT 22 as the quality of life, Rhinovas, and also nose score in every patient prior to surgery and after the surgery. And in every patient, we perform rhinometry and rhinomanometry prior to surgery and after surgery too, and NPIF. also. So, but I totally agree that the subjective feeling of the patient is the primary result that we want, that the SNOT is lower. Not only the nose score, but the SNOT. This is, for us, this is the most important thing, how to measure if the result of the surgery is good. Okay. So I was told to discuss a lot.
Yeah, I would like to, you know, get in there. I think there's one misconception with regard to, you know, the objective rhinologic functional diagnostic, whatever you use, okay? The problem is, yes, we want to improve the complaints of the patient. So improve SNOT, improve visual analog scale, whatever. And the art, because we are, you know, medical, so we are artists, we are not science, is to differentiate between those who have a profit from, like, enlarging something, diminishing something, the turbinates, whatever, cutting out. And now you refer to the empty nose syndrome. You had nice CT scans of, you know, massacre of turbinates. And if I still remember patients coming, you know, I've had like 3 times of laser turbinectomy or radiofrequency, just do it another time and it will be fine again and stuff like that. And there's a problem of humidity in the nose and the nasal cycle and the tissue, and the tissue doesn't forget everything that you have done to the turbinates. And so the problem is to decide when you stop going further down this road, okay, for the 4th or the 5th time. And that's a completely different story, because we only get like recurrent problems and, you know, selected patients in our university anyway. And then you have a higher likelihood that you have a visual analog scale which is worse, but rhinomanometry or rhinoresistometry or acoustic rhinometry may help you to say, well, actually the nose is wide. And Victor, in the first surgery, put down the suction probe on the contralateral side, saying, you know, there's literally no obstruction, there's slightly a spur or bended septal deviation, whatever, but that's not causing any nasal obstruction. But if this patient had presented himself or herself, sorry, forgot about that, with, you know, I've got a stuffed nose and do something about it, and she has had like mometasone spray and Salandouge, and came back and said, well, that was nice and it slightly improved, but I want to have a permanent solution, then I need to offer something, and I would like to have, in a way, a more objective way to see whether, you know, another turbine surgery, whatever kind of, will be helpful, or whether I should go for the maxillar process diminishing removal type of thing, or something completely different, like the opposite, to make the nose smaller again, okay? And I think that from a scientific point of view, we need to have, you know, more data, and that's why I appreciate, you know, your department, Pavel, doing all this stuff to get in a situation where able. And now the problem is that all those objective functioning tests only add up to about 60 or 70% of the information of my visual analog scale. So there is room of improvement because there's turbulence, there's humidity, there are other stuff, you know, influencing my visual analog scale or my SNOT 22, but that doesn't mean that the 60 or 70% of information is like nothing, okay? Now, the other thing is it's time-consuming, it's expensive, it's not well paid for in our healthcare system, okay? And I'm coming from a university, so I don't pay attention to this type of economic affairs anyway. And I think that's, in a way, the mission for universities to solve this problem, in contrast to people looking for the general population who have to make, you know, quick decisions, cheap, and, you know, provide secure treatment, which is a different mission at all.
But I think, especially in this case, it is very important to have that look into the nose, to examine what is happening. If I look into the nose, what does it look like without decongestion? And it's important to ask the patient if they've had decongestion, because some of them will come to your practice and they've had their usual shot of decongestion because they use it every, like, 2 or 3 times a day and every day. So ask them for that as well, if they've used decongestants, if they use it regularly, because that is also an information for you that they have a subjective problem, and also important for you to know that they actually have used it, because then you can't really judge what you see. So it is important, no decongestion in the nose, then have a look. Then if they haven't had decongestion, put in some decongestion and see what happens, and also ask the patient what they feel now.
Thank you. And I would also like to mention the medical legal aspect, because septoplasty is probably in Western countries probably the most surgery with most legal issues, because without rhinometry and the rhinomanometry, it is very difficult to have some objective data, and for some patients that probably would want to sue you that you didn't perform the surgery well. So it's something that you have that you can use in a possible lawsuit, because otherwise there is nothing that you can use to prove that you performed the surgery well. So this is also one of the aspects.
Okay.
And we will proceed with the lecture about rhinometry.
Yeah.
Achim, sorry, I interrupt you.
Always.
Don't stop, please.
No.
Can we continue with some short OP video?
Okay.
Then we will have short break. Yeah. And then we will continue with, I don't know, Petr Matoušek, can you OP5?
Navigation in this patient.
Yes, Petr, shortly, can you show us navigation, please?
Okay, so I am preparing navigation now. So it is a headband. You put...
Can we have obraz 3? Detail?
Ten kovovej mi dejte. So it's... I put it and fix it into the forehead with this headband. Okay.
A ten druhý obraz zase, aby šel vidět operatér pozice z dálky, z větší dálky.
Fix the head in the right position. We need for surgery. Pod tím, jestli to vezmete. Okay. And as you can see on the head of the patient is, can you see it? This? NIRS? Can you see it?
Yes, we can.
Yeah, okay. So can anesthesiologist tell us what is that?
Sorry. Můžete ukázat druhý obraz zvenku, ať jde vidět, kde stojí ten operatér.
Druhý obraz zvenku.
Dobře, do rohu ho dejte a jinak tak, jak byl ten původní.
Fixem. So this is NIRS, which is not standard during this surgery, and anesthesiologist can tell us what is that.
Okay. So NIRS is near-infrared spectroscopy, and it tells us deoxygenation of the brain. Because for this surgery, you as surgeons require controlled hypertension, and hypertension means lower blood pressure, so lower blood pressure for the perfusion of the brain. But we do not want to cause any more mortality or morbidity. So this is our way to control the perfusion of the brain.
Okay. Rukavice, prosím, mi dejte. No, dejte mi to. So this is a patient's tracker. We put it into the headband and insert it into the navigation. Navigation is a fusion system, ENT, navigation from Medtronic. Nesterilní rukavice, prosím, pěkně mi dejte. And now we are, it's a electromagnetic navigation, so it's perfect for ENT, that it's not shame. With you don't shame with endoscope like in optic navigation. Definitely optic navigation is a little bit more accurate, but for us it's Sondu, prosím. It's enough if we use that. Navigation is strongly recommended for using in this kind of surgery in sphenoid sinus. definitely in revision sinus surgery, in polyposis. Vidíme i obrazovku. So now I navigate the probe, registration probe. Aha. Ale nejde mi registrace, nevidí mě? Asi, nebo co se děje? Aha. Vidí všechno, jo? Tak můžu já navigovat, jo? Next. Okay. And now I will go on the surface of the patient, and it correlates with surface on CT or MRI. And it correlated with our CT scans. It's important not to press a lot the skin, only on the surface you go. Okay, can we see the picture on the screen? Uh-huh. Okay, and now we can see that navigation is pretty well. I think there is I think 2 millimeters difference between tip of the nose and the probe, and I think it's enough for our surgery. So this navigation is done, and now we can prepare the surgical field. Tak můžeme zalepit prosím oči a chystat se na operaci.
Thank you. We will have now short break, and you can continue. Okay. And I think that we can have break 10 minutes, 15 minutes, but try to follow the videos. We published these two in last years, these two books dealing rhinology, endoscopic surgery of skull base and surgery of orbita. These books are in Czech, sorry. Gift from publishing Tobias for you. If you don't have this book, you can take it at the registration desk for free. Yes, so if you have it, it is not necessary to take the second one or the third one or the fifth one. But for this, who would like to have this book, you can take it there. Yeah. Thank you. Halo, halo? Halo, Petr?
Ne, on už tam není už.
Je připravena operace, nevím na kterém sále.
Je připravena operace na sále číslo 7.
Takže můžeme...
Na sále číslo 7.
Operating theater number 7.
Zase tu anemizaci.
Tak profesor vás volá.
Doktor,
we hear you.
Vicky Hránková. Vicky.
Ano, tady jsem.
Můžete prezentovat, můžeme...
Pane docente,
Honzo, slyšíš mě?
Yes,
sál číslo 7.
I hear you perfectly. So...
Honzo, my představíme pacienta krátce. Ano?
A je to case 15?
Yes, case.
Sál číslo 7, aby jsme... Okay, we will continue with 2 cases in operating room number 5 and operating room number 7. The one case is the number 15. It's a man with sphenoid sinusitis, 43 years old, with frontal and periorbital headache since 2023. Okay. With feeling of facial pressure. This is a rhinoendoscopy with mucus from sphenoidal recess draining into nasopharynx. Here. And there is a CT scans, frontal, sagittal, and axial, with opacification of the sphenosinus of the left side. So the procedure will be endoscopic sphenoidotomy. And I will present another case in operating number 5 then. It's case number 5. And it's a patient with papilloma of the inferior turbinate. The male, 14 years old, with several months nasal obstruction, bilateral discharge, and the nasal corticos was without effect. And in 1 year of age was performed cleft palate surgery. And this is a picture from rhinoendoscopy with papilloma of the inferior turbinate on the right side. And there's a CT scans, sagittal, axial, and frontal on the right side. Here. So procedure will be a laser resection of the lesion and turbinoplasty. So we can move in operating theater.
Honzo, so you can start, yeah?
Yeah. We can start. Please give me the smaller section. So we will start with the inspection of the left nasal cavity. So what we see now is the deviation of the nasal septum. This is a cleft palate patient. So the anatomy is a little bit different.
Můžeme pohled i z druhého sálu, prosím.
Okay. Okay, so maybe we will start with middle meatus. Here, what we see here is a little bit like edema of middle turbinate, which could point at central compartment atopic disease, but another thing is history of the patient and other things. So this is not what I can conclude from operational theater. This is the nasopharynx. The greenish fluid is from adrenaline we used to make anti-edematic and anti-bleeding constriction using adrenaline. So now we will have a look in the right side of the nasal cavity. Okay, so this is the papilloma, probably papilloma of inferior turbinate. This is middle turbinate. Again, we see here some small edema, which could be in other things also central compartment atopic disease. There is also edema posteriorly, but I am not able to go further with rigid endoscope. Now we will try to look beneath the inferior turbinate. You can see that the septum is deviated highly to the, fortunately, to the left side. So we can have a look here to the nasopharynx and on the right side. There are also remnants of adenoids, and it's not very easily to see Eustachian tube orifice because we know that this is a patient with cleft palate. Okay, so we will start with FRIER to just see what is, how big is the, let's say, tumor of the inferior turbinate. So this is movable, this part. So I will resect all this part with the plan is using thulium laser. You had a lecture on turbinoplasties. I missed it, unfortunately, but when we make surgery on inferior turbinate, we use radiofrequency mainly, and in some cases we lateralize the inferior turbinate, we lateralize the bone. But in this case, it won't be necessary because there is enough space here. So I will start with thulium laser section. Can we as well? Okay, so in Pardubice we have KTP laser. So hopefully this will work similarly. So we can start.
What kind of laser do you have now?
We have now thulium laser.
Thulium.
But můžeme to začít? Yeah. Now it seems to be ready. So we would like to leave small part. Okay, I make small incision with forceps, nůžky. I just want to prevent cutting the bone, but I think here we cut only soft part. Yeah.
Můžu poprosit, můžete pustit i endoskopický obraz z druhého sálu? Tam se něco děje, ať můžeme sledovat.
Můžeme. So now we will continue with thulium laser and cutting, or the other way how to do it. Můžu ten plán. Can I show you what I learned from Professor Chrobok, which is also very helpful, is when you put it in a, like, not forceps, but squeeze it, just squeeze it and wait a little bit, and then we can easily cut it as well. So the thulium laser. Asi vezmu nůžky. Okay, maybe when I cut it immediately, this would be much faster. Now you can see a section. So I only follow the forceps, so I think it's not bleeding that much, so I don't need thulium laser that much. I will use scissors. Nůžky. And I think the main complaint when patient is not breathing through the nose is in the anterior part, chapáček, anterior part of the nose. So in this case, větší. Okay. So I will use this. So we remove this part. We can send it to histology. And Petr Matoušek told me that pathologists may perform also PCR testing. And even that posterior part is not that important for nasal breathing. I will cut it as well. Zase si vemu ty kleště, ten pen. Jo. So I will squeeze it again here. We can have a look from the superior part. No, it's not visible due to blood. So the main goal was only to enable breathing through the nose. So hopefully we will be successful. There is only a question of recidivation. So, okay, I will use again scissors. Okay. Yes.
I ask colleagues from Germany. All these lasers are not so cheap. Yes, so if you use this method, is it covered by insurance company? Because you can only cut mucosa, you can use all these expensive things. How is it in Germany?
Usually it is not really covered in Germany. You will just have like a procedure code which will be like resection of the turbinate, and it's not that you get additional money for using a laser. It's just a procedure. It doesn't matter if you use cold steel or if you use a laser, so it's not paid for.
Jürgen, your private praxis. What about there? Are you thinking about cost of this procedure, or are you not thinking about it?
Yes, we are thinking about the costs here, and to be honest, I would take a scissor.
Krapáček.
Well, being the advocate of the devil, the amount of money that is attributed to one OPS code is based on the consumption of the mean of a number of reference hospitals in Germany. So as long as some reference hospitals from the INEC group are using laser devices or, single-use devices or whatever, at least a percentage is going into the amount of money that is attributed, at least in theory. In real life, it's probably the scissors, because it's like quick and dirty, and you're for sure there, okay? Now, but that leads us in Germany to, whenever we buy something, we want to have like the possibility to have a reuse of this and not single-use stuff, because every single use is just, deducting from the income that we have. And that is a high difference to like the colleagues in the US, who are able, especially in outpatient, to use, everything, or to charge everything that they have as consumables on top.
Zase ty nůžky. Okay, so now I work on lateral part of inferior turbinate, which I have to be aware of nasolacrimal duct. But I don't touch lateral wall of nasal cavity. And this probably will be the last, hopefully, last incision. Krapáček. And I will put gel foam with Exacil to prevent bleeding.
Just a question from my side. Has a biopsy been taken before the surgery to see if it's just hypertrophic mucosa?
Yeah, there was ještě mi půjč chapáček, nebo spíš nůžky. Yes, I asked Peter, and he told me yes, there were inflammatory processes, so no tumor visible under microscope at pathology. So that's why we just decided to just do part resection of mucosa, chapáček, to enable the patient breathing through the nose. And again, we will send it to histology as well. These parts I removed. To be honest, this is my first. We had one patient with benign tumor of inferior turbinate, but we had to resect it all. In this case, I hope this surgery will be functional. So dáme tam gel aspoň. Bo ještě tady tohle může možná trochu bože nůžky. Fortunately,
do you have any question to Honza Vodička?
Well, it's more a question of understanding. Now, if it's an inflammatory process and not a benign tumor, I can completely agree with that, because the inferior turbinate and the swell body may actually build again. However, in any other case, are you going to take a margin in terms of to assure that the process has been eliminated incomplete, or do you think that, you know, a bit too much? Because obviously, with every margin, every tissue you take, the remnant of the turbinate will become even smaller.
If this is inflammatory process, I will be very conservative. If this would be tumor, I will surely do resection of the probably bone, it depends, and I do excision of lateral parts of the turbinate. So in this case, I consider it as as a really functional process. So there is a risk of recurrence of papilloma, but maybe there is a question whether we should treat it with laser now to prevent recurrence, but this will be only hypothetical, I think. But we have laser, so we can treat it at least a little bit. Ještě ten laser si vemu?
Yeah, exactly. I was thinking along the same lines, and I would make it depend on what the first histology told you. So if the first histology said something about papilloma, then I'll probably, you know, use the laser, and otherwise I would wait for the result of what you have taken.
Okay, so it's. Okay, so we put there gel foam with tranexamic acid. Už ten exaciel. Okay, I put it. Tam mi dej tu ší. Jo. Hoď mi ho tam, prosím tě. Okay, so we like gel foam a ten druhej, and the second one, and we will, and because it's not bleeding, I won't put anything else in the nose. Ty máš ještě máš? Gel aspoň? No, můžeš, jo. So. Yeah. Dej mi kousek jenom. Tam ten menší. Okay, so this will be last piece here.
And another one. Oh. Yes, and I think that's it. I will only control whether gel foam is not going to the nasopharynx. Hopefully it will be possible through the... Yes, only partly suction.
And what is your recommendation for tomorrow? What should doctor do with the patient?
We can start with nasal lavage, and that's it, nothing more.
Nothing more. Don't actively remove this gel foam, suction, and so.
No. Yeah, we only say patient that he can just sneeze or something, and there can be some gel foam. So, but it's usually coming out quite fast in the nose, and then the nose will be empty after several days. So the only thing will be that there will be just healing process on this inferior turbinate, which can take 3, sometimes 4 weeks. So this can be quite a long time until final healing. Okay, so hopefully. No. No. I would stop with this. Or there is a. Should I do turbinoplasty on the left side? But this would be question.
No.
I also don't think so. So I thank you for your attention, and I will just.
Honzo, a short question. Do you use local steroids after surgery for postoperative care?
In this case, I won't use.
Thank you.
Welcome.
Honzo, thank you. A můžeme přepnout na sál 5, prosím.
So, can you hear me?
Yes.
Well, yes?
Yes.
So we are ready to perform sphenoidotomy in this patient. It's a very rare case, I think. The patient has only, I think, one sphenoid without septum sphenoidal.
Can we endoscopic picture?
There is a very small right sphenoid. I don't know. You saw CT scans?
We saw everything, and the patient was introduced better.
Okay. So now we are on the left side. This is inferior turbinate. This is a middle turbinate. We push it a little bit laterally. And then we can see superior turbinate is over there. Here is the septum. Superior border of Koana, which is our main landmark for this kind of surgery. We can see anterior wall of sphenoid sinus, and natural ostium of sphenoid sinus is over there. Usually it's about 1.8 centimeters up to Koana, superior border of Koana, which is here. So here we can see some vessels. It's a branch, septal branch of sphenopalatine artery. I think 1, maybe 2, maybe 3. It can be. Okay, so we can start from natural ostium tool you have, or you can go through the anterior wall. Sometimes it's a thick wall, sometimes it's very thin. So we will see. It's thick, so I use a Carison at first, and I put it into natural ostium. Carison 2 dolů, prosím. And I'll start to resect the anterior wall. I'm curious what we will see in the sphenoid, because ostium is free.
Mlží se to, mlží se to.
Oplachujem to, sestřičko, prosím. You can see mucus. And I think only mucus. Pojďme dál ještě. I saw that it will be mucus still there, but Sani? A little bit more. The safe removal of the anterior wall is medially and caudally, so this way. The bone is a little bit thicker here. Ještě pojďme. And I make it a little bit wider to look into the.
So do you think that it corresponds with CT preoperatively?
It doesn't correspond now. Now it's septal branch of sphenopalatine artery is bleeding. So coagulation, please. It doesn't correspond with CT scans.
What options are you thinking about?
Options for what?
To stop the surgery?
I think we already did what we need, only to have a look into the sphenoid, maybe on the right side. If it from the right side there was a little bit more mucus there, but I think that it's only one sphenoid, so it's not maybe necessary. I vibrate a little bit. I have a look into the sphenoid. So I can use this kind of tools. What is Kerrison Ronger, which is a very nice tool for removal as mucosa as bone.
What instrument do you use in Germany? Same, Kerrison, yeah? In Brno?
It's
yes.
Very expensive tool, but very good tool. Dejte mi ještě. Pardon?
You can also use a higher Kofler punch for this. It's better because we can get the backward punch. There's a special backward punch. You can better work
to
the bottom of the sinus.
Přímý košiček. You can use Stamberger punch, which is this kind of instrument, especially in enlargement of the natural osteum, and it's safe, very safe instrument, because if you go deep into the sphenoid, there is a less risk you injure, for example, carotid artery. So I think we can look into the sphenoid, and I think surgery is done. So we can see at 9 o'clock it's a cella. Above is tuberculum cellae. I can't show you because it's a small opening of the sphenoid, and right in front of us is carotid artery. Dejte mi prosím něco tenkého, dlouhého. Asi možná sondu. Dejte mi sondu. Aha. Jo, ale já nevím, jestli tam došáhnu s tou sondou. So somewhere here is a course of internal carotid artery. Here, like I said, a probe at the end. Here is a cella and tuberculum cellae, planum sphenoidale.
You have navigation. Can you show it on navigation for orientation?
Okay.
But we don't have picture from navigation.
Picture from navigation, please.
V pravém dolním rohu.
You can see?
Yes, yes, we can see. Ale endoskopicky chceme taky vidět, ať víme, kde jsi.
Aha. Okay.
Peter, can you try to show us the floor of the sphenoid sinus by turning around the endoscope possibly?
Yeah. So now I'm looking down. Aha, dejte mi sání. Očistíme. I'm trying to look inside, but it's not so wide. Se ještě trošku rozšířím. Dejte mi Kerison, prosím pěkně. Máte nahoru nebo jenom dolů? Jenom dolů, tak nechte mi tady ty dolů. Já se trošku rozšířím. Ne, jenom ať se tam dostanu. A little bit more laterally, which usually here is a septal branch, so maybe I catch it again. Ještě se nemůžu dostat. Now we are in. There is a blood. Tak ještě dolů možná, to otevřeme trošku. Nebo víte co, dejte mi zahnuté sání. I try to suck to krajní. To krajní. I try to suck the blood from the floor of the sphenoid. So do you think it's enough or
Achim wants to widen laterally.
No.
No?
No. Well, unless we are here to go to the complication side of the street immediately, no. Because there is no pathology left, and I think even the blood is something. I just wanted to make sure there is no mucus, fungus, whatever at the floor, and I think that has been proven beautifully by you, Petya. So excellent, and no more surgery, because after that you only can win problems.
Yeah. You are right.
And do you think that it was mucocele?
I don't know what chronic rhinosinusitis, I think, yeah. But what was the nice opening of the natural ostium? It was not blocked, so it was nice. Bez toho mi to dejte.
Well, the question is, he reported.
We were in indication. We were in advance there. So if we wait. And maybe if we wait for, I don't know, months, there will be no pathology on a CT scan. I can't suck it more. It's big suction. Try it once more. Je to zacpané, ta dírka, nebo?
Well, I actually think this is a very worthwhile thing to have, despite, probably not for the surgeon on a day like this. The one thing is that if you have had some kind of acute rhinosinusitis, the CT scan will show some opacification for at least 6 weeks. So if the patient comes and reports about having still problems, and headache is, the chameleon of our symptoms, we see something and we still have to have a look there like you did.
I think that it was. I don't know. Vicky, can you look at the CT scans? I think it's repeated, and the opacification was there more times, yeah, not only in one CT. Here we are on the right side. I'll show you superior turbinate and maybe small polyps or mucus on the right side, but this is the same, same sphenoid, yeah. And there is openings, and here is a small cyst.
We don't have picture now. We have yes.
You
now
don't have?
Now yes we can see.
Endoskopicky, yeah. This small. Aha, dejte mi chapaček. I take it out. So we are on the right side, just in front of, and here is a, like retention cyst. Dejte mi sáň ještě. Asi ne. I try to open the sphenoid from other side, but it's not. I press a lot. My nemáme navigaci. Dejte mi, napojte mi navigaci, prosím. Napojte mi. I'm a little bit, I think, moved by navigation. Here is a tip of the nose, and can't see me. Yeah, here is. So we look on the right side. Here is the superior border of Koana, which it's a different. Can you see CT scans? Navigation?
No.
Please, navigation.
Yeah. Yes.
And you can see how you can be mistaken by navigation. Yeah, because I am on superior border of Koana now with navigation, and yeah, you can see endoscopic image.
Yes.
Yeah.
You can.
And you can see on navigation that we are not at the at this landmark. Yeah. So I think it's a difference due to movement of patient's tracker, for example. Yeah. So it's not precise, the navigation, and what you see is every time more than what shows you navigation.
So it can help you, but it is not possible to rely only on navigation.
Yeah, definitely. Já se nemůžu dostat, ale do té levé dutiny.
Necessary to use for this sphenoid, for this case, with this shape of sphenoid, is necessary to use navigation?
It's recommended by American Association of ENT to use in every case of sphenoid surgery.
And in Europe? Jürgen?
I can tell you I don't use it because we do much sphenoid surgery with myxotomes or so on, and we do it sometimes with neurosurgeons. And you see, as you see here, at the beginning about 2 millimeters were a difference between what you see and what the navigation system, and 2 millimeters, that's much in the sphenoid sinus. So I rely on my experience in this region here. And you see here, if the main thing is to go first look for the ostium and then go medially, not laterally. And when you have the medial, you open it medially. For example, also with the punch from Stamberger or so on. Then it's not so difficult to operate in the sphenoid sinus.
So I'm trying to open a sphenoid from the right side, and I can't. It's a so tough bone that is very problematic, and I'm afraid of to go through. But I think I finish it. What do you think, Pavel? What's your recommendation? What I can do?
You are too weak, probably. You have to use.
We have opened
more power
from the left side, so it's only one sphenoid is over there, so it's necessary to open it. I don't think.
But if you don't want to do it, you can also do it from the left side to the right side. Is it the spur there, or is it the front of the Koana?
Yeah, definitely I can go through the septum, through the
and then you open up
approach.
on the other side, it's no problem.
But,
that's what the neurosurgeons do every day.
Here is, but here is a whole sphenoid, It's a no septum there on CT, so it's opened from the left side.
I think that in this case that it is not necessary only for us. It should be interesting, but it's not necessary. It's my opinion.
I would have done it also, but he tried to do it. But if I wanted to try it, I would have from the left side. But I don't see, I don't have an intention to open the sinus from the right side.
Now I can go through the septum here, but more anteriorly I would do, because it's a rostrum sphenoidale is here. It's a thick bone. Somewhere here, and I can go through the septum to the right sphenoid in normal cases, Or you can use kerison nahoru, rozdělíte mi teda, prosím. Dejte mi kerisony.
Is there anybody who would like to continue to open it?
Excuse me?
Nobody wants. Nobody. Peter, nobody wants to open it from opposite side.
Okay, so then I am finished. Yeah?
Yes, you can. You can.
Okay. At the end of the surgery,
now I would like to ask Achim to have a lecture, because we have still time before your patient.
One thing important, to put the middle and supraturbinate back to their position. Oni už mě neslyší asi, že?
Yes, we can hear,
we can, back to the position to prevent maxillary sinusitis after.
And recommendation for following days, what to do with patients, with this patient, with this case?
I think nothing. We don't put, I think, packing there, maybe some Gelaspon. So I think that patient can go rinsing the nose, definitely, like in other cases, 15 times a day. And he can go home, I think, tomorrow.
Recommendation when he is going home? For the patient? What to do?
Rinsing the nose 15 times a day.
Yeah. Okay. So, Peter, thank you very much.
Okay, thank you.
And following lecture is from Achim Boyle about 24-hour rhinometry. It is special new instrument. We have it also in Ostrava and in Münster also, and in Freiburg. Do you have it from Münster and Ostrava? And we would like to use it for our indication for. I am not sure that if it has really an impact, but we would like to know how is it.
Thank you very much, Pavel, for introducing me, inviting me, and also giving the possibility to speak a bit about our research. So we just had the discussion going before this surgery that you have patients who have a problem, so subjective complaints, and then you have a look at the nose, like in this case, and it looks better than you previously anticipated. And then you do, whatever you have, like acoustic rhinometry, rhinomanometry, rhinoresistometry, you may a peak nasal inflammatory flow or whatever, so PNIF, and in the end, you find some kind of septal deviation. And the problem is that if we go through the rows of the participants today, we'll have about 66% of you having a septal deviation. And now if I do an operation on everybody of you, in case you are willing to agree to this procedure, like your subjective complaints will not improve in any patient, especially not in the long term, so like after 5 years. We have the problem that septoplasty and also septorhinoplasty and so on has a 5-year happiness rate of about like 50 to 70%, which is not great. Okay, and nobody will die from a septal deviation. So why subject the patient to this? So the question is, because now our hypothetical patient has problems and we didn't find anything, is there something to get from these 60% where we know this septal deviation is actually causing a nasal obstruction to a higher percentage? So to be more frank and more optimistic. Now, if you have a look at your septal deviation, the conventional approach is to look at the type of the deviation. And there's Ladina's classification. That's a highly cited classification system, which actually takes the bending way of your septum. And as a rule of thumb, is if the septum goes across more than 5 millimeters to one side, this will come across with increased resistance and cause a nasal obstruction. So if you have this kind of like 5 millimeters, especially if it's in the first 2 centimeters of the nose, you can be quite confident to do surgery. And that's like the basic assessment that we are doing. We are using anterior rhinoscopy or nasal endoscopy, and then we're having a look, and that's it. However, a slightly bended nasal septum, in like every patient has a kind of facial asymmetry, and you may have that. And Suka Kandel in like 18 something told us it would be physiological, and we don't want to correct a physiological septal deviation and miss out on some other problem, okay? Whether it might be turbinate or projection, protection, whatever. And in this situation, we can go for a conservative treatment, and then it still doesn't work, and we are still looking at the patient. And that's where a company developed something called long-term rhinoflowmetry, which gives you a resistance over a 24-hour time frame. So you are able to use this little MP3 looking device, which can be carried around, and the patient should subject himself to physical activity, and then you get the nasal flow on the right side in red and on the left side in blue, so similar to a pure tone audiogram. And you also have the heart activity, the breathing frequency as additional markers for physical activities. And the patient has an ECG as well to get an impression what he or she is doing, and we give them a diary to ask them, well, when did you have dinner, and when did you do your sports, jogging, surfing, I don't know what is that perfect for this situation. And up to now, we only had the graphical analysis. So just looking at it and saying, look, it's changing from high activity on the left side to high activity on the right side and vice versa. And by this, there were by Ron Eccles, very senior sir, from the UK, definition of different patterns in the nasal cycles. And these patterns were established by all different means, like endoscopic repetitive examination or rhinometry or acoustic rhinometry, whatever. And you have a classical type, which is this reciprocal congestion, decongestion, which I just showed you in this first slide, or you have changes in parallel, so both sides decongest to work more, to allow the passage of more air, or you have done some stupid irregular, something is going on, or you don't have anything. Like if you have resected both turbinates, there's no swell body available anymore. And now the most current review from rhinology shows that there are several confounding factors, including sleep and posture, which you have also to take into account. And that's the reason why we weren't happy with a pure graphical representation and to say, well, this patient has a nasal cycle or an irregular cycle. And that's why we took this little machine and we exported the raw data, and we used 3 different blinded investigators to get a definition of what is actually healthy and what not, and to compare completely healthy patients, which we had for like some different kind of surgery, not nasal related one, to patient with any kind of endonasal inflammation, including allergy or chronic rhinosinusitis. And then we might, the data look slightly different by getting high resolution data in a short term to see have a look at the noise and signal ratio, and to use as a first pilot group 30 healthy subjects and 40 patients and some rare diseases to define the definitions for, you know, normal changes to see how fast the nasal cycle is actually reacting to changes in posture, to physical activity and stuff like that. And we came up that we were able to define what is actually healthy, which normally is the classical type, but this has the presumption that you have two roughly symmetrical endonasal sides. So if you have a septal deviation going straight to the left, there is no chance that the left side can work as much as the right side. And then if you see a parallel or in concert type, you see this as an adaptation mechanism. So if the nose is brought to its limit, it will then decongest on both sides to allow nasal breathing. And then step further, if it's even worse, then you go for the irregular type, especially if you have had some kind of surgery, some kind of tumor or radiation therapy or whatever. And the last thing, with these 24 hours, you are able to get a very long duration of this examination. And by this, you should see some swelling. And before due to, you know, working hours and stuff like that, most of the studies were using techniques for repetitive measurements for 30 minutes or up to 11 hours. And then after 11 hours, if nothing happened, they said, well, there is nothing to be observed. However, with 24 hours, and especially in sleep, because during the sleep time, it's much easier for you to see the changes and to get an increased resting phase. You see that actually normally everybody should have a pattern, the examination being resection of the whole swell body, okay, which is a sin from my perspective. And so we are continuing with that, and we now have some data which are still not 100% objective because of, you know, problems with calibration and the measurements. But nevertheless, this is a very nice tool, especially if we have a patient where we don't know why he suffers from anything. And there's the problem of an early detection of empty nose or paradoxal nasal obstruction on the one hand. And the second thing that I wanted to send you home with is the idea, if you have somebody reporting about problems with the nose and the nose being perfect, it's physiological that the nose has an increased resistance to the mouth, okay? Every small kid knows it with adenoids. So, and then think about the fact that possibly they would have a benefit from a lung function, because if COPD or some other stuff, you know, COVID pandemic, whatever, actually catches them, they may have a subclinical lung function problem, which only shows up when they use the nose. And the second thing being expectations. We have lots of young, slim ladies reporting about problems with the nose during their physical activity, like jogging. And the nose is not for jogging, okay? The nose is for walking straight on one level. So expectation management is something you have to deal also. And the 24 long-term rhinoflowmetry or rhinometry, we'll see which term sticks to this procedure, may be helpful in the future, comparable to a 24 blood pressure management or something else like 24 hours ECG. And with that, I'm looking forward to receive all the questions from Pavel and his department. Thank you very much.
Can I ask, thank you for this presentation. There are many, many questions.
Yeah.
How did you start? With healthy people?
Yeah.
And did you know what is normal finding before? Did you start?
No.
No. So you start and you...
Yeah, we used patients who had acoustic rhinometry, manometry, rhinoresistometry, nasal endoscopy, and questionnaires, and they were as healthy as can be. And then we put them on this mechanism, and then we took a mistake. We took a mathematician to look at the noise-signal ratio, which is something I won't do in my life again, because they only see noise. Okay, which is helpful, but you have to learn. And then you need to average the result. okay, to make a mean. And this is very difficult because by doing averaging, you don't want to lose the signal, you only want to diminish the noise. And that is actually an art, and we are quite happy after, you know, several pilot studies and tryout and doctoral thesis and stuff like that to get to this thing where we now have one export function presenting, I think, 13 different parameters, and we'll now play around with those parameters to see which are actually the ones that differentiate between healthy and disease, and then also which type of disease. Yeah, but there's still more to be done. Lots. So anybody looking for a PhD, Niels?
Hey, what does it look like in practice? Is it like a home sleep test?
Yeah, it's like an oxygen brill, which you put around your nose, and then you have those 3 ECGs, and you have a slide MP3 thing there, and it doesn't bother the patient at all. So they're really happy. It's quite easy to recruit even healthy patients for this thing. And now for money, because it's always a question, there is in our EBM catalog a number for continuous monitoring of sleep and you know, cardiac type of things. So what you use for polygraphy.
5 candles.
Beg your pardon?
5 candles. You must have 5 candles.
Yeah, and that's why in a different pilot we use polygraphy together with that to fuse it together to get there that we can go for the EBM thing.
So until now it's more like an experimental setup for you,
and you have that's research.
One machine, right? Or do you have more than one screen?
We have, I think, 4 machines with one always making trouble. Yeah, well, it's, you know, it's a prototype type of thing in development. However, yeah, we're getting there.
Do you think that we have prototype?
Yes.
Oh.
Well, in terms of being distributed, it's more or less, have a look at how many hours you're measuring and how high the amount of missing data is. Okay, and because the package for the batteries and stuff like that, if you lay yourself on that during sleep, okay, you'll get like missing data. And that's, you know, nobody can be accused for that. You need to give it a try. But the polygraphy is something that you put on top here, okay, and if they change the packaging, it will be even better. However, I think it's worthwhile to do research on that one now. There have been papers from Ulm during, I think, 22, 23, but they don't have the export function that we developed, so we'll see whether their results are still valid.
You mentioned that you had 3 investigators.
Yeah.
They were medical doctors, or do you have special some engineers or somebody?
No, medical student and 2 ENT guys, like one standing here. Yeah, and then we were judging each of our examinations, and we had different ways to technically export the data and present the data to see which presentation actually suits us best. Based on a visual analog scale assessment of 6 different aspects like noise, signal ratio, nasal cycle type, change of nasal cycle. The nasal cycle apparently takes only about 5 minutes to change from this position to that, like from working side on the right side to working side on the left side, only 5 minutes. So it's pretty steep and pretty quick. And to get those data reliably.
Thank you. Any other questions?
So that was from the Ebony Tower.
Thank you very much. Achim, now I would like to direct to Ope. Is somebody to follow him? Někdo doprovodíte? And Vicky, can you introduce the following patient from Achim Boyle? Yeah? It is the patient.
Yes. It's a case number 11 in operating theater number 7. It's a man with invert papilloma, with bilateral nasal obstruction since 28, and but the tumor of the left nasal cavity was found in 2024, and the histological verification inverted papilloma. In CT scan and MRI, we can find that I think that there is no distraction medial wall orbit, but there is a CT scans. We can see the nasal cavity with extension tumor in the left nasal cavity, with not destruction in intracranial space or orbital space. And this is an endoscopy finding. This is a tumor on the left side of nasal cavity. Nasal peak, inspiration flow 0. Again, the CT scans, MRI. And the diagnosis is inverted papilloma. And we'll perform total resection of the tumor. Thank you.
Vicky, I think that it is enough. So the patient, they are not yet at OP, so we can have some lectures now. Mm-hmm. And then we will continue with these videos. So I would like to, moje docere, Vicky.
Okay. I think that you will continue with some presentation, but I will present another case number 13, in operating theater number 5. Okay. Later.
So we have now time at OP, and so I would like to have a lecture about endonasal dacryocystorainostomy. We will have one operation in approximately 30-40 minutes. So endonasal dacryocystorainostomy is preferred now, and external approach is not used very often. The operation is indicated in obstruction of nasolacrimal duct, and it doesn't matter if it is congenital or acquired nasal declama-like obstruction. The principle of this method is opening of the lacrimal sac above this obstruction. There are basic steps how is it performed. It is left side, middle turbinate. So the mucosa is removed and bone. It is so-called linea maxillaris. It is created by frontal process of maxilla and lacrimal, very thin bone. Then with ukazovátko druhé. Moje nefunguje nějak. Zelené. Then with chisel or with Kerrison or with burr is possible to remove the bone medially to a lacrimal sac. Then the lacrimal sac is incised vertically, sometimes also horizontally, and it's opened widely in the nose. There are basic anatomical structures. So it is left side, septum, middle turbinate, and it is so-called linea maxillaris. Usually it is very well observed. You can observe it, and it is the main structure for you for orientation. And there it is position of lacrimal sac and nasolacrimal duct. So the most important is linea maxillaris. Sometimes it is said that lacrimal bone is removed, but it is not true. The lacrimal bone is very thin and is in posterior part of the lacrimal fossa, but it is important to remove much wider process, frontal process of maxillae, and to open the lacrimal sac. Posteriorly, you can see uncinate process, bulla ethmoidalis. So we are anteriorly, more anteriorly than uncinate process, usually. During operation, sometimes the orientation due to bleeding is not quite easy, and the main mistake during the operation is that the opening and removing of mucosa is performed too anteriorly. If you start with this surgery, you are afraid to be more posteriorly, and very easy trick is using bayonet forceps. One branch is inserted in medial canthus, and the second one, opposite side, corresponds with this position of lacrimal sac, with this linea maxillaris. The advantage is that you can use this method more times during surgery, and you need only a few seconds, no special equipment. It is very, very easy method, especially if there is bleeding and you don't know where you are. It is EDCR on cadaver, again, left side. So the first step is pushing the medial concha medially, then removing of mucosa. Me personally, I don't perform it anymore. And then with chisel or with Kerrison punch is removed bone medially to lacrimal sac. And then is probe inserted into the lacrimal system, and the lacrimal sac is incised. It is video from operation. Left side again, middle turbinate and linea maxillaris. So we start the surgery and push with raspa concha medially. Then I don't use, usually don't use laser and other things, and directly with this Kerrison I remove bone, including mucosa. Sometimes it is bleeding, but usually not very much. This Kerrison, I think that if you want to start with this surgery, I think it is the best instrument for it. It is better than chisel, and I think that it is really the best approach. Then you can see and you can touch from outside the inner canthus, and you can see movement of the lacrimal sac. This sac is very wide, so we can expect there some mucus or something. Then we insert the probe into the lacrimal system, and you can observe moving. Usually, when you touch the probe, you can observe moving of the medial wall of the lacrimal sac. Then we do incision. You can see the probe. It was this sac was very wide, and now usually with scissors, normal scissors, we do some horizontal incision and operation is done. Then we insert there only Gelaspon with nothing usually, and operation is done. Peter Matoušek, he likes to use all these new instruments, this radio frequency, and for removing mucosa. It's nice, really nice, but I don't have time, and I am nervous when the operation is too long, so I don't use it. But it is possible. You can use it. It's nice. It is this linea maxillaris, yes? So it is frontal process of maxilla. It is not lacrimal bone, it is more posteriorly. And the technique is same. Yes, also he is using usually this Kerrison. You can use also a chisel. The advantage is that it is with one palm you can remove the bone medially, the whole bone medially to lacrimal sac. But usually we don't use this technique anymore. But it is also a very good technique. We can use also gel, but we don't use it anymore. It is the disadvantage is that sometimes you can damage the lateral portion of medial concha, so there is higher risk of synechia. So we don't use it. So after operation, what we recommend, because there sometimes you can, when the patients are blowing, they can create emphysema, so we don't recommend them blowing nose directly 1 or 2 days after surgery, and then they can wash and they can blowing their nose. We recommend 15-20 times a day. Patient, they usually are without any problems very shortly after the operation, so they stop this bleeding, this washing of the nose, but it is prevention of some synechies and other complications. It is not due to the operation, but you can prevent to developing the synechies. EDCR is operation that is really has very high success, 85 to 99%. So it is really very high. So most of patients, if the indication is nasolacrimal duct obstruction, it is really very high. Final result should be evaluated 1 year after the surgery, so not 2 months or 1 month after surgery, but longer time. And you can observe their different shape of rhinostomy. We use this fluorescein. You can observe it optically, but you can observe also color, so you can really say that the patient is okay. Complications are not common, so you can sometimes observe periocular hematoma, emphysema, so blowing nose directly after the operation. Be very careful, and in some times can also synechy develop. The question is, and Misha Masarova-Mladoňová will have a lecture about it. The question is if intubation is recommended, is necessary or not. The benefit is unclear. Some surgeons, they use it in all cases, some don't use it. We think that indication is in children, because children, the care of the nose is not so good, usually not so good like in adults. So when we started with the surgery, children had to go after 1 week again in general anesthesia. We removed all this fibrin and other things. Now we don't do it. The indication for intubation is also canalicular obstruction. So all problems, if there is something with canaliculi, it is really indicated, and the stent there should be removed after 8-9 months, not earlier. So much longer than normal intubation. Also in narrow cavity and in reoperation, we use this silicone tubing, believing that result will be better. When you want to start, how to start? The most important thing is good indication. So for many ophthalmologists, they recommend patient for the surgery. They don't distinguish between obstruction of canaliculi, obstruction of nasolacrimal duct. Everything is for EDCR. But when you want to start, you should be sure that it is only problem of nasolacrimal duct, that canaliculi are okay. Now we, for example, at our department, we are able to touch and to do, but ourselves probing and all these procedures, if you don't have experience, you should have some ophthalmologist dealing with these problems, being able to distinguish if canaliculi are really okay. And what is advantage of this endoscopic dacriocystorhinostomy? It is patient, student of some university with acute dacriocystitis. And we know that approximately 70% of all patients having acute dacriocystitis sooner or later are candidates for dacriocystorhinostomy. Yes, so usually or very often they have repeated problems, and advantage is you can do, for example, external dacriocystorhinostomy, but it is problem because there is inflammation, there is bleeding, everything is bleeding. But if you do endonasal dacriocystorhinostomy, it is quite normal anatomical structures. So after 1 day after surgery, lady can go home and is without any problems. So advantage is that you can do this surgery also in acute stadium of the disease. Where can expect failure? I think that I mentioned it, that if there is canalicular disease, so some problems with canaliculi, the results can be worse and the patient shouldn't be satisfied. In reoperation, of course, all surgeries, reoperations are usually much more difficult and results are worse. And if nasal cavity is narrow, because the orientation, the care after the operation is more difficult and it is really not so successful like it normal anatomical situation. What can you in chronic dacriocystitis find is dacriolithiasis. You can observe it approximately in 10 or to 15% of these chronic problems. But it is not. These dacrioliths are not composed from calcium. It is not like sialolith. These dacrioliths are composed only from proteins. They have shape of this lacrimal sac, nasolacrimal duct, but they are composed only from proteins. Good message is that if you find this dacriolith, that results are really very good. We have statistics there. It is not that nearly 100% you are successful. So if you find dacriolith, you can inform patient that you are best candidate for good result. So what take home? What message take home? The advantage is that this operation is performed in area you know it. You are familiar with this area because you do other types of endonasal surgery. That it is first choice of, especially in reoperation, and that success of this operation is really very high. So if you have good candidates, I think that there is no problem to start with this operation. Thank you so much. If you have any question, Petra?
I have 3 questions, if I can. 3. First one is about preoperative imaging before DCR. If you do that or not, or I think in Germany, colleagues, if you do or not. There was a topic of discussion in a Rhinologic Congress, European. Second is nasolacrimal duct stenosis and indication for DCR. And third thing is if you check inferior meatus before performing DCR in adult patient.
Yeah, thank you. 3 questions. The first was preoperative imaging. When this surgery started in the 90s of last century, it was believed that this surgery is indicated only for very wide, big lacrimal sacs. It was believed that if the sac is small, that it is not indicated, an external approach is used. Now is used this surgery for all types of lacrimal sac. At that time, we performed dacryocystorinography in all patients before surgery to know where is obstruction, how big, how wide is the sac. But lately we found that it has no impact on our decision, so we don't do it. So no dacryocystorynostomy, we don't do it anymore, and I think that preoperative examination like fluorescein test, probing, and syringing can give you enough information about the anatomy of the lacrimal system. We don't use CT, even though it is believed that in all endonasal surgeries should be CT scan done. If I compare it with middle ear surgery, yes, we use I think that in most cases we used CT, but in an endonasal dacryocystorynostomy we don't use it, and I am not sure again that it can influence our approach. We don't use it. We don't use it only if there is trauma or some other problems in history of the patient. Yes, in this case, yes, but not normally. We don't use it. The last question was the second question was. Does lacrimal duct stenosis? Yes. No. What can offer the patient? Do nothing. Maybe you can use some steroids. They were used also some stents for nasolacrimal duct, but we don't use it and we don't have experience. And I think that it is not. It is much more complicated for patients that DCR, because this operation is very easy. So if the patient is complaining, has problem, there is stenosis, we indicate EDCR. Yes, enough? And the last question, inferior meatus. This patient usually are recommended by our cooperating ophthalmologist, Dr. Červenka. We see this patient directly before operation, so they are indicated for EDCR, so we don't examine this inferior meatus. We discuss it with Jürgen. I don't think that if your opinion was dealing only with in children or also in adults, so it is possible to examine inferior meatus and Hasner valve.
Yeah, as we do it in children, the identification of the Hasner valve and with the fluorescein, rinsing, and then we with a sickle knife we open the Hasner valve. We don't do a probe inside. Back to the preoperative examinations. We don't do also only in rare cases a CT scan. That depends on the anamnesis and the clinical findings. If there is an endoscopic view, you see polyps or so on, then, or the patient said, yeah, I have maybe I have a bad smell also on the left side, and we operate the left side, so then we will do a CT scan, otherwise not. As you said, there's no better result if you do a CT scan or not, and we have to look also for the CT scan is not like going and shopping, that is also, we have radiation and so on, and we have to think about if we should do it.
It's similar like discussion, I think, in Prague and the European ENT Congress, and there was discussion if you plan septoplasty if CT is necessary. Yeah. And there were some people, Professor Energy, for example, from Turkey, and yes, in oral septoplasty, before septoplasty is necessary CT.
Yeah, I would say if the results are bad, but you said you have 90%, 95%. If you have 60%, you should think about a CT scan. But you have the good results with no complications. Why should we do this? Yeah.
Especially if you consider that you have a high rate of incidental findings in a CT scan that don't have any or that don't cause any problems to the patient. Like in a lot of CT scans of the paranasal sinuses, you see opacification or swelling of the mucosa, and it won't change anything. It's an incidental finding, and the patient doesn't have any complaints, and so there's no real additional information that you gain from a CT scan.
Thank you. So
one comment. So it depends on the patient's history. So when there is some postnasal drip, I would think about CT scan.
Is there an anamnesis? You can do it, but it doesn't depend on the operation of the lacrimal duct. You will do it any other way also. Yeah.
So thank you, and we can continue with lecture of Misha Masarova. So Misha, Honza Vodička now. Okay.
So good, not afternoon, but morning. So let me tell you our attitude toward endonasal sinus surgery in Pardubice, because we are always focused not only on nasal breathing and other symptoms, but on sense of smell. So on this one. So we know that patients with some troubles with sense of smell have different etiology. It's nothing new, but sometimes it's quite difficult to differentiate whether this is sinonasal or post-viral. This post-viral can imitate also sinonasal, so we put these patients on steroids, and if the smell improves, then we can predict that surgery can be helpful. Another indication for smell troubles can be qualitative parosmia, but it's really rare and seldom indication for surgery. So first of all, we try steroids and also other kind of treatment before we start surgical. I was in Nancy a long time ago, and there is a head of a department, Roger Jankowski. His name is Jankowski, but he moved from Poland to France. And he had this quite interesting idea how to treat patients with chronic rhinosinusitis with nasal polyposis, and they did more extensive surgery than we have done in the Czech Republic, and so they always focus mainly on ethmoid sinuses, including middle concha or middle turbinate resection. As you probably know, there is another new, very aggressive surgery called the reboot surgery introduced by Bachert, but I am just more prone to do it according to Roger Jankowski. So when the conservative treatment is not successful, then we have several possibilities, and this is quite new publication. There is Philip Gevert, who is also very just involved in chronic rhinosinusitis and biological treatment. And you can see here that our surgery is called nasalization, and this nasalization can include middle turbinate resection. And considering sense of smell, we think that this is a very important structure. When the disease is aggressive, then we recommend to resect it, or this is our experience. So there is reboot surgery. It means that you remove all mucosa, also from maxillary sinus. But if you imagine a lot of patients with chronic rhinosinusitis with nasal polyposis, they have mainly affected the ethmoids and olfactory cleft part. In maxillary sinus, it is usually secondary part. Okay, so for example, some cases. So this is, we usually follow patients a long time. So this one was followed 9 years, a woman 52 years old, and she came with a diagnosis of post-viral olfactory smell loss. But on MRI scans, you can see olfactory bulbs are here present. And here in ethmoids, there is some inflammatory process. So we switched the diagnosis to chronic rhinosinusitis with nasal polyposis. At day 0, she had a very low score of sniffing sticks and odorized Marker's test. So we put her on steroids, and she improved her sense of smell. Odorized Marker's test can have 0 to 12 points, so 8 is almost the normosmia. Then she came later on with loss of smell, so we put her again on steroids. And we have done just regular surgery, endoscopic sinus surgery, but this patient again came because of smell loss. So she never had troubles with nose breathing. So her nose was empty. So we recommended her to do again RIFS or RES, because it's not very functional surgery when you resect middle turbinate. But considering smell, you can see that afterwards she came, or we invited her to come because she wouldn't come. And you can see that the sense of smell was preserved for almost 5 years. So since that time, I think that the middle turbinate resection can be helpful. According to Jankowski, just ideas. So we have another case. This is man, 63 years old, fluctuating smell disorder and good response to steroids, but he had no nasal polyposis, so chronic rhinosinusitis without nasal polyposis. And you can see that the sense of smell was not that bad. It is hyposmia, but this patient had a really subjective complaint of decreased sense of smell. And we did resection of the middle turbinate on the left side and waiting what would happen. And you can see here that later on the right side, this is threshold testing. So you can see this is 0.5, it means there is nothing. And on the left side, at least anything. So he asked us to do surgery, the same surgery on the right side. So we have done it, and afterwards the patient was quite
happy with his sense of smell. These are his pictures, so you can see here middle turbinate resection on the left side, and it's still visible here on the right side, but finally we resected on both sides, so it's quite not easy, but not that difficult surgery if there are no polyps. So these are 2 cases of middle turbinate resection, and this is very specific case with post-traumatic olfactory loss, parosmia and phantosmia, and this patient, if I just very shorten his long history, he had head trauma, then phantosmia was the most important symptom. He had loss of weight of 20 kilograms, so he asked us to do something. We usually use lidocaine to prove whether it would help for phantosmia, and if it helps, there are some publications from United States, from Leopold, who just did surgery on the olfactory cleft. So we again tried our best to do it locally, but finally, after 2 years with very severe symptoms, we just did scarification. And because it was helpful only partially, we repeated this surgery. Now the patient is without sense of smell, but happy that he can eat and just do his social life with his family during lunch and so on. So it's really, we have only 2 cases in our just register, so it's very, very seldom. It's always very risky, and we are afraid of it. But it is how it looks like. We are also afraid of mucocele, but so that's why we also do magnetic resonance. You can see here, especially post-traumatic changes in frontal-basal region of the brain, and here almost no olfactory bulbs. So in discussion, considering just endoscopic sinus surgery and effect on smell, on a review, which is here in the European position paper, it should work. But if you look more precisely, it works, especially in just like snot. But it looks a little bit less in APSIT test, and when you use sniffing sticks test, you can see here P0.03, so it was proved that it helps, but it's not that clear. At least we did also the study on it, and effect of endoscopic sinus surgery was correlated with higher polyps, asthma, and Lund-Mackay scale. Then we could be helpful, but it's still questionable. And also this study proved similar results, but we can expect a beneficial effect based on reviews, publications. We can improve, using resection of middle turbinate, we can improve the sense of smell. As I said, it was just promoted by Jankowski and other authors. There is no effect according to this study. What is important, there is no risk of empty nose syndrome when you resect middle turbinate. It has to be just, you have to have reason why to do it. But if the conservative treatment is not successful, then we think it's available. Okay, and then only to just points to phantosmia. There are some paper about also resection of olfactory bulb. If you resect olfactory cleft, then you have to expect rhinoliquoria, which we consider to be very dangerous. So we do not do this surgery. We just do scarification of this tissue. These are our studies. You can see here that in most of the patients, the sense of smell was unchanged. In some of patients was worsened. In some of them was improved. But if we focus on patients, we have only 11 of them who we could just follow them for some period. So you can see here that this is prior. The result is of all odorant markers test is prior surgery and then after. So it was improved, but we do not have that much patients. So to conclude it, we still think that middle turbinate resection plays its role in olfaction because you can easily just put intranasal steroids to the ethmoids and still just keep these patients with quite good mucosal status. But on the other hand, we surely have patients who responded only for just 1 year or half a year, and then the sense of smell was worsened. So we always do it when there is no effect on conservative treatment, and we always do it when there is effect on steroids. So when patient says, yes, there is effect, and we can measure it using odorized markers test, then we decide to offer this kind of surgery. And this is this parosmia, phantosmia, it will be always disputable indication in patients. So it's something I don't want to just focus much on this topic. Nowadays we have biological treatment, so a lot of these patients will undergo biologics, and which is helpful, but again, it's not working in everyone. So thank you for your attention.
Thank you for your nice lecture. So middle turbinate resection. Any questions from the auditorium?
Do you resect the whole middle turbinate or just the anterior part of the middle turbinate?
Whole? So
like the whole turbinate or just the anterior part? Yeah.
No. Just we start from the anterior. Mm-hmm. We always leave like 4 millimeters of it to have some anatomical point, and go posteriorly till the just attachment close to the choana. And so there we stop. There is a risk of bleeding from branches of sphenopalatine artery, but still we just really resect it almost in whole part.
And do you do it as a single procedure or always in combination with your sinus surgery?
This one patient, or I don't know, 2 or 3 patients were as a single procedure, so it's very rare. Most of them are when we do endonasal surgery, like nasalization, and so we include this.
No questions? No. Have you observed a small CSF leakage from the turbinate, or not? No, during the surgery, like around the fila. Sometimes we can see it.
Yeah, fortunately not, but we are always aware of it and just keep out of this risk. So yes, we as I said, we leave always at least small part of middle turbinate there, and almost do not touch the cribriform plate, which is always risky from this. So it was also according to Leopold. They expect leakage, so they have to cover it. So I don't think this is for phantosmia. It's proper surgery.
Okay, thank you very much.
What about the superior turbinate? Do you make any resection of superior turbinate? Do you have any indication for that?
Thank you for the question, but we don't touch it.
Because sometimes we make the resection of superior turbinate if we have larger approach to the posterior ethmoid or to the sphenoid sinus. But we didn't discuss the resection of superior turbinate to the smell.
Only just comment that there are surely also on, not only on superior, but also on middle turbinate, there are some fila olfactoria, but still, even if we resect it in indicated cases, we think we can help patients to improve their inflammatory process in ethmoids. So that's probably how it works. But nowadays, biologics works perfectly.
Okay, thank you, Honzo, very much. And we can go to the other patient, DCR. So, Vicky, can you introduce us the patient, please?
Yes, let me introduce the case number 13. It's the woman with the obstruction of the lacrimal pathway. 81 years old, with epiphora of the left eye since 2023 and frequent conjunctivitis on the left side. Fluorescein disappearance test was 0 and 2 on the left side, and repeated probing massages was performed, but it was not effective. And during the probing, upper lacrimal caniculus saw a soft stop in common canalicculus, and through the lower lacrimal caniculus, soft stop in common caniculus too. There is a rhinoendoscopy physiological finding on the both sides, and the procedure is endoscopic dicrorhinostomy on the left side and canacular intubation on the same side. So we can switch the screen in operating theater number 5.
5, I think.
Okay.
Pavel, can you hear us?
Yes, I can. So can we start?
Yes, you can start.
Yes, Lucia, she is holding the endoscope with her
endoskopický obraz, prosím.
Tak tady, tak to nějak, tak to ale... Vidíte, can you see me? Endoskopický obraz, můžeme?
Vidíme, we saw it, we see it.
It is not easy because Lucia has patient, the screen has behind her head, so she has turned head, and it is not easy for her to concentrate, to focus the picture. I only want to show you probing of the inferior canalicculus, and there this movement. Can you see this movement? If
we can see.
Move this movement in the inner canthus, it is information for you that it is obstruction in common canalicculus. If you touch the bone and there is no movement, we say that it is so-called hard stop, but there it is so-called soft stop. So there is some obstruction in common canalicculus. It is indication for us that intubation will be necessary in this patient. Now we remove the vasoconstriction. I saw the patient yesterday, so we can go again to anatomy. So it is septum, left side, it is middle turbinate. There we can see very well this linea maxillaris. You can see that in this patient it is a little anteriorly from the anterior aspect of middle turbinate. There it is inferior turbinate, and we are now in choana and nasopharynx. We can look in inferior meatus. Now we usually don't do it, but we can do it. Máte si tlustší? We have optic 30 degrees. 30 degrees, yes, so once more, 30 degrees for and I try to, from outside, I try to touch lacrimal sac, this area. There is no movement of Hassner valve. Mm-hmm. So now we can start with the surgery of it is done not under inferior meatus, but there above, under inferior concha, raspa. Yes, so we move again the middle concha medially. Okay. Now bayonet forceps. I can show you how to, during operation, how can you use this forceps. So we can go outside. You can see outer inner canthus outside, and corresponding place is there a little posteriorly than this linea maxillaris. And now I start directly with kozu, můžu poprosit, directly with Kerisson. We use the bigger, the better. So it is Kerisson number 2 and number 3. So we start with number 3. Number 3. Yes. So I don't know. Can you see also the picture from outside? So I have to be not in this direction with instrument, but more laterally to contralateral side. Yes. I don't know what I did, but I think that, yeah, okay. Well, the other, I can see the movement of lacrimal sac now, yes?
We can see it.
I usually don't clean the nose after each insertion of instrument, because it is bleeding, but not very much. I think that it is not necessary to do anymore. I inserted the suction, and again I am going more superiorly. Once more. Well, again Kerisson. Again Kerisson.
Pavel, for your information, on the second operating room, they are ready, or they started surgery. So if you want to show us, and then we can switch.
Yes. Okay. You can observe it without any explaining. You can.
It was a pass from the lacrimal sac.
Probably from lacrimal sac. Probably yes, and also there you can see.
We can see.
Pus. Yes, so regurgitation of pus. Ještě. You can switch
okay,
on.
So we can switch to the other operating room before we present the patient, please. Nechte nám prosím obrázek tady z toho sálu, i endoskopický, i z druhého sálu potom, prosím pěkně.
Tlak má jaký? Tlak?
We have just present the presentation, the case report, so I repeat it. It's case number 11. the man with inverted papilloma, how I said with bilateral nasal obstruction since 28, and in this year we diagnosed tumor of the left nasal cavity. Histologically verified inverted papilloma, and this is a rhinoendoscopy finding. In the left nasal cavity, there is a tumor. And this is the CT scans and MRI. When we can see an MRI, we can see the tumor of nasal cavity on the left side with the extension into orbit or intracranial, but not with destruction of dura mater or orbital.
Extension to the right side.
Yes.
It's in the posterior parts of nasal cavity. Okay, thank you.
We had a total resection of the tumor. So we can switch on the operating theater.
Boyle, we have you on the screen.
Yeah, perfect.
So you can start.
Yeah, I hope you have me also on the microphone. So this is the left side, and he has quite a decent septal deviation.
Obraz, prosím.
And when I have a look, the interesting part is that I can see the axilla, so the attachment of the middle turbinate, with medial polyps and lateral polyps. So that's the first thing I have a look at. Can they hear me? Yeah? Okay, and on the other side, I had a look because of the nasal obstruction, and first you think there is nothing. However, if you go below the septal deviation, you then see that there are polyps as well. And that's why I actually am looking here to, there's the middle turbinate. The middle turbinate looks quite good as well, and then the mass is just too massive, if you want to say so. So I can't really see an attachment. Okay. So first I'll diminish. Can you spill the water across the endoscope? You know, with this system.
Once again.
Yeah.
Můžete nám dát obraz i z druhého sálu, prosím, endoskopický? Malinký.
Again, please.
Můžete nám dát druhý obraz z endoskopického sálu, prosím, malinký?
Okay, that's better. Blakesley straight, and I'll just try to get, you know, the polyps out of this side, because I want to see whether it's really bilateral or, as I reckon you said, it's coming from the other side, okay? And personally, I think it's, with regard to recurrence, the most important part to see where the inverted papilloma is attached. So, and there it looks like it comes from the other side. We'll see. Which would be quite massive. So it's still histology from the right side. Okay, no. Then it's fine. Blakesley? And can you spill again? We need to press the button. Yeah. Okay, Blakesley.
Up, left. You can see a DCR now probing, and you can see probe. So it's Professor Kominek here, and here is an endoscopic image from Achim Boyle.
Blakesley.
Nebyl mě slyšet? Another try. Here was Professor Kominek, DCR and probing, as you saw. And here is Professor Bohle with inverted papilloma resection.
May I ask you, did you find any hyperostosis in the CT scan?
For the endoscope,
I mean,
you know.
origin of the site?
Yes, we think that it's a middle turbinate, which was, I think, you saw CT scans? Yeah,
okay.
Yeah. So I think there was on the middle turbinate hyperostosis, so from the middle turbinate somewhere to the ethmoids or medially.
Is there any perforation in the nasal septum? Because we saw the nasal polyps or inverted papilloma in the right side.
I think it goes through the choana to the right side. I think.
Yeah, that's my impression currently as well. That's why I'm slowly and steadily working towards the posterior part. Blakesley again, please. For not missing, it's slightly dark, unfortunately. Yeah. And just a bit of water on the endoscope again, sorry. Spilling the water, yeah. Or you just put it over to me, because it seems to be...
So maybe we can open a just discussion on shaver because it's inverted papilloma. I don't use shaver even in nasal polyposis, so I would also use just forceps.
Yeah,
but I can ask other just people here.
Perfect, thank you.
I did previously use the shaver because it's nice and quick, and especially in cases like this when it's bleeding.
Okay.
But the problem is that you actually want to have histology of the whole tumor, because we have to think about malignant transformation of inverted papilloma, and in most cases of malignant transformation, not the whole tumor is transformed, but only a small part of the tumor, and you don't want to miss that. And you can miss it if it goes down the shaver.
Yes, we use the shaver, but we should send all macroscopic tumor from the maxillary sinus, and because there can be squamous carcinoma associated with inverted papilloma. Yeah.
In this inverted papilloma, I don't think that pathologist will examine whole papilloma, only parts, definitely. So I think that the use of shaver is beneficial. In this case, I will use it.
Yeah, sorry.
Yeah, I think it's a big discussion about that. I mean, pathologists, they can still miss it, of course, but I think it's still more reliable to have more material than just a small biopsy, maybe before you use the shaver, just of the most anterior part of the tumor. And I actually had a few cases now with carcinoma in situ, yeah, you really want to make sure that there's nothing like this, because, I mean, you will still follow up the patients for long term, but it's different if there was a carcinoma or even if there's malignant, like real malignancy there. And I think what we should also maybe stress again is what we just quickly talked about this hyperostosis. Because for the inverted papilloma, it's really essential that you have a radical resection at the origin of the tumor. It's nice to know in advance, before you start the case, where that origin could be. And the hyperostosis is one hint towards that. So always, if you have a CT scan, look for the hyperostosis, because that's a good hint that the origin of the inverted papilloma is actually there. You can also look at these seripiform patterns, convoluted seripiform patterns in the MRI, which usually lead towards the origin as well. But I think the hyperostosis, especially if you're not very experienced at looking at MRI scans, it's much easier to see.
Called pedicle-orientated surgery of inverted papilloma.
May I say something to
the good thing is that you can be radical at the origin of the inverted papilloma, but still can preserve important structures like the inferior turbinate or the nasolacrimal duct if they're not actually involved in the tumor, because it's a primarily benign tumor, so you want to resect what you need to resect and want to be radical at the pedicle, but not do a radical resection of everything that's in your way.
Changing sides to the left side. Okay, so it's like second definitive histology, not a frozen section currently. Yeah. Blakesley?
In this scenario, the shaver usually can help you find the origin of the papilloma, because it's everything is clearer.
May I say something?
I understand what you mean, and that's why I loved the shaver in cases like that previously as well, because you can just nicely reduce everything that is basically not adhesive to a structure, because then it won't be the pedicle. But yeah, as I had a few cases of malignant transformation that we probably would have missed, I don't use it anymore. I mean, what you can do is you can put a like a tube in between, like where the suction is, to get material.
And it collects material.
Yes, yeah.
We don't have,
that's something that you could think about. But yeah, as I said, I've stopped using the shaver.
May I say something to the shaver? I'm operating since 35 years now in ENT. And I'm not convinced from the shaver. Why should I use the shaver in this situation? See, when I come first to Czech Republic, they all use the shavers. I tried it. I don't see any advantage. It costs much money, a shaver. It's a single-use instrument. It's not sustainable. And I can also take it out with the Blakesley here. It's the time is not more, and I think I have the same results as you have. Why should I use a shaver? And it's dangerous. I know from Rainer Weber, it's sometimes you can, especially as younger colleagues with a shaver, you can cause defects in the skull base and so on. So leave hands from the shaver. That's my opinion. Yeah. And the discussing for the shaver is an academical discussion. It's not a discussion of the practical everyday surgery. This can be solved alone with the Blakesley and your experience and a good senior after you, behind you, but not with the shaver. That's nothing for the shaver.
But what Rainer also says is, and I think the shaver has its place, because it's the most precise instrument that you can have, because it cuts exactly where you want it to cut. It cuts everything. So it cuts ocular muscles, it will cut brain and everything, so it is dangerous, definitely, but it's also extremely precise, and it doesn't tear mucosa. So I think for cases like polyp cases and other cases, I really like to use it. I don't use it for every case, because it's expensive, it's single use, as you said, but it's the most precise instruments that we have as well.
That's what I don't agree with. I don't think the most precise instrument is my eye, is my instrument, my control, and not a shaver that you cannot control at the end of the shaver. That's not a precise instrument. I think we should not discuss this, and I think if you use a shaver, you have to show, is it better than the normal operation we do with an endoscope and the Blakesley? That's the benchmarking. And I think it will not be better to operate with shaver. It costs more, it costs more time. It is not sustainable. What we have to look for here, it's a single-use instrument, and I think we have not so much money in ENT. I think I like to spend my money for other things than for a shaver.
If I can, I disagree a little bit. There is a company, Surgipa, I think, sterilizing knives or shavers, so it's possible not only only for one use.
We're not allowed to do it in Germany.
Okay.
We did it also with the instruments for the navigation. It's not allowed.
Okay, so in our country we can, and I think it reduces operating time definitely. And for me, the operating field is clearer, and if it helps me to find out where the pedicle of the tumor is, so I will use it.
I don't use shaver very often, so I am not very prone to use it, but I admire people who can use it because it's the operation view is more visible than with just forceps. It's without blood. You have to just follow your blood's just accumulation, so you have to look at these things, be aware of the orbit and skull base, but I think it's helpful, even if I do not use it. And considering money, I think when we started biological treatment in ENT, then the money is something just we don't care now, because we see how much can be patient, how much it can cost. So now shaver is just very cheap instrument.
What does it cost? What does it cost? You say it's cheap. What does it cost? Single use. And how long is it to prepare in the OR for the shaver? What does it cost? And the cost afterwards, if you do.
We have also a sterilization process, so yeah.
100 euro?
200?
200 euro.
Yeah, okay, that's a word. But you do it in more patients than the biologicals. Biologicals are only a selected indication, but not really in daily indication for this. And you have the nurse have to prepare all the shavers, and you have to look for the residents and so on.
Again,
for me, it's not a
shorten time in operating room. What's it makes money too.
And I totally agree that it's not an instrument that you should use for every single patient. Like, I know in Australia they use it for every single operation, which is a nice thing. I would love to do that, but it's just too expensive to do it. And I wouldn't recommend it for junior doctors as well without someone looking after them, because as I said, it is dangerous. It cuts everything, and it doesn't care if it's muscle or brain or whatever. But for the experienced surgeon, it can reduce operating time. It improves your field of vision, which can then reduce complications, might reduce complications. And also, you can't be, like when you use the Blakesley, especially if you use a non-cutting Blakesley, you always tear the mucosa. You're not as precise as if you cut. So, yes, cutting instruments are an option. And I use it mostly because if I have like a real bad polyp case, I really like to use the shaver. Still.
Advantage of shaver is that it is you are one-hand surgeon in sinonasal surgery usually, and this is 2-in-1, so that's perfect. If you start perform some surgery with a neurosurgeon, for example, 3-hand surgery or 4-hand surgery, you realize how this surgery can be nice and clear, and you can see everything, and you can prepare, make a preparation as you want. So that's advantage 2-in-1. How are you, Achim?
Well, I'm following your discussion, and while doing that, I'm trying to find out, I've been here to the axilla and the middle turbinate, okay? Yeah, and apparently really, so you can see it, what Tanya said from the CT scan, that the ossification is on the left side. I was just, surprised in the beginning about seeing something on the right side, and that's why I started over there to know, is there a second problem type of thing, okay? Also time-wise, Blakesley. Now, because there seems to come everything from the middle turbinate area on the left side, I'm just slowly finding my way to the posterior part. Yeah. Thank you.
And you don't use a shaver?
Actually, I do use the shaver, knowing the disadvantages that Tanya has had. Now, you have to take into account that, so starting on the right side with some surprise and
wanting to know where it is actually coming from. And the coming from is really important for me because I think that adds up to the recurrence rate. I like to make sure where it comes from before I destroy the path where I'm looking at. Blakesley? And you see that this is the inferior turbinate and this is the septum, and there's no injury here whatsoever currently, so no reason to suspect any origin of the inferior turbinate. And that matters to me. And actually, I hope to be much quicker in the nasopharynx to, have also the blood going away, because I realize it's not the best situation for you to follow my lead. I'm sorry. And that's another beauty is the possibility to use water for irrigation, because it also helps with the possibility to see. I leave this deliberately to see that I've got my polyps here. Okay. And try, but the section actually is not helping currently. Blakesley, to get posteriorly to make my way in the nasopharynx as low as possible. Yeah. And I had 2 occasions already where I got quite a bit of tissue out, but it's still not to have like perfect side. And obviously I'm just trying as a strategy to get to the nasopharynx, to have my reservoir there, Blakesley, to then be able to see better.
Can I have a question?
Sure.
If we know that it's probably the attachment is on the middle turbinate, we plan to resect it anyway. Yeah. So when do you plan to do it? When you have just cleaned the nasal cavity, or because?
Yeah, when I have a better surgical field, Blakesley. Okay. So I want to really see where I am to make then the distance to be like minimal invasive, however as aggressive as necessary, to make sure that I remove the papilloma completely. And because I'm unhappy with the situation here, okay, you see that's the middle turbinate. There I've got polyps medially and laterally.
Yeah, we can see it.
And now medially, the upper area looks fine, so I can try to pull that down and get rid of that. However, it's not, that's not an oversight I'd like to have. Blakesley? And that's the reason why I try to get to the posterior part in this area.
What would be the plan if the attachment of papilloma would be like in frontal part of the maxillary sinus? Do you resect it always, or do you just remove it from the bone? What is your attitude?
I resect the papilloma, and afterwards I use a drill to get rid of the attachments, even the last cell. And that's why we already prepared the drill here as well, depending on whether I need this or not. Blakesley?
And if it is on lamina papyracea, would you resect it or drill the cover with the drill?
Yeah, personally I like to resect the lamina because I'm with Jürgen that with the Freya or Kottel I'm more precise, okay, while not injuring the periorbit.
Yeah. Some surgeons advocate that it allows spread to papilloma into the orbit. So you disagree with that?
Yeah. I think it spreads into the orbit if you don't remove it completely.
Yeah, perfect. Yeah.
And so I'm more on the aggressive side of the street.
Thank you.
Now my question would be, we have positive experience with doing an MRI scan about 6 months to 1 year after this kind of surgery. because there are lots of people who have some kind of ossification, and if you have a remnant somewhere in the ethmoid or in the maxillary sinus, okay, you may miss it, especially regarding the fact that most of our ENT guys don't have an endoscope being paid for. So do you have any idea on imaging after radical surgery of inverted papilloma?
I have probably one comment, because there was a very nice work from a military hospital from Prague, and the recurrence of papilloma could be also after more than 5 years, so they recommend to follow the patients at least 10 years. So
same way here, 10 years we follow up the patients. We don't perform MRI scans. If we consider that it can be a recurrence, that we perform CT at first. And what we do, we took samples of blood from CSS antigen, which can, higher levels can show us that it can be recurrence we can't see by endoscope. So SCC antigen, which is more exprimed in this kind of neoplasma in inverted papilloma.
Yeah, I completely agree with the fact that you need to have a follow-up like in a tumor patient, by the way.
Yeah, I think it also depends on where the origin of the inverted papilloma is. Because if it's somewhere where I can actually see it well endoscopically, and usually I would have a big access to remove it completely. So in most patients I can actually do a good follow-up, especially in the maxillary sinus, by using a flexible endoscope as well. And if I can see it clearly, then I won't perform any imaging. But if it's unclear and if I can't see it properly, I would do an MRI scan. But just on demand, basically, if I need it.
What do you think about HPV in origin of inverted papilloma and vaccination, especially in these recurrent cases or multifocal origin of inverted papilloma?
The literature is actually quite inconclusive with HPV. There's a lot of studies, but the problem is that they're not of good quality, most of them. They examine, or they use different methods to examine for HPV, and they show different results. So actually we don't know yet if it plays a role, so I can't really have any recommendation for vaccination at this stage.
Is there any place who would recommend after inverted papilloma vaccination? Or has someone experience with it? Because we do not recommend it. So no, probably not. You do?
No. But I've heard about it, I think, in Milano and in Sofia, too, from American guys, that they told that they tried in patients with recurrence and multifocal origin of inverted papilloma. So they try the vaccination, but not results yet.
I have a question to the MRI and recidive. Are there strong criteria to say that's recidive or not? I think an MRI must be done. Is there a strong criteria that say here this is swollen, here this is recidive of a tumor or not? Exist it? Is there strong criteria in the MRI? Can a radiologist say, yeah, that is recidive, you must operate on this point? Okay. I've never heard it. Never heard it. Our radiologists cannot do this.
Inverted papilloma has a typical shape on MRI, so you can, or a radiologist can say more precisely, okay, it's mucosa, or it's liquid there, or looks like papilloma. Definitely, it's not histology.
Looks like papilloma.
Looks like papilloma. Yeah, definitely.
No definite criteria. Okay.
But on the other hand, you have the inverted papilloma is not that fast, so we can have at least several MRIs. So then compare it to previous ones. So this can be also helpful.
Okay. Do you have a scissor, a long scissor or something? Yeah.
But we can agree that normally the first operation should be done this way, that you can control every sinus and you don't have to use the MRI. That's what we should do, and not to use the MRI. Yeah. Okay.
Joachim, you are resecting middle turbinate?
I hope you have seen this rather large tumor that I just got out. And now I'm trying to get around. So the idea is this is the inferior turbinate, this is the nasopharynx. Here I've got a tiny bit of their bone, okay? Medially to that bone here is the sphenoid opening there.
You can see.
Okay. And I've got all around this structure, I've got inverted papilloma. Then this is the middle turbinate, going like that. Here is the uncinate process, and here's the axilla, which I just cut in terms of to have a remnant later on. And here's the inverted papilloma still going into the ethmoid sinus. Okay. So the middle turbinate has to go for sure, and it may help me actually, Freya. And I also, the Freya, yeah. So in terms of, we have seen the sickle knife working with the uncinate process. This is a different way to come from the interior part, because I'm not sure what's happening with the maxillary sinus. A patient had a fracture a few years ago, and that's why the facial bony landmark of the maxillary sinus has a break as well. And there's just a suction, tiny bit of a opacification within the maxillary sinus. Okay. There you see the natural ostium of the maxillary sinus, Freya. So now I'm sure that I'm where I'm supposed to be. Okay. Cutting Blakesley straight, please. Yeah, I'm with Jana, Annette, Barbara, and Petre, who are supporting me perfectly, because I'm still lacking with my Czech, unfortunately. I have to work on that. Tanya is way beyond me. Okay, so here I've got my opening, yeah? And the maxillary sinus doesn't look too bad, okay? So that's positive for the patient. Cutting Blakesley straight. Yeah, but cutting. Yeah.
Blakesley, oni mají Blakesley rovný a Blakesley 13.
Okay. Cutting Blakesley straight. You see that here's so this is an area of attachment.
Here we can see it.
Here, okay. So I'll mark this one for my personal area of, getting a step further because of making sure that nothing comes back. Okay. Okay. Blakesley. The normal one, yes.
Doesn't quite work out. Yeah. Blakesley? Ah. Yeah. By the way, from the parts that I got out, there were actually whitish parts in there. So it may well be that definitive histology later on tells us something about a squamous cell carcinoma. The likelihood based on the publication of Lawson is about 15%, just to give you a rough figure. And it obviously depends, 45-degree cutting. Blakesley, please. Yeah.
Pathologist just reported the histology at this moment. It looks like
inverted papilloma
without malignant structure.
Perfect. Thank you very much. Okay.
Was message from pathologist?
It's so the specimen from the right side was inverted papilloma without squamous cell carcinoma. Okay, we started that just at the beginning when we didn't know where it was like attaching or so. Okay, bipolar, please. The other? Okay. The other. Thank you. So 45-degree Blakesley, please. I know you see that the area of attack or attachment is getting smaller slightly, okay? I'm sorry to take my time, but yep.
It's very nice surgery.
You are too kind. First beer tonight will be on me. Yeah, thank you. (45-degree). Sometimes if you see the ostia to the sphenoid at large, you have to think that maybe the polyp came through, okay? Which is another thing. Yeah, thank you. Okay, here you see something is going on, you know. I reckon that's sphenoid sinus opening. Okay, so it seems to go there. That's maxillary sinus.
So based on the surgery, you still presume that the attachment is in middle concha, or this?
Yeah, middle concha and this area exactly.
Okay, so these are like posterior part of ethmoids?
No, I think it's the anterior part. 45-degree Blakesley. You know, here's that's the posterior end of the middle turbinate, and that's the ground lamella going over. And I'll now.
Also on ground lamella it was attached.
Yeah. And that's probably why the ground lamella looks slightly thicker on the CT scan.
I think it goes to the superior turbinate, the hyperostosis. Yeah.
Yeah, we'll see. I haven't really got the impression where the superior turbinate is in here. Maybe it's just, you know, one part of this whole something. So here is the ethmoid. That's the way to the frontal, okay, which looks nice. And here you see the posterior wall of the maxillary sinus. And now we are taking the Kerrison punch, please.
So maybe for us, would you be so nice and show us anatomical landmarks, not only for us, but also for people who are sitting here? Maybe again, because it's very important when there is no middle.
45-degree black in between, please. Okay, this is papilloma for sure. Okay, skull base, presumably.
Again, please, can I ask you to show us landmarks you use when there is so much out?
Yeah. Sorry, I didn't get that. Yes, sure. So we do have the maxillary ostium with the posterior maxillary wall, okay? Wait a second.
I can see.
Here's the posterior maxillary wall. We have the corona with the eustachian tube here. Okay, this here is either tumor or the posterior end of the middle turbinate. We'll come to that. This is tumor for sure. We have here the ostium of the sphenoid sinus, and we have here the incision that I made on the middle turbinate. Okay, this is the lamina papyracea. Okay,
can see.
Where I started to get rid of some mucosa. We'll continue that later on. And now I'm currently trying to go along like the lower part of the medial wall of the pterygoid fossa, which is here, coming to the area of the sphenopalatine artery, from 45 Blakeslee, to define the attachment here, okay? Because one thing is that it went over here with the ground lamella. The second is that in here is bone, okay? There you can see it, quite thick bone, which I don't like as well, in terms of I need to resect it, okay?
Okay, thank you.
So I'm for sure in the posterior ethmoid, and you see that I always start to work from the bottom going to the top.
Here you can see the hyperostosis, middle turbinate. You can see hyperostosis here, the posterior part of middle turbinate, and it goes anteriorly.
Yeah, perfect.
Posteriorly, somewhere here. Okay.
I'm now going into the sphenoid opening, enlarging it even more to the lower part to see whether or not I'm able to get across this hyperostosis here. Yeah. But my suction seems to be blocked. We'll see. Okay, Carson again. I think the suction is by part blocked. Perhaps you need a syringe to do something about it.
It looks like the hyperostosis goes to the lateral wall of sphenoid posteriorly.
Yeah. That's the way it feels as well. Just a syringe to give it a flush also. Sorry, we just need to get the suction going again. Anne,
like you mean to flush the section, Ilona vyplach toho sání.
Okay. Yeah, that's better. Thank you very much. Okay. Thank you. Sorry, it's gone again. I'm just using the flash to irrigate the whole surgical field until the section is working again. Yeah. Okay. Freya. So here is the maxillary sinus, and here is the posterior fontanelle. Thank you. Okay. Bipolar.
They meet best jo.
I'm now going for this sphenopalatine artery, which normally has several branches. Professor Matuszek just beautifully showed us, the normal anatomy. My anatomy isn't that normal, unfortunately. Freya.
May I ask you, what's your plan? Are you going to resect Aminopapiacea or no?
Beg your pardon, I couldn't understand that. Am I resect what?
Aminopapiacea.
Yeah, I think so. In this area where the attachment was. But first I want to deal with this area here because this is all tumor. And to do so, I'd like to control the sphenopalatine artery. And also for getting into the sphenoid sinus and then taking the drill to drill down this bony structure. Okay. Here you can see a branch coming out. 45-degree Blakesley. Yeah. Bipolar. Straight Blakesley. yeah, whatever.
Zvedni nám tam trošku hodnotu na bipolaritu. Nevidím. Já ho nevidím, nevím. No, aspoň dej na 2.
Okay. "45-degree Blakesley." They've made a break or what?
Sleduje, víš? To je zajímavá operace, krásná. Co tam vykonat na skořepách? Toto je pořádná endoška.
So our question was how looks preoperative CT scan, how it looks like, considering lamina papyracea, because now we are going to discuss whether or not resect it. Yeah, but now this, yeah.
The only point for me to think about resecting it was the fact that in this area here, I had the impression that there was.
Sorry, we have now CT scan. So, but on CT scan there is a really visible part which is just probable, just destroying the papyracea lamina.
Okay. Yeah.
Yeah, you can if you can see that there's a bit of bone thickening as well. It goes towards the lamina papyracea, so most likely there. It's like a bit of hyperostosis, and I think that's where Achim showed where the attachment was as well. So I would definitely, as he saw the attachment and there is the hyperostosis, at least I would drill this area. And as lamina papyracea is very thin, it could be that it's lost completely, which is not a big problem if it's just a circumscribed area. But I definitely would drill it, because if you leave it, there's a risk that you will have recurrence there.
Bipolar.
No, ani ne. Jedině, kdyby bylo něco extra, zatím jako tak už jsem začala trošku rozumět.
So, yeah. Yeah. So we will make decision during the surgery.
Okay. 45-degree. Bipolar. There's still more to.
Is the strength of the bipolar enough for you?
It's okay, yeah, fine. Yeah. Yeah. 45 degrees. And 45 cutting. Yeah. 45 small. Yeah, we'll try it. Okay.
Achim?
Yeah.
Pavel, I was not here for the whole time, so can you explain me what structure can I see there? I am not orientated now.
Okay, so we start again with the maxillary sinus, which is this one. Yeah. And actually we didn't have a really nice view inside. Okay, but that looks straight. Then we have here lamina papyracea. Here is the frontal sinus. Wait a second. The frontal sinus. Here is the axilla with the remnant of the middle turbinate, which I use as a possible orientation landmark. Here you see a hyperostosis, okay, which is coming from like the skull base. Really nice. Okay, and then we have here the sphenoid sinus, where the medial part is fine, whereas the lateral part is apparently part of this whole project with this bony remnant. And below, I took away the, well, not quite. I took away the posterior part, bipolar, of the posterior branch of the anterior ethmoidal artery. And yeah, to make this area nude. And now the problem will be, and now we are taking the navigation. You see that here's, more tumor, okay?
You can see.
And the problem is that this, the navigation.
Můžeme navigační snímky tam dát také do rohu?
Yeah, Jana will do it in a second. Okay, and I would reckon this should be there's the hyperostosis to be seen. I'll get on that one as well. There you see the thick bony structure. We are 1.9 millimeter off, but that's, I think, okay. I'm here on the backward side, that's fair enough, within the sphenoid, and I've got this structure. Now if I go below here, I'm in the real sphenoid sinus. So I have to get rid of this structure. Drill. And that's when it shows that the Australian department is well prepared. So we have a 15-degree angled diamond burr. And it's more about me. Sorry, yeah, thank you. Okay.
Achim, if you want, you can use Surgiflo for bleeding during the procedure.
I'm not used to this comfort back from Germany. 45 degrees. No, I mean, that's the reason why 45 Blakesley. That's why I cut the sphenopalatine to get a better cervical feel.
So you don't use Surgiflo Flossil during tumor surgery?
When we resect the skull base.
Mm-hmm. Yeah, do you use Surgiflo?
No, we don't have it in our department, so we don't use it. I quite like to use, if it's oozing from everywhere, I like to use adrenaline for clotting. But you have to be careful in this area, as you're fairly close to the optic nerve. So I wouldn't use it freely in the sphenoid sinus or close to the sphenoid sinus. Yeah.
Adrenaline, what solution? 1 to 1,000 or 1 to 10,000?
We usually have 1 to 1,000.
Okay. Surgiflo, you don't use it in other indications? For example, uncontrolled bleeding in children, or you don't use it in no indication?
For the kerosene punch?
Why not? And what is the situation in Czech Republic? We have it.
We have it. It's expensive. It's 5,000 crowns, so it means how many euro? 200 euro for one Surgiflo.
45
Sometimes
degree.
it helps you. It can help in big bleeding. Again, you have in this kind of malignancy, for example, you have clear field and you can be more precise in your preparation during surgery.
Drill?
Achim, maybe you can comment on why you started using the drill now to reduce this hyperostosis instead of just breaking it off?
Yeah. I don't like to have a bleed from the cavernous sinus or the internal carotid artery. And
thank you.
I mean, for you guys it might be interesting, however, yeah, you know, patient first. And I try, you see that slowly but steadily I get there to get more remnants. So this was the one hyperostosis we had here, okay? And now again the navigation, please. It's, yeah, sorry, it's on there. Okay, for me that's the area of the skull base where I'm now, okay? So that's exactly the angle. And this one is proper sphenoid sinus supposed to be with the posterior wall. Okay, I'm touching the bone despite the fact that the navigation tells me there's perhaps a millimeter available. 45-degree angle. So now I know that medical also on the lateral sphenoid wall. 45 Lexley. Yeah. So, and that's something which is not so nice and where, you know, which is something where I would like to do more in terms of postoperative care. Drilling on the lateral wall of the, you know, there's something, some kind of asking for trouble.
We need just a little more.
Do you have any experience in post-operative steroid washes in cases like this? Because I spoke to Sarah Patel from Stanford in Sofia, and what she does is for these cases where you can't drill as much as you would like, to use steroid rinses with the hypothetical thesis that there's chronic inflammation leads to transformation to inverted papilloma, and with the steroid washes, you you get down the inflammation, and then probably maybe less recurrence.
Do you speak with me, Tanya?
Yes.
I think there are several aspects in this theory which still need to be proven. For once, there are cases where you have inverted papilloma but no chronic rhinosinusitis. Like this guy, actually, the frontal looks nice and everything, okay? And even on the other side, where it's growing around the corner in a way. So I would challenge that idea. Yeah.
But I actually had quite a few cases where it didn't look like inverted papilloma intraoperatively, just like bad chronic rhinosinusitis with nasal polyps. And then histology came back as small parts of inverted papilloma.
Sure, but I think that's a question of statistics. If you have 11% of the population having chronic rhinosinusitis and about 2% having chronic rhinosinusitis with polyps, and you have about 4% in histology with chronic rhinosinusitis with nasal polyps to also have inverted papilloma, I don't know whether, you need more power to exclude the parallel occurrence. Having said that, in earlier days we said that the allergy doesn't contribute to the development of chronic rhinosinusitis, whereas now, at least in Asian people, there seems to be proof that it's actually the case. So the humble answer would be, I don't know.
Yeah, I think we actually don't know, and there's no literature regarding this, but I found it was quite an interesting hypothesis. And I mean, it doesn't really hurt a lot, and doesn't have a lot of risks for the patient. And
yeah, 45 degree.
Achim, we want to fulfill our schedule. We leave now operating theater, and now we have planned lunch. But before lunch, we have to make photo all together. So we can go now downstairs, and there is some photograph. You can follow me. Then we make photo, and then will be lunch there, and we can continue. You can sit and you can eat here. The operation will continue. Probably now we should start at 1:45 p.m. with biological therapy. But Achim, he has their lectures, so probably we change our panels and we start with epistaxis. Yes, we will see according to the operation. Now, photo, lunch, and come back, please.
Klimatizace prý jede na plné koule. Prý. Prosím tě, mám problém trošku, Lenka Čabalová je na sále a operuje a má přednášku, takže si přehodí. Dobře, takže ji skipneme. Jo, OK, dobře.
Jako já ty myšlenkám jako
Alenka. Now, because we changed the session, biological therapy will be after epistaxis. So now you have a time for rest, for
Hello? So we can start with our afternoon program. Now we start with lecture because Niels Abrams will tomorrow operate, and so we will not able to have lecture. So we start with short lecture about septoplasty, step by step. Niels.
Hi, I was asked to give a speech about septoplasty step by step for beginners. So we're going through it step by step. And first I'd like to start with the anatomy. There we go. We have 3 parts of the septum: the perpendicular plate of the ethmoid, the vomer, and the septal cartilage. 2 very important points of the septum are the anterior spine of the maxilla and the K region. That's our setup in Hamm, how we operate. We start with the injection of ropivacain and suprarenin. Also, we use cocaine for the decongestion. That's our instrument table. We have the Killian specula. I really have trouble with the laser pointer. It doesn't go where I want to. Okay, this works for me. The mouse works. We have this way. Okay. Okay. We have the small preparation scissors, we have the bayonet forceps, we have the columellar forceps, the Edson Brown forceps, and the ala retractor. On the cutting side, we have the scalpel, of course. The Bivo knife, we don't use it on every operation anymore. The Masing knife, the sharp elevator, the Frias elevator, and the Cottle elevator. The bigger scissors, the different kinds of Blakesleys, the Craig, and the cartilage forceps. Also, we have the 2-prong hooks. Up here we have the chisels, the hammer, and the bony crusher. Then some additional instruments like the suction device. So first step, what we do is inspect the nose, which is a very important step. We shave the hair out of the nose, so we have a good vision. For this, we use the sharp 2-prong hooks and remove all the hair. Afterwards, we use the Cottle forceps and the ala retractor to pull up the nasal tip and make the incision parallel to the Cottle forceps to find the caudal cartilage of the septum. Afterwards, we use gentle cutting till we really see the cartilage. When we found the caudal end of the cartilage, we prepare the upper tunnel. So we remove the pericondium from the septum cartilage. This is how it's supposed to look like. So we have a whitish blue. And in this moment, we know we are not yet at the right space. At this point, we also use the Killian speculum. When we finish the upper tunnel on both sides, we begin preparing the lower tunnel, the tunnel on the nasal floor, or inferior tunnel. We normally start on the concave side because there's less tension, so we have one side, safe side, and then we combine the upper and the lower tunnel. And if it's no deviation in the frontal part, we can also perform this on both sides. If there is a spine in the front, normally we have to resect some cartilage first, which is one of the next steps to complete the lower tunnel afterwards. This is what you can see here. So we make the posterior condylotomy, which is either at the maximal point of the septal deviation or at the line between the cartilage in the front and the bone in the back. Then we mobilize the cartilage and take out a part at the bottom so we have a free view on the bony spine. If we have a big spine like this, we now prepare the lower tunnel, the inferior tunnel, which is very difficult. You see it very well on this picture if you do it in the first place without resecting the cartilage at first. For resecting the spine, we normally use a chisel because it's massive bone. On the pictures you can see it here. We have the upper part, which is the cartilaginous spine. You see how we incised it and afterwards removed it, and now you can see down here the bony part of the spine we can remove with the chisel. So that would be a very easy septum normally. In some cases, there's a deviation of the caudal part of the septum or a retracted caudal part of the cartilaginous septum. In those cases, we create a pocket in the columella. For these, we use the small preparation scissors or the deviated alar scissors. And then with the PDS sutures, we can pull it into the columella pocket. In some cases where we have a severe deviation, we need a PDS splint to stabilize the septum after the resection. So this would be something we would do in between and suture it to the cartilage and afterwards pull it into the columella pocket. At the end of the operation, we reimplant mostly cartilage, sometimes also bony parts, and then we fixate the septum with hemitransfixion suture or with a transfixion suture. In many cases, we use a transfixion suture with a straight needle, so we can fix the caudal part of the septum to the medial crura of the alar cartilage. Afterwards, we use, you can see it here, those blue silicone splints. We fixate them on the septum, and afterwards, in the most cases, if we don't use Doyle splints, we use nasal tamponates. Thank you for your attention.
Niels, thank you for the presentation. Any questions, please? Peter?
Like to ask how often do you perform a turbinoplasty or some surgery on inferior concha during this septoplasty, like for compensatory hypertrophy on the site you have more space?
Yes, we do it with a submucosal electrocautery normally. We don't coagulate the mucosa, of course, and we do that quite frequently, normally with the majority of the surgeries. We also look at the middle turbinate, of course, if there's a big concha bullosa, for example. That's something we always have in mind. And if there's a big concha bullosa pressing into the septum, we sometimes, of course, do have to resect it.
So, okay, can say 90% of patients have a turbinate surgery with septoplasty, or?
Yeah, around about.
Okay, thank you.
I think that septum surgery is one of the most difficult surgeries because I think that most of people, they do it as self-makers, yes? Because you don't have any control if somebody is doing something in deep. You don't see what is he doing. For me personally, the border in my professional life was staying in Klagenfurt in 1991. Up to this time, in Czech Republic, it was explained that septoplasty, not septoplasty, resection. It was no septoplasty in Czech Republic. That it is not possible to do under general anesthesia, that only under local because it is bleeding. It was so in Czech Republic. And it was very difficult to separate pericondium from cartilage and bone. And there, when I was in Klagenfurt and I saw Dr. Kolmitzer, he was staying, the patient was lying there. He was looking in the corner and he was separating the pericondium from cartilage. And it was for me something, when I came back at home, I started to do it in quite completely different way. Yes, I was not afraid, but I think that for beginners it is really not easy operation. Peter?
What is very beneficial is to use endoscope to teach young residents to know how to perform that case. So we use it and we teach them.
I think for teaching that's a very good idea, yes.
So tomorrow we will see, we try to show, but
as you said, you have a special septum for me.
It's not easy. I think that this septum is not easy. It's for experts.
Hello, question. Would you perform turbinectomy prior or after performing?
We don't perform turbinectomy.
Radiofrequency.
Speak to microphone, please.
We don't take out the inferior turbinate completely.
I meant radiofrequency turbinectomy.
Yeah, we do that afterwards when the septum is straight, because in many cases you don't even see the lower turbinate to judge it in strong cases. For example, the case you see, I think it's number 3, which I will operate tomorrow. The septum is so much to the lateral wall you don't even see the inferior turbinate. It's impossible to do the treatment of the turbinate before the surgery.
But on the other side, you can more space afterwards. Okay.
Normally
splints,
afterwards.
You put splints and then you start.
No, before the splints.
Before the splints.
When the septum is basically straight, before reimplantation, we perform the treatment of the turbinate, then we reimplant and close the septum.
Okay, thank you.
So, some words of septoplasty is the result of 1,000 hints from experienced surgeons before you. That's my opinion, or my experience. When I was on the university clinic, no one can operate on a septum. No, everyone, yeah, septal surgery is not so difficult, do it, yeah. It's how you do it. But it's one of the difficult parts. If it's the opener to the surgery for an ENT surgeon, that's my opinion. And you have to have a very experienced surgeon that shows you step by step how to prepare it. It's like a cooking book. You cannot make a cake without a cooking book. I mean, if you start at the end of the recipe and you go backwards, then you will not succeed. And I had a great experience in Utrecht from Professor Heusing. He was one of the famous surgeons in Europe, and he taught me step by step how I have to got an operation of the septum. In our university clinic, no one knows how to prepare. And the most thing what happens is that they shorten the septum in the anterior part, and the septum goes down, and you get an empty columella afterwards. That's what I see today. And that's, Nils, can you please, den Papua-Stich, sag mal eben, auf dem Video. So that's one of the great hints what I learned from Hassan, what I learned. And second, I showed it is one of the great hints I've learned from him. Yeah, you saw the picture here, right? That's the Papua stitch. That is Professor Heusing told me. So when you're in fear, did a posterior chondrotomy, and the septum goes away, and you want to fix it in a columella. You name a stitch here. You take the stitch here, and it's here. Put it, drive it through the nose, and it's lying here on the nostrils. And then you fix it with transplexy, with 3 transplexy sutures. That will fix the septum. If it's here for 7 or 8 days, it will fix the septum very severe. Yeah. There are 1,000 things you can learn, and the second thing I have learned: don't forget the turbinate. That's what that Professor Piesich said, which Professor Heusing said. Don't forget the turbinate. If you don't look at the turbinate and you have a concha blosa, for example, you will not succeed in your surgery. That will not succeed, never. That's the 2 things from many things I can show you. But don't forget this stitch. It's very good to, if the septum goes back. That's a wonderful stitch and we call it Papua stitch because the Papuas put all this to the nose here, the things, yeah. Thank you.
Thank you for this comment. If there are no questions, so we can continue. Thank you. And we can continue with program. We changed our sessions. We start with, because you need some time to, and we start with epistaxis. Peter, the stage is yours.
Thank you. Thank you, Pavel, for introducing. So I would like to start with our session, which is epistaxis. I don't know if Professor Komínek introduced here the new book, Epistaxis. which is published at the end of last year. It's in Czech. I would like to, I have two books here, and most active participant during the session of epistaxis can have this like a present. And what's the most important thing that you have here two of editors, main editor and his deputy, and they can sign them, and you have a big trophy. I don't know, big trophy. Okay.
What criteria do you have to be
most
the most
active?
active? How? What?
Most
what
active.
should we do?
So active.
Active.
Active, maybe applause. We will see. Okay. So epistaxis, yeah, two books for you. So epistaxis is the most frequent emergency in ENT, in rhinology specifically, and in the recent 20 years, there is a shift in paradigm how to treat the epistaxis from long hospital stay with packing and repacking and packing and repacking and packing and repacking to immediate surgical procedure or embolization. So that's why we choose this like session. And I would like to start with presentation. I would like to ask Dr. Hanák about treatment overview of epistaxis. Honzo, please. You can without jacket, I think it's terrible hot weather here.
Good afternoon, dear colleagues. I would like to thank Professor Komínek for inviting me in this workshop. My topic today is epistaxis treatment. There are several methods for treatment of epistaxis. We can use for epistaxis treatment cauterization, I mean chemical cautery or bipolar electrocoagulation, and absorbable nasal packing, non-absorbable nasal packing. Surgical therapy involves endoscopic sphenopalatine artery ligation of the ethmoid arteries and transantral internal maxillary ligation. We can use embolization, I mean selective endovascular arterial embolization, and other methods such as fluid resuscitation, blood transfusion, hemostatic therapy. Cauterization includes chemical cautery by sticks with silver nitrate, or bipolar electrocoagulation by bipolar forceps. It's indicated for localized bleeding, primarily in the anterior part of the nasal cavity. Absorbable nasal packing involves hemostatic gelatin sponge, oxidized regenerated cellulose. It's indicated for diffuse mild mucous bleeding. Flowable gelatin matrix with thrombin is indicated for persistent and severe epistaxis. I usually use this material for during the skull-based surgery, or when I remove some benign or malignant tumor from paranasal sinuses. Non-absorbable nasal packing includes ribbon gauze and strips impregnated with antibiotics ointment and the more modern material Merocel. It's compressed, dehydrated, expandable sponge, Rhinorapid, and nasal catheters. Nasal catheters are indicated for recurrent severe epistaxis and posterior epistaxis. Surgical therapy includes sphenopalatine ligation from endoscopic transnasal approach, ethmoid arteries ligation from the external approach and transantral internal maxillary artery ligation from the external approach, from subapial approach. We can use bipolar forceps or a clip player forceps with hemoclips. Selective endovascular arterial embolization by Seldinger technique is indicated for recurrent severe posterior epistaxis and before surgical resection of the vascular tumors. Our radiologists use some embolic substances, for example, onyx. In the first picture, you can see juvenile angiofibroma before the embolization, and the second picture shows the situation after the embolization. Every patient with bleeding from the nose should have checked vital signs. If it's necessary, we should provide venous access for fluid resuscitation by isotonic crystalloid solution, for example, Ringer solution. If the blood loss is higher, we can use blood transfusion. As hemostatic therapy is indicated by Exacil-Pamba. If the patient has a higher blood pressure, you can use antihypertensive therapy. And if the patient suffers from hypovolemic shock, we should cooperate with intensivists. Thank you for your attention.
Thank you, Honza. Very nice overview. Anybody has a question for?
Yes, excellent overview. Thank you very much. One thing is, being a registrar at some stage, okay, I wondered when the patient came in whether or not I should stop them being on an oral anticoagulation. Yeah, because I just put a packing in. You have, let's say, recurrent bleeding on the left side. Put a non-resorbable packing in, put him on the ward, okay, and we would like to wait for like 48 hours. And now I don't know whether he's going to bleed again or not. And if, then maybe my consultant tells me, why haven't you stopped warfarin, Marcuma, or whatever you call it? Whereas if I stop warfarin, Marcuma, whatever, he'll tell me, why did you stop? We're going to discharge him immediately afterwards, you know? And now we have to use heparin or whatever to bridge it again, and it makes things complicated. So how do you do it?
You know, the first step is, we use such a first step nasal packing, I mean non-absorbable. Then if the patient is still bleeding, we use nasal catheter, and we usually let this nasal catheter for 2 days. And if the patient suffers from recurrent epistaxis, I usually indicate rhinoendoscopy in the general anesthesia, and we can do the sphenoplatin ligation by endoscopic approach.
You meant the patient with anticoagulation therapy, yeah?
So the patients, yeah. I will send this patient in. No, we will take the blood. We will take coagulation and
we send him to the intern.
Yes, and it's in the internal department. Yeah.
Can I have comment? I don't think that so many patients needs to be just bridged by Clexane or heparin. So I don't think that this is that big trouble, because when there is a bleeding, they usually also cardiologists respect that we need to just put it off this kind of medication.
But after discussion with cardiologists, because you can take for the patient a bigger risk if you take something off.
That's true, but there are only really few just indications for permanent anticoagulation. So this is
discussion with intern or cardiologist, or it's the best way how to solve this patient. Yeah, stop if it's possible, and then you have patients without epistaxis. Okay, So what's your favorite packing? Do you use gauze packing?
You know, we use usually strips with ointment. But I know there is more modern packing, because I know that you use Merocel.
Yeah. We try. We discuss it with Professor Weber. He's not here nowadays, and he's strongly against using this self-made packing into patients. That it's against law. I don't know what in Germany. What do you think? But Professor Weber told us that never.
It's not exactly against law, but I would think that it's quite hard to defend yourself if one of these packs actually dislocates and the patient suffocates. Then at least if you've used a packing that is actually on the market, it's probably easier to say, okay, well, this is a CE approved packing that I've used, and I've used it according to how I should use it, then it's probably easier to defend yourself. That's one point. And I think what also Professor Weber always stresses is that modern packings are there are some modern packings that have like a lining, a very smooth lining. And they are actually nicer for the patient to be removed. And it's also the risk of rebleeding is much less, because you don't have, depending on how long you leave the packing, not a lot of granulations growing into it. So he's a big fan, and I'm a big fan too, because he's my teacher, of these packings that have a lining and that don't stick to the mucosa.
Because the damage of the mucosa after this gauze packing is terrible, I think. Okay, we can see what vets use. So we can see packing and horse nose, and removal. So I think it's not for our patients. They want to feel that. Okay. What about okay.
The question.
It's not my horse.
May I have a comment? The question is, what are we talking about? Are we talking about the bleedings in the practice, or which we can coagulate? That's not the problem. On the other hand, if I have severe bleedings on the intensive care, so there's nothing is. The main thing is to stop the bleeding, and it doesn't matter what you use. And if you want to, you have to use a Belloc, and we have to do this 2 or 3 times a year today also. Why? Because severe bleedings, it's not matter of a CE or whatever it is. You're eager to stop the bleeding, and then afterwards you think about what you can do. So if you have a practice, I do coagulation and I do the operation of the sinopalatine artery or so on. But it's a massive bleeding in intensive care. It doesn't matter. You use anything to stop the bleeding.
Definitely, you are right. Yes, after injuries like car accidents, for example, definitely. Do you use antibiotics during packing? And
if we use a nasal catheter, the patient is using antibiotics. Yeah.
Excuse me, what is it, nasal catheter?
Balloon catheter with balloon. Nasal catheter with balloons, like this.
You mean balloon packing, like balloon tamponade from catheter? Okay. Okay. Any other questions?
Professor, as you mentioned, patient with coagulation therapy, anticoagulation therapy. My feeling is that now we are able to stop in most cases this bleeding with electrocoagulation. That this patient, many patients, they use it, but you should say, yes, he has anticoagulation, so tamponade. But it is not true. I think that mostly it is only local bleeding. And even though he is using this and this medication, we are able to stop it with electrocautery.
I disagree a little bit. If it's anti-aggregation therapy, like antithrombotics, then yes. But if you have a patient with warfarin, then if he has 2.4 or more, then I think that if you coagulate the place, then starts bleeds around and around and around.
My patient with warfarin.
That could be, but that must not be. That could be. Yeah, I know this what you said. That could be, but must not be. I first want to try what Pavel said. Always with the coagulation. Somewhat to the nasal splint you saw just. They must not be filled up with air. They must be filled up with water, with saline. This one. Show it the picture again. Yeah, because air is too hard and too strong, and you get necrosis in the nose. So this one, you must have to fill up with water and saline solution, but not with air.
Because after that, you can see you have to be, or the packing should be a little bit more posteriorly than usually we see. But
fill it up with water.
Cause the alar necrosis here
but
after 2 days.
This one is in the choana, and the other one is the nose. So, but they have to be filled up with water and pressure controlled, not a air in this thing, and then you have great necrosis after 2 days. They have to be filled up with water.
So I think we agree that best packing is no packing, yeah? So if we can treat it like coagulation or different way. Have you mentioned FlowSear or Surgiflow in therapy of that? I don't know. Yeah.
I use it during the skull-base surgery. For example,
during skull-base surgery, we use it in young children, for example, who are in a therapy for leukemia, for example, or something like that, and they have low thrombocytes. I don't know. Yeah. Right. So we put the Surgiflow into the nose, and it stops bleeding, and it's perfect. For them to have no packing, especially if they are 6-year-old, for example.
Yeah, I think that's another patient group where we have to have a look at. So. First of all, I think, yes, if you are able to coagulate and then leave it alone, perfect. All the guidelines, British guideline, French guideline, and so say, okay, you coagulate, if it stops, fine. Next one, please. Now, the problem is the guy with the recurrent bleeding being, for instance, on intensive care, but more often it's on intermediate with an left ventricle assisted device and having, everything the cardiology dreams about, and then starts bleeding, and you put in whatever you want and you put out whatever you want after like 2 days, and then repacking and stuff like that. FlowSeal is a possibility, but there's also a Stark-based powder available on the market. For instance, Annexate, developed by the US Army from like Gulf War type of things, I don't know. Any experience from you guys with that?
No.
Especially in thrombocyte deficient patients? Because we started to use it. They have what baby powder looks like. You have this, okay? And you give it the patient, say whenever something comes out looking red, you are able to do yourself a bit of, Stark-based powder in there. And that gives the patient the empowerment to help himself in a way. You can cut out the applicator if it's stocked or something. And it's actually, in comparison to FlowSeal, quite cheap. So that would be something. Have a look at that one as well.
So maybe it's something like Traumacell we had years ago. I don't know. Okay. You mentioned how do you treat the patient after packing, like in the hospital or outpatient?
No, we take them in hospital because we believe, based on a recent publication, I think orchestrated by you or Rainer, or that any patient with a nasal packing is supposed to be an inpatient, but there's also a political background for that one. They're inpatient for 48 hours. After that time, the packing goes out. If they bleed again, they go straight to the OR to get a sphenopalatine artery, well, bipolar coagulation in my hands. And the anterior ethmoidal artery follows if there's any bleeding seen there. And which leads me to the next question, if I may ask, that is, when do you do, or don't you do a CT scan before taking the patient to the OR?
It's later, yeah? Discuss. Okay. But I think it's different from our country or from our department, because we treat this patient like outpatient. We put the packing, if it's anterior or don't know if it's posterior, we put rapid renal packing, and he or she goes home.
That's the same who do we in the practice also in Germany. But to flow seal it's a pity, but I must put a little water in the wine, because with the Osler disease, I tried it. You put flow seal many times in the nose, nothing happens with the Osler's disease. That's a great problem for us. We have 4 or 5 patients with Osler's disease, and you can put anything in. Especially a flow seal. Flow seal doesn't work in Osler's disease.
In Rendu-Osler, you mean Rendu-Osler-Weber disease.
Yeah, that's a great problem for us.
Okay. So I think, questions? No? Active guy?
Just a small question. Which type of intravenous hemostatic do you prefer? The Exasel or the Sinon? Exasel. For the serious epistaxis. Okay. And why? Do you think it's more powerful? We had this discussed many times with some older colleagues, skilled colleagues, let's say, and we have no answer for that.
There is our intensivist anesthesiologist Ondrejor can answer that.
The reason is very simple, because Exasil tranexamic acid have A1 strong of evidence, and Ditzinon have no evidence at all. On the other way, the tranexamic acid stabilizes the coagulum, and Ditzinon only block only go for better function of platelets. So the mechanism is completely different.
Thank you very much. Thank you. Okay, so Honzo, thank you very much again for a nice overview, and I would like to ask next presenter, who is Michaela Mladoňová, and she will tell us something about S-point.
Thank you very much, ladies and gentlemen. I'd like to continue with S-point epistaxis. Is rare or frequent? So we will see. Epistaxis is one of the most common acute conditions in ENT. The treatment paradigm has shifted toward selective coagulation of bleeding vessels, but despite it, the source of the bleeding is not correctly identified in about 30% or 20% of cases. Severe epistaxis is usually considered to arise from posterior parts or from posterior bleeding. But I'd like to introduce you a newly discovered source of epistaxis. And this specific bleeding point is localized somewhere in the superior portion of the septal body, posterior to the septal body, and somewhere around the axilla of the middle turbinate. So as you can see, it's here. And this specific point arises from the septal branches of the anterior ethmoidal artery and was named after Mr. Stamp, and that's why Stamp's S point. Since S point is of an arterial origin, severe epistaxis originate from it. And what's more, due to its specific localization, is not easily identified by anterior rhinoscopy. And in this unclear terrain, bleeding from S point is often mistaken for bleeding from posterior part, it means from sphenopalatine artery, and this results in refractory epistaxis. There are also some studies in the literature. For example, Roque et al. Have published that selective coagulation of the sphenopalatine artery leads to recurrence of bleeding in about 30% of cases. And they assume that the cause is undetected S point. And these assumptions were confirmed by other authors too. Well, we have performed a retrospective analysis at our hospital. 25 patients with refractory epistaxis were enrolled. And as you can see here, in 32%, we have performed coagulation of the S point. And in 68, it means the blue one and red one part, we have performed selective coagulation of the sphenopalatine artery. But in 2 cases, we have noticed recurrence of the bleeding, and as you probably know, the cause was undetected S point. So totally in 40% of patients was the bleeding from S point. So in conclusion, S point plays important role in severe refractory epistaxis, and it is very important active search and identification. You have to use endoscope, systematic endoscopic assessment, and what's more, coagulation or endoscopic endonasal coagulation, safe and effective therapy with high success rate. That's all, and thank you for your attention.
Thank you very much for a very nice presentation. So, questions? Professor Comini.
Thank you for the presentation. All these patients, they were patient under general anesthesia, this examination.
Under the general anesthesia, yes. That's a very important point, yes.
And is possible to coagulate this S point also in office as outpatient?
It is possible, of course. You must have skills. Patients have to...
What skills?
You have to know how to use endoscope. The patient must cooperate. You must have skills like to reach that area of S point, as you know, because it's very difficult to get there. And I think at our outpatient clinic, there are often young doctors, and it's quite difficult for them, I think so, for us. That's why it is much more easier to find it under the general anesthesia. Maybe what's more, these patients were patients with refractory epistaxis, yes? And this was analyzation of these patients with refractory epistaxis. And these patients were in operating theater, of course.
So, okay, yes, thank you. And if you start it under general anesthesia, 40% is not, it is a lot of patients. So you should start with identification of this S point epistaxis, and then to follow, if you don't find bleeding there, to follow with sphenopalatine artery.
I'm not sure what's the best way, but at our department, since 2019, since we know about S point, we do it like this, yeah? We are doing endoscopy of the whole nasal cavity. We're trying to reach S point, and if there is no bleeding, we will continue with coagulation of sphenopalatine artery in these patients.
So, literally, the recommendation, yeah?
Oh, excellent presentation. Thank you very much. I think that the teaching about the S-point, so making people aware, especially even older registrars, perhaps, is a valuable point. Now, my question is, in those cases where I came across an S-point bleeding in actually general anesthesia, so I was supposed to do something else, the patient were also having quite a severe septal deviation, and that impeded the registrar or whoever had done the examination before to actually have a look at that point. You know, he was only seeing it dripping down from somewhere. So if you are going to have a look at the patient again, perhaps you always also have the chance to have a look at the amount of septal deviation, so whether you wanted or needed to have a septoplasty to actually reach this area, because it may well be that the turbulent nasal flow actually attributes to the fact that you have a dryness in this area. Okay, and that would be my hypothesis, that that's one reason why you may see this as a third location. However, having said that, it's like 60 to 70% anterior bleeding, coagulation, go home, and then you have like 30%, from which the majority, possibly 70%, is phenylpalatine artery, and then you are in the area where you are with the S-point, to the best of current knowledge.
Thank you.
The problem of S-point is this behind septal body.
Yes, it's posterior to septal
intumescence,
body.
So you can't see it nicely in local anesthesia. Only in
But you should
patients.
use tetracycline, of course, to
Okay.
Can you repeat it once for us order?
In one...
Where should we find this S-point? Where? On lateral
on the septal
or
body?
medial,
No.
septal wall, nasal wall? Where?
It's on septal body, yeah. In the superior part. Yeah. Picture. So, it's on septal body, in the superior portion of the septal body, yeah, Professor? Yeah. Okay. And next slide.
Where is medial concha?
So I'd like to, show it here.
Make it bigger.
Yeah. Pardon? Yeah, Professor, here is septal body, yeah? Or nasal septum. Here is lateral wall and middle turbinate. Are you orientated?
Yes, I am now.
Okay.
I was orientated before, but I am not sure that everybody knows where it is.
And can you see this bleeding point? Mm-hmm. So it's in the superior part of the septal, or of the nasal septum. Yeah. It's posterior to septal body. Somewhere here is intumescence, yeah? Yeah. And is in the area or in the one line with a middle turbinate, yeah?
Yeah.
So you have to find middle turbinate and then go medially and you will find it. Probably.
Thank you.
One of the problems is that the mucosa is damaged after packing, usually, if you look for the S-point. So some authors tell us that we can conclude that it is S-point if you can see a pedicle of the vessel or how to say it, stříkající? Bleeding, squirt, I don't know how to say it. Okay, Professor Chrobok?
So, short question, excellent presentation. Have you ever seen bleeding from S-point on the both sides in one time?
I haven't.
Is it possible?
Definitely it is,
why not?
I think. Why not?
Why not?
Everything is possible.
Yeah.
And have you seen the bleeding on the both sides?
No.
No, thank you.
Okay. Any other question? No? Misha, thank you very much.
Thank you very much.
And I would like to ask our presenter, Dr. Hildebrandt, with presentation timing of surgical treatment.
Thank you. Okay, so as we've heard before, epistaxis is a very common otolaryngological emergency, and in most cases, the indication for surgery will be posterior epistaxis, which is arising from the sphenopalatine artery. In rare cases, especially in trauma cases, you will see anterior epistaxis arising from the anterior ethmoidal artery. So nowadays, if we talk about surgery for epistaxis, it's mainly about sphenopalatine artery ligation, and that's the main point I want to stress in this presentation. If we want to talk about indication for surgery, we have to weigh up the high success rate of surgery and the risk of maybe prolonged hospitalization, maybe immobilization with nasal packing, and of the packing itself, against the potential complications, the risk of surgery, and anesthesia if we opt for surgery. We also have to consider that our patients that come in with epistaxis, especially with severe posterior epistaxis, they have a high rate of comorbidities, about 70%. For example, hypertension, cardiovascular disease, and clotting abnormalities that might also influence their fitness for surgery. The literature has shown that early surgical intervention in epistaxis, which means endoscopic sphenopalatine artery ligation in comparison to nasal packing, can reduce the length of stay at the hospital for these patients. They can produce reduced costs per patient. We have equal or less complications compared to nasal packing and embolization. We have less pain and discomfort for the patient, and in some case series, they show lower recurrence rates than nasal packing. To underline this, I want to show you two studies. The first one is the one by McDermott and colleagues. They have investigated 45 patients that had sphenopalatine artery ligation in their department. What I found quite interesting, and we were talking about this packing and repacking, 21 of these 45 patients had two previous packings before they went for surgery, but there were also patients that had 3 or 4 or 5 packs inserted before they actually went to surgery. The mean time to ligation from the time of admission was 2.8 plus minus 2.2 days. The mean length of stay for early ligation, which means within the first day of admission, was 3 days. Late ligation, after the first day of admission, the length of stay was 6 days. There was actually no difference in the need of blood transfusion, but there were significant differences in costs of treatment of about 6,000 euros versus 10,000 euros. Dedia and the working group, they did a standard decision analysis model comparing first-line SBA ligation, which means SBA ligation straight after admission in posterior epistaxis cases, and they compared it to current practice algorithm, which was in their department nasal packing for 3 days. This is a theoretical model, I have to say, so no patient involved. And what they could find is that they, if they opted for first-line SBA ligations, they had cost savings of $1,796. And only if the duration of packing was reduced to 2 days, then the packing was cheaper. And for longer duration of packing, there was a very a steep rise in costs. Obviously, this is at first a theoretical model. It's based in the United States, so you can't really directly compare it. And obviously, you can't really judge what is best for the patient just on the basis of costs. But it's interesting what is involved cost-wise. Very interesting is the study by Lakhani that proposed the so-called Wexham criteria to decide which patient might benefit from early surgery. And these Waxham criteria were persistent posterior epistaxis that was uncontrolled by packing, hemoglobin drop of more than 4 grams, or the need for blood transfusion, 3 episodes of recurrent epistaxis requiring repacking during a single admission, and this recurrent nosebleeds we talked about before, repeated hospital admissions for recurrent ipsilateral epistaxis. They then applied these criteria retrospectively to patients admitted to the hospital for posterior bleeding during the time frame between 2002 and 2010. And they said, well, if at least one of the Waxham criteria was achieved, then the patient should have gone for surgery. And they actually saw that all of their patients fulfilled at least one of the criteria. And they also saw that uncontrolled epistaxis and more than 3 rebleeds during admission were more often fulfilled than the other criteria. The Hellenic Society of Rhinology and facial plastic surgery did extensive literature review and put out guidelines for posterior epistaxis management, and they recommended to withhold SBA ligation. We were talking about this, or kind of this before, if the patient had coagulopathies or was on anticoagulant therapy, but had also elevated INR of more than 2. And then they said, well, it's better for the patient to first withhold the anticoagulation, and then if still the bleeding hasn't stopped, then they would opt for SBA ligation. And also in medically unstable patients with a high anesthesiological risk, obviously these patients are probably not fit for surgery. Factors that also have to be considered are availability of operating rooms and materials, and obviously the doctor's experience in performing this kind of surgery. They also proposed a treatment algorithm for severe posterior epistaxis, and I want to go through it with you because it might be a bit hard to read it. And I also want to do some additional comments on the scheme. And this is only for posterior epistaxis and for quite severe bleedings or critical bleedings. So after initial assessment and risk factor assessment, they always apply the ABC approach, which first needs to secure especially the breathing part in our, when we talk about epistaxis. They do lab examinations, and then they actually classify the bleeding in severe and critical bleeding. Obviously in critical bleeding, and we've talked about this before, the first aim is to stop the bleeding. So the patient has to be packed, and obviously it doesn't really matter if it's a nice surface of the packing. You have to stop the bleeding, and then you have to maybe also do a Belloc, that's for sure. And so you apply the temporary posterior packing with double balloon catheters or Foley catheter and anterior packing, and then you should, as soon as the patient is stable, opt for surgery. That's one of my comments that I made before. In less severe cases, it is good for the patient, and especially the nasal mucosa, if you use less traumatic packings, there's this one Suntouch tamponade, which is a PVA tamponade with a plastic sheath around it. What is important for the younger colleagues, and what I always see in our department, what is a problem, you have to, if you do a posterior pack, you also have to make sure that you use an anterior packing as well, because otherwise they will continue bleeding out of the front of the nose. So always posterior plus anterior packing. And in the severe cases, if bleeding can be controlled by cauterization, then the patient, you don't have to go towards surgery. But if the patient can't be, or if there's still active bleeding, they recommend temporary posterior packing, and if that fails, they go towards surgery. I think what is a good option is in patients with posterior packing, if the packing is primarily unsuccessful, so your patient bleeds, although there is a good packing inside, a good posterior and anterior packing, and the patient is still bleeding, check and correct the blood pressure, because that's an factor that might also lead to persistent bleeding under your pack. Check your coagulation, and if that doesn't help, then the patient goes for surgery, and that's what we do in our department as well. And if the patient needs repacking and has more than one repacking, I also think that these patients might benefit from surgery, and that's what the WACSAM criteria more or less say as well. We don't often use embolization anymore, because usually patients can really be controlled with surgery, but you have to have it as like a last resort, so if the patient still bleeds. So thank you for your attention, and I'm happy to discuss this with you.
Thank you very much for a very nice presentation. So, questions?
I am most active. I would like to have this book. The approach can be different. It depends on your activity. When we discuss the approach to sphenopalatine artery surgery with Rainer Weber 10 years ago, I think, we were surprised because he said, every week we do minimally one surgery. At that time, we were much more conservative, and we didn't perform this surgery, or very rarely. And it depends on you. You can operate nearly everybody immediately, or you can wait. What is your approach now in normal patient, not with some anticoagulation, blah blah blah, with normal patients? So he is in hospital with packing, and if you remove it, you go to operating theater directly, or do you wait?
It depends. Like if the patient comes in, I can control the patient with a posterior packing. Then the packing stays in for 2 days. Packing comes out, depending on what kind of packing. If they have the balloons, I always try to deflate them after 1 day, just step by step, because I don't want to get necrosis of the mucosa. And so if I can control the bleeding with that, that's fine. Patient gets discharged on the 3rd day, and that's fine. If I get rebleeding with the packing in situ, and the patient has proper packing, and I can't say, well, it's not, it hasn't been properly packed, so it's a pack failure, I'll repack it properly and then give it another chance. If the packing is proper, everything else that I can control is controlled, and he still bleeds, I go for surgery.
Surgeries do you perform at your clinic per year, per month?
Well, we had this, we looked at our patients.
How big is your region? How many people are there approximately?
It's quite a big region. We have smaller hospitals around, but you usually don't see emergency patients. But we have in Freiburg, we have just one ENT department. And I would say it's about maybe 2 a month that we see that actually have to go to theater. Sometimes it's more, sometimes it's less, but on average, I would say it's about 2 a month. We did the study on our patient, a retrospective study, and we saw that for patients that have been admitted to hospital, it was like we had 520 571 in a 5-year period, and 14.7% had to undergo surgery.
How many doctors are able to do this surgery?
Well, all of the consultants that are on
How
on
many
call.
consultants do you have?
We have 10.
10. How many operations do you perform?
Yeah, we have about 30 to 40 people undergoing this kind of surgery per year. So I think it's, and we have only 6 consultants. So if anybody wants to become consultant, please send me your details. But we also have ENT specialists who are capable of doing this type of surgery because we quite aggressively teach it, hoping that at some stage it won't be necessary to come to a university clinic anymore for this kind of, treatment. Yeah.
Well, the problem is with that patients usually come in not during office hours, but at night, and then the ENT doctors outside the hospital, they're not on call, they don't care about it, and everyone gets sent to us.
Yeah, but
so
because we pack them for like 48 hours, normally, and I refer to my previously posed question regarding the CT scan, they have the packing inside and then they start to bleed, so we have the opportunity to send them to a CT scan. And then it's normal that like the more senior registrars or ENT specialists actually want to deal with that. When I just did the papilloma, I was actually dissecting the sphenopalatine artery at one step just to, get a better surgical field. So to have this skill, okay? And that's just the basic. But, I mean, Münster is responsible for about 7 million people which is Westphalia. So in northern Westphalia, we are Westphalia, supposed to. However, there are like smaller also ENT units who are also doing some kind of stuff, So it's not the complete 7 million. It's just the ones who are making trouble.
I think the procedure itself is not very hard. It is quite, because it's not a sinus surgery. You stay out of the sinuses, out of the sinus area. It's basically an intranasal procedure, and it's quite easy to perform. So, and it helps your patient. It has a high success rate, low complication rate. Of course, the patient has to be fit for surgery, fit for anesthesia, but otherwise it's a quick thing to help your patient, and they don't have to get packed and repacked and stay in hospital for 6 days, 7 days, 8 days.
What is most critical points when it is better to avoid this surgery? When you are thinking not to operate, it's better to have another tamponade, not to operate?
Well, if the patient's unstable and not fit for surgery, basically, if the patient comes in, has anticoagulant treatment and an RNR of 3 point something, then I think, well, maybe we try to antagonize that first before we put him to surgery. If the packing hasn't been done properly, I try to do a proper packing first, because obviously every anesthesia has risks, every surgery has risks, so we always have to outweigh this. But yeah, I think that would be the main points.
Yes, I think that the same approach is at our...
We talk about the arteria sphenopalatina, and you said that it's an intranasal approach. You know that there are different methods to stop the bleeding from the arteria. How do you do it?
Sorry,
do you do it with clips, or do you do it with monocoagulation, do it bipolar
I do it with bipolar coagulation. I think the clipping is hard to do, because it's hard to put clips in there, in this area, and also there's a risk of them slipping. Monopolar coagulation has coagulation in a depth that I probably don't want to have. I usually do bipolar coagulation unless I can't control it and I can't get there with my bipolar forceps. Then in some cases I use the monopolar.
Yeah, we normally use the monopolar suction device. That's the same we use in the laryngology. And I must say, for me, the opening, the sphenopalatina, if you want to coagulate them, is always in sinus surgery, because When I do it, and I can tell you I did it several times, if it's bleeding, if you had packings before, the tissue is very weak, and if it retracts. So you have to open the sinus, you have to take the burr, you have to take the bone in the backward on the sinus and look for the sphenopalatine artery. And then you can coagulate it. Sometimes, in this case, which had packings before, the sphenopalatine artery is retracted to the back wall of the sinus. And you have no chance to get this with a clip or with a bipolar. You must free the bony canal from the sphenopalatine artery, and then you take the monopolar cautery suction device to stop it. That's my opinion.
I have to disagree with that. Like all of our patients that I take to surgery, they have had packs, and they have been repacked, some of them, and I still have never ever, in all of the cases that I've done, needed to remove the back wall of the maxillary sinus.
Yeah. Maybe that's
not of one of the cases, because what is important that you don't get rebleeding is that you try to coagulate all of the branches. So it's not just the main branch, but you have to follow
the main branch
towards the anterior wall of the sphenoid sinus, because there's always branches there, and there might be an inferior branch, an accessory branch as well. So you have to coagulate all these branches to not get rebleeding, but I never had the problem that I couldn't find the artery because it was retracted.
That's not the problem. It's not you can find it, but it retracts during the operation. And tell me, I do it several years. I'm very old, and I have to do it several times because if you coagulate it and if the bleeding comes new, it comes, and you have to drill it. That's my opinion. I think we must not discuss it, but it's not only intranasal surgery. That's what I want to emphasize.
Yeah, also I don't have this experience. I've got 20 years of ENT experience now as well, but I've never had to do it. Maybe it's, I don't know, but not in my cases.
But I think that you can go to the artery, to the infratemporal optericopalatine fossa, to resect the posterior wall of maxillary sinus, and it's not a problem because you have a Carison usually for a resection of crista ethmoidalis. Yeah. So, and another remarks, I'm cutting the branches after I coagulate it because you can't see what is behind. So what's your management?
Yeah, I do that too. I go to the main branch, take the ethmoid crest to better see the main branch. Then I coagulate the main branch, cut it, and then I keep dissecting posteriorly until I'm at
you reach anterior wall of
sphenoid. And coagulate and cut all the branches that I get across. And also I dissect downwards from the sphenopalatine canal or opening, because in some cases there's an accessory branch coming out there through an extra ostium, and you have to coagulate that one too.
And do you open maxillary sinus? No way. Okay.
No.
Because I think it helps younger colleagues.
Yes, it helps for
definitely for orientation.
Definitely. But then you have to do sinus surgery.
Yeah. Okay. So what about our department? How many sphenopalatine artery coagulations we performed last year, Lenka?
Okay, last year, I don't have statistics for last year, but in the last 8 years, what I have statistics about 40.
40?
40, but it is usually, some of these are combined surgeries, so only sphenopalatine arteries in the last 8 years, let me see, I think about 20, 25.
So we have to speed up a little bit.
Yeah, we have to. And we thought that we were really proactive considering surgical treatment of epistaxis, but we were not.
What about CT scans before this surgery? Do you perform it?
Well, I have to say in our department, usually they are performed, although I personally think it's not necessary. Because we did a retrospective analysis of our patients as well, and within these 571 patients that we actually looked at, there was none with any pathology on CT scan.
What about?
But do you do the CT scan to find a pathology, or do you do the CT scan because if you go for the anterior ethmoidal artery, you need to have a CT scan because you're doing sinus surgery?
We do it to find pathology, because that's why I do it, because usually the bleedings from the anterior ethmoidal artery are very, very rare. If it's not a tumor case, and not a trauma case, sorry. So if it's a trauma case, I will have a CT scan, but otherwise it's not really necessary, I think.
Yeah, for us, we do it to do sinus surgery in case we need it, and that's why we want to have it like in every sinus surgery case, and so that's a different prerequisite. And now the problem is, if we would know beforehand that we had to go there, we could be more specific, but because we don't know, we have to. And the second thing is, after packing or with packing in place, you always have an opacification, so yeah.
But how many anterior ethmoidal artery ligations did you actually have to do in non-trauma cases?
So if we go for like 40 in a year with nosebleeds going, probably every 10th or so 4 or 5 people. Yeah, and yeah, while that is not very much, it still is probably feasible to have the CT scan if you have a skull base injury, and so colleague had a skull base injury while trying to bipolar coagulate the anterior ethmoidal artery. It's certainly nicer for
I completely agree that if you opt for anterior ethmoidal artery ligation, you should have a CT scan. But I actually never had to do that in non-trauma cases.
And if you go to the anterior ethmoid artery, you go transnasally endoscopically, or from Lynch incision, from open approach, or transcaruncral approach?
I would go endonasally.
Endonasally?
Less complications.
What's your opinion?
I'm with Tanya, and if it retracts, then I'm prepared to do, precaruncular approach or Lynch incision, whatever. But yeah, only if it retracts and I need to go there.
I think it's more difficult to go transnasally in comparison to go transorbitally, I think. Small scar, but you can use a transcaruncular approach, which is with endoscope, and then you, it's a risk of CSF leak. What about CT scans and Pardubice? May I ask?
Sure, we do it always. Just I asked Zdeněk, maybe he can comment it a little bit.
Dr. Knížek from Pardubice.
Thank you for your word. I would say we always perform CT scan before doing the surgery for acute epistaxis in the patient. We do have reasons for that. One of the reasons are that each of the patients have some different anatomy. There can be some Haller cells, there can be some Onodi cells that can be in our way, and we do less complications if we know what the anatomy of the patient is. And the second thing is, it's rare, but it happened in our department. There was some case of severe posterior epistaxis. We did some nasal packing. We were prepared for doing the sphenopalatal artery ligation, and we performed the CT scan, and we saw there was the hemangioma in the roof of the ethmoids. So we just performed the surgery for the hemangioma, and that was it. So we always perform CT scan.
Yeah, I think yes, of course, there is a rare case of something that might be missed if you don't do a CT scan. But on the other hand, we have to think about radiation exposure to our patients. And as I said, we have about almost 600 patients, and there was no pathological finding on CT scan. I think it's something that you actually have to weigh up. The risk of probably missing something, but then obviously when the patient gets his packs out or while they do surgery, you have to have an endoscopic view of the whole area and the whole nose, and if it's a tumor that is actually protruding into the nose and patient is bleeding from there, at least you will see it then, and then you can still perform a CT scan. And then obviously if it's a tumor, the patient needs more extensive surgery afterwards.
Different is in trauma, yeah, definitely after trauma.
Yeah, definitely. Yeah. Patients, and as I said, in our department, patients still get CT scans, like all the patients with epistaxis, because the head of our department wants it like that. It's just my opinion that it's not necessary in all the patients. And I think the literature shows that as well.
Only to add that radiation of patient, it doesn't make me troubles. Yes, my philosophy is if it influence my approach or not, but radiation for me, not my radiation. Yes.
Yeah.
Okay, Tanya. Oh, one more. Active.
Is it some simple tricks how to find the sphenopalatine artery during the surgical procedure? Almost every time I have a problem to find it. And it takes me, let's say, 10 times longer than the skilled colleagues from me. Almost everyone knows where to find it, let's say anatomically, but in practice, it's a little bit different.
One thing is if you palpate the fontanella, yeah, so if you don't open the maxillary sinus, yeah, you go towards the end of the middle turbinate where it attaches to the lateral nasal wall. And then you start palpating the fontanelle of the maxillary sinus, which is soft. And as soon as you get to the hard bone, this is where your incision starts. And then from there, you follow posteriorly. And what also quite helps is that if you medialize your flap, then the artery tends out. So it makes like a little notch. And that makes it easier to actually find it. So really try to medialize everything. You don't even, like, not in all cases you can see the ethmoid crest. It might be very small and you can't really identify it. And also think about that you actually, in most cases, you always tend to be too high up. So go down. Stay at the level of the attachment of the middle turbinate. Yeah, because as you dissect posteriorly, you always go up, and then you're far too high and you end up somewhere in the ethmoid, and then you realize, oh, I've opened an ethmoid cell. So try to stay down, orientate yourself towards the inferior turbinate. And I think what is really, really helpful is this tenting of the flap so that you can actually see how the artery actually tends out. And not like the rest of the mucosa that is basically like straight and that it's like a little tent that comes out. And that quite helps, I think.
Sounds perfect. Thank you.
Okay, Tanya, thank you very much for a very nice presentation.
May I have one question? And do you use, what kind of endoscope do you use for this surgery? 0 or 30 degrees?
I use the 30 degree because it's standard in our theater. I learned it with standard. A 45, but now I'm using 30.
Thank you very much. Okay, so what's next? Next is Dr. Kachabalová, surgical treatment, step by step. So maybe it will be another answer for your question. Lenko, please tell us how to do it.
Good afternoon, ladies and gentlemen. The topic of my presentation is step-by-step surgical treatment of epistaxis. How we do it in our department. A lot of information has already been said, but I think I have some quite nice videos. So I will show you. So the timing and indication has already been discussed. I think that we are in agreement with Professor Hildebrand that we tend to have an active approach to these patients, and we tend to indicate the surgery more and more. If there's time, I also have presentation with our results from the last 16 years, and there is a big shift from the indication of embolization to indication of surgical treatment. So in the last 8 years, there are basically non-embolized patients, and nearly all of them were treated surgically. And surgery versus embolization, there's the question if it's complementary or if they are alternatives. For us, it's not an alternative. For us, the surgical treatment is primary, and only in case the surgical treatment is contraindicated or it fails, then we indicate the patient for intra-arterial embolization. So basically, we have these options: how to surgically treat epistaxis. We also will discuss locus Kieselbachii, because this is the first thing or the ideal situation for treatment of epistaxis. So Professor Komínek, he gave me this video how to show you, to demonstrate how to treat anterior epistaxis. So this patient is obviously not bleeding actively, but she had some cottonoid swabs in her nose for local anesthesia. So you don't need endoscope, you don't need anything special, you just coagulate the artery with anterior rhinoscopy. So this is a really nice video, but for mainly the youngest colleagues. Is there anything that you see that you would do differently? Because I think that if it was me in the video, Docent Matoušek would tell me that it's all wrong. I think. Of course, you need to use protective equipment like the face mask, and you should also close your unit. So I will move to the sphenopalatine artery coagulation.
Never.
Never, okay. But the patient was not bleeding actively, but okay. Never. The sphenopalatine artery coagulation is performed under endoscopic view. This is left side. I will show you a video later. So we perform it under general anesthesia. Here in our department, the first thing we do, we perform antrostomy. Then we identify ethmoidal crest, and after its resection, we coagulate the artery with bipolar coagulation, with a sort of modified bipolar coagulation by clamp, which seals also bigger branches of vessels. And it was already discussed, we transect the coagulated branches. According to literature, it's nearly 100% effective with minimal complication rate. And for us, speaking for our department, there are no absolute contraindications. ASA4 for us is relative, and it's on the discussion with the anesthesiology team. So this is a video on the left side. So the first step is medialization of, no, sorry, it was the right side, but the patient was bleeding on the left side. So the first step is, of course, the antrostomy. The problem with identification of the structures is because most of these patients are after repeated nasal packings. So for us, the identification of the maxillary sinus of its posterior wall and superior wall is convenient for better orientation because in the nasal cavity the structures are usually altered with the packings. So first you saw the cottonoid swabs with adrenaline, then this is antrostomy already performed, and now the ethmoidal crest is already resected, and these are the branches of the sphenopalatine artery. Now it is coagulated and transected. There should be bone on the posterior end of your dissection. What about anterior ethmoidal artery coagulation? Embolization is contraindicated because it is a branch of the interior carotid and it could lead to stroke or amaurosis. And usually it is because of the bleeding from this artery is caused usually by trauma, as was already said. And traditionally, it is said that you should coagulate the anterior ethmoidal artery in combination with sphenopalatine artery coagulation in intractable epistaxis. And as I analyzed our data again, in 2016, the S-point was defined in 2016. And after 2016, we performed just one anterior ethmoidal artery coagulation. And the other patients that we would probably indicate for AEA coagulation, they were treated for S-point bleeding. So this shift is very visible. After the definition of the S-point, nearly no ethmoidal artery coagulation, which is of course much technically demanding than S-point coagulation. What you can do, you can use these two approaches by Lynch incision or transcaruncular incision, which minimizes the scarring. The transnasal approach was already discussed, but it's, according to literature, it's not routinely used because, well, in patients with ethmoidectomy already performed, then it's probably easier. But from our point of view, if the ethmoids are intact, it is quicker and easier to go through the orbit. In the patients that we performed this surgery, we saw complications only once. In one patient after the transcaruncular surgery, he had diplopia, but just temporary. So here you can see the transcaruncular approach through the lacrimal caruncula. You enter the orbit between the periorbit and the lamina papyracea. And here you can see that we perform the surgery with the endoscope and that it is favorable to do it with 4 hands. That means 2 surgeons. Because what you can see here, this is the endoscope, this is a retractor, this is suction, and this is a biclamp that we use for coagulation. And then you compare it with coagulation of S-point, so it's much less complicated, even though we don't think that this type of surgery is that complicated. So I will show you. So this was a patient after a facial trauma. He was bleeding from the anterior superior part of the nasal cavity. And here you can see that we are already inside the orbit. Here there's the bone, lamina papyracea, and this is the periorbit. So we are going to dissect and dissect. And after coagulation of the artery, it will be visible here. Here. Yeah, it's working a little bit funny. So here you can see see the line in which it should be. it's a suture between the papyrazza and the frontal bone. So now then we are coagulating the artery. And in a few seconds you will see that there is no bleeding inside. Okay, this is the artery. So we are still inside the orbit. And yeah, we also transect the artery. Some more coagulation. And then we will have a look inside the nasal cavity and you will see that there is no bleeding anymore. Okay, just a few seconds. Sorry. Oh, now. So you can see just this coagulum, and we will suck it out, and no active bleeding. So we already discussed S-point, and Misha told you everything about it, but I will not discuss it much further. But I think that this is a nice video showing where the S-point actually is, and that in a patient in local anesthesia that it would be quite difficult to find, because what you need to do is to lateralize the septal intumescence. So maybe in some patients that cooperate well, it would be feasible. So thank you for your attention.
Lenka, thank you very much. Any questions? We have to speed up a little bit. Okay. So Lenka, thank you again. Once more. You can go. Thank you.
There are any questions?
Very nice lecture. So somebody is sleeping over there, so I need to wake up. Some of you bleeding from the internal carotid artery, the last thing. It's a topic, and it is a nightmare for endoscopic surgeon to have this experience with that. But it's rare. In the literature, we can find that only 29 cases are described in sinonasal surgery. A little bit more, 1% in pituitary surgery. And if you look at the skull base surgery, it's almost 10%, so more. It has terrible consequences. It's clear. So I would like to show you a case report. It's a 79-years-old woman with partial opacification in a sphenoid sinus. Here you can see a little bit more on the right side with destruction of the bony wall of the sphenoid. The patient was indicated to biopsy, and what's important, she has a history of breast cancer. So surgery was performed by younger colleagues, younger residents at another operating room. I was on another operating room doing standard FES procedure, and I was called to the operating room that they have a problem, or they had a problem. What was the first their mistake? They didn't record it, what they did. So we started recording, and that's what we saw. Blood everywhere. So it was mononostril approach. So what to do? We have to pack immediately to have a time for another solution. Definitely you have to discuss it with anesthesiologist. It was, I don't know, 3 minutes to pack it and stop bleeding, and it was 2.5 liter losses there. So now we can see. This is a very stressful situation. So you should have a list what to do and a bleeding from internal carotid artery. So we ask second scrub nurse to assist us. Wider and another suction beneficial is to have rinsing system on your endoscope and put packing. Then you have to call endovascular team, angiologist. They prepare for definitive solution, definitive treatment. You have to harvest the muscle. Depends on you. If you take it from the neck, we usually prepare during the skull-base surgery umbilical area for taking fat there. So it's prepared, and now you can see we remove the packing and bleeding is continuing, but it's sucked by from the other nostril. And we put the muscle over the injury. Then we put glue, Flow-Seal then, or Surgiflo, and we transfer a patient to the endovascular treatment. Usually the stent is used. So how to avoid this terrible complication is to know anatomical situation. Here you can see the course of internal carotid artery around the pituitary gland or sella turcica. Beneficial is to have an MRI during skull-base surgeries. Meticulous technique, if you around carotid and there is a tumor, what was, I think, wrongly performed here, we use grasping instruments for taking a biopsy. And I think that it should be better for if we use cutting. We use cutting, okay. Lenka told that we use cutting, okay. And you can use Doppler for orientation and you can find where the carotid artery is. Study anatomy, if you can see this subsepta which goes to the internal carotid artery is beneficial, same as here. An MRI, this patient, the carotid is at the center of the tumor. We knew that, but image guidance system, as I told, even in this case, which was considered like easy case, but it wasn't, is beneficial. But even if there is no tumor, you can see that sometimes the bony wall of the carotid is very thin. You can see pulsating carotid here. Here is an optic nerve. It's a right sphenoid, the sella and carotid. And if you try twist this subseptum, definitely it will lead to the terrible consequences. So think about indication because anything can happen at any time. And prevention, knowledge of anatomy using navigation and proper surgical technique. And what's most important is to have a plan how to manage this terrible complication. Thank you for your attention. So I think that we can close this part, this session. What I have to is the winner of the book, who is?
I have one question. Can you show the first CT of the patient? It must be a very stressful situation. I have no experience. I remember only Professor Stamberger. Maybe you met him, and when he had lecture about this experience with internal carotid, the first was that they had lecture. He performed the operation with neurosurgeon, and they were speaking English. The first was that they shift English into their born language. The first word was Scheiße. And then they do something, I don't know the result. So it is really very stressful situation. I don't want to prolong the discussion, but what was the indication? The patient had headache.
Headache and strong headache.
Strong headache.
Strong headache, and definitely it's a lot of these patients we perform biopsy from it's a neurosurgical indication, like yeah, and a lot of these biopsies we performed, and it's a possibility to put this patient to the radiotherapy and make their life better.
The shape of sphenoid. Can you say some information? Is it okay or easy? Where should be?
I think yeah, it's a easy sphenoid. It's septated a little bit, one more septum than it's normal. And what else here? If you look at the carotid, here is yeah, it's a thick bone after, but the problem is here, yeah, that here the carotid, and we knew that. But we...
You mentioned that you used cutting instruments.
I don't know
what is your recommendation?
I think I can control what I cut. So for me, it's better cutting instrument than grasping instrument, because with grasping you can't control what you do. My opinion.
Cutting instrument was definitely used because this is one of the surgeries I will never forget. The problem in this patient, what made the management of the bleeding more complicated, was that it was considered easy surgery, and we decided to perform only mononostril approach. And that means a very narrow corridor for the management of the bleeding, because we thought that it will be easy surgery, and well, it was. We opened the sphenoid, and I took some biopsy, and my colleague from the neurosurgery has said, take more. And that's when it happened. The problem is that the carotid artery itself, we were far from the carotid artery, about 1 centimeter. We checked it with image guidance, but the problem was that it was invaded by the tumor. It was a metastasis of the breast carcinoma. So it was invaded by the tumor. We didn't know that. And what we discussed with the neurosurgery later on, that in such cases where the internal carotid artery is invaded by the tumor, that we should perform angiography prior to the surgery. Maybe it would help, maybe it would not, I don't know. But after we performed angiography, the carotid was totally obstructed with our nasal packing. That means there was no bone, it was totally invaded with the tumor. So once we packed the sphenoid, there was no blood flow through the carotid. So we performed no stenting because there was no place to do it.
But we saw it on MRI before surgery, I think. Okay.
Yeah, I remember one case from November 1997, the same procedure. It was a cleavage tumor, and the neurosurgeon said to me, yeah, you have to take a biopsy. That was in the beginning from the MRI angiography. And they said, yeah, we did an MRI angiography, not the DSR, so not this, you must not do it, that's not the artery. So then I did the biopsy, and I wonder how the blood goes out through the wall here. And I had a bad feeling during the operation. I said to my resident, you stay here with the tamponates, and if the bleeding comes, you have to put all things in the nose. So that was what we done. It cost me 1 year of my life, really. And then we put them to the angiography, and they said, no, we cannot stupid. Then I wait, do a Belloc tamponade before. Then I put, then take muscle here from the upper thigh, yeah, and bone from nose. And then I put outside and very cautiously, and I put the muscle inside, fibrin glue, and I blocked it with a bone, the sinus, the orifice of the sinus. And this woman lives today, but it was awful situation, and she got necrosis in the columella at the beginning, because we think about what could we do with this tamponade, and I say one day I said we have something to do now, and we did it, and it was the end was lucky, but it was stress every day. Yeah. 1997.
Thank you for comment.
When I hear it, I think that neurosurgeons are responsible for it, because in your case, they said take specimen. Yes.
Outside, yeah.
Yes. Okay. And what is your recommendation for people doing this surgery?
Yeah. If your new surgeon comes to you, you have two times. The second was the same. I can say you first MRI, CT, and angiography, CT angiography. And if you don't, and speak with the radiologist.
When the situation is, yes?
Before. All the diagnosis you can get before, take a biopsy in this region.
It was a similar situation. Professor Lipina, who is head of the Department of Neurosurgery, came to us and asked, is it possible to perform it in your operating rooms without navigation? No, Radim, that way. And I didn't know that it will happen. Yeah. So sometimes they are dangerous neurosurgeons. That's the result. Okay. Okay. Thank you. And anybody wants to have from Czechs?
Who was the most active?
Most active was Doctor. I don't know.
Where you are from?
Yeah. I'm from Prague, from Motol.
From Motol. Doctor?
Radek is the first name and Pavel is the last name.
Radek Pavel. Dr. Pavel.
Yes.
And
second was a colleague from Germany, but he doesn't want Czech book. So who wants? He speaks Czech? Okay, perfect. Thank you.
He will study Czech language. It is very important language. Easy.
Okay. Congratulations.
So now we have approximately 15 minutes break, and then we have start last hour session at 4. We have 1 hour. Thank you.
you want to have biologics? Yes. I will give you biologics.
So, dear colleagues, we start our last session. Biological therapy. It is therapy me personally, I don't have experience because it is doing by Petr and his group, but I think that it is therapy that probably in near future can change our approach to chronic rhinosinusitis. Achim, I would like to ask you for the first presentation.
Yeah, thank you very much. Yeah, excellent, yeah. I'm just a bit flabbergasted because of this slightly different floor that is actually a famous church in Münster in the evening hours, and you know we are getting to the evening, so a most appropriate slide. With regard to biologics, I have to list the conflicts of interest that I had the pleasure to participate in several of those phase 3 studies which led to the possibility that we are now able to prescribe. And because I've done that for like Novartis and GSK and AstraZeneca and Sanofi, I have a bias, but towards all of them possibly. And I'm also co-author on one of the papers I'll show you later, and the EPUS 2020. Now, the background of biologics is the idea of endotypes being associated with chronic rhinosinusitis with nasal polyps. And actually, because the polyps attribute to the fact that 80% have a type 2 inflammation, it's allowed for us to prescribe dupilumab, mepolizumab, or omalizumab for this group of patients. And that's the background with the 80%. And as you can see, there are several biomarkers, including, but not limited to, IL-5, total IgE, eosinophil cationic protein, which have been attributed to being a type 2 disease, so being mediated by eosinophils. So to put it very short, if you have got polyps and you have got eosinophils, you have most likely a type 2 inflammation, and then you may think about using biologics. And another factor is mentioned in the upper right area, that's asthma, bronchial asthma. Okay, and there are other diseases, including atopic dermatitis or eosinophilic esophagitis, which are also mediated by this type 2 disease. Now, the Euphoria put forward the first step to define who is actually suffering from chronic rhinosinusitis with nasal polyps in such a severe state that it would be justified to spend yearly treatment costs for Germany of about 15,000 euros per person. And because this is an unlimited treatment, so if you want to treat them, you have to give it year for year for year, and the patients are about 40 years of age when you start it. You have 40 years per patient per 14 or 15,000 euros, so quite a bit of money. And the idea was that you need to have a significantly impaired quality of life, loss of smell, because that's the most sensitive symptom of a severe disease, asthma as an indicator that you have a type 2 inflammation, which is in a way doubling up with this one, and you have had systemic corticosteroids before 2 or more courses during the last year. And now, then we got the phase 3 studies for dupilumab, and we got more experience, and that's why in Germany we put forward a guideline, actually. And I'll try to get you through the guideline despite the fact that it's Germany, because with, you know, talking with a few of you guys in between, I became aware that you are able to prescribe biologics. Now, what is in-label or off-label? In-label is severe chronic rhinosinusitis, so it's not for somebody who just wants to have a treatment, but they should suffer. It's only for adults. They have been continuously on intranasal corticosteroids, and with this setting, they have insufficient control of their disease. And there's a difference for Germany that for omalizumab, that's it. So intranasal steroid spray, steroid drops, you are unhappy, you go to your doctor, and then he may prescribe omalizumab, whereas for mepolizumab or dupilumab, you have had either systemic corticosteroids or previous surgery with recurrence of polyp to be in label. Now, so that's the minimal data set that you need to have. And then the second part in here is about the question how you define severity, including the size of your nasal polyps, or nasal polyp score, or that the polyps came back after surgery, or that you had systemic steroids, or that you have ongoing symptoms, like with a SNOT-22 score, or that you have a total IgE, which actually allows you to use, for instance, omalizumab. So that's the second thing to document why it is a severe case in this specific situation. And then, because the people thinking about the guideline are actually doing surgery as well, and you know, surgery is cost effective if you think about 2 years after the surgery, and we are currently paying for one sinus surgery about 2,800 euros, so less than for biologics. The idea was, well, are there patients where we want to actually be able to offer biologic therapy? Yeah, and we thought about an 85-year-old chap having had previous skull-based surgery and having, you know, 2 heart attacks and 1 stroke or something like that. Nobody would like to do another sinus surgery for this old chap. Okay, and that's why we came up with ideas to introduce a significant risk of the operation. So using the New York Heart Association classification, or skull-based injury previous, or a risk for systemic corticosteroids, because they may be helpful for a time, including diabetes mellitus or thrombotic problem, or another time of type 2 inflammation. So all the conditions, including asthma, atopic dermatitis, and so on, that I previously mentioned. Then the non-steroidal aspirin intolerance, to put it short, okay, as another point, because you know that the polyps may recur. And then you can also put forward how much systemic steroids you have used, or whether you have used aspirin deactivation, or how fast polyps reoccurred after surgery to come back, and as markers how many absolute numbers of eosinophils you have in blood, or whether it was graded as minimal, moderate, or high in any histology report. So we put that together, and we try to stress the fact that, you know, we want therapeutic freedom, especially if there's a severe risk associated, and to be able to use that also for the documentation, because people will come back and you need to prove that actually the treatment is effective. You need, for instance, know this type of classification, showing you from no polyps to large polyps with complete obstruction of the nasal cavity, what you need to write down at baseline, and then in our world 6 months after beginning of treatment. Now currently in Germany we have 80% being prescribed dupilumab, so only of severe chronic rhinosinusitis, okay, to make that sure. The other ones are being operated on or whatever. And about 11% being on mepolizumab, and about 8 being on omalizumab, and 1 percentage is on other. And that's, for instance, tezepelumab and other stuff where we have something with the pneumologists going on, and there is more to come. So that's probably like the early runners or stuff like that. And they really make extremely happy patients. So that's why I, in general, would like to encourage you within, you know, economic reasonable limits to use this new technique in your patients. Now, if you prescribe, you also have to be aware of side effects. And for instance, dupilumab, because it's such a large market share, may result in conjunctivitis or hypereosinophilic findings or joint problems. And normally that doesn't lead to discontinuation of the treatment. And I put down a few strategies for you guys how to work with that. And the most problem one is probably the deterioration of asthma and increased eosinophils in the blood, where you may consider systemic steroids to be added on, or even a stop of the therapy. In contrast, omalizumab is quite long on the market, first approved by European Medical Association for Asthma in 2005, may have something which is called a serum sickness, and that leads to a deterioration of the quality of life. So the patient feels like having a fever or infect, and it starts normally like on the next day after the injection, and it gets gradually better. So if they tolerate it and you can keep them on the stuff, and because omalizumab is injected every like 2 or 4 weeks, and you explain, look, yeah, that's associated, but keep on the good stuff if you think that the overall treatment effect is beneficial of you. They stick to it, and then it gets better again. However, you have to be observant and ask about, what do you do on the next day and the day after. And because it's more than 12 hours after injection, it's certainly something that comes across not while the patient is in your outpatient department. Now, we like to use the biologic as in home use, so that the patient is actually able to use it, the syringe or pen, by themselves. And the advantage is that we don't see them every time they need to have an injection. The disadvantage being we can't observe them. And obviously we need some kind of another informed consent regarding how you use it in storage, so no freezer. Okay, how long am I allowed to have dupilumab outside in this kind of temperature and stuff like that. And then in Germany, we need to speak about the language barrier, because if the patient isn't able to get the emergency up and running, then we can't get him into home use, because nobody will be there if he has an anaphylactic shock. And all of those biologics are proteins, and so all of them can cause an anaphylactic shocks. And there are not all of them, but some are available as a syringe or as a pen. And the syringe has the advantage, if you have a feeling that it burns, you can make the injection very slowly, so that's why this is preferable for patients suffering from this burning sensation. Or if you don't like to see a needle at all, then you may go for the pen. And obviously they need to be trained, because otherwise they will make incomplete injections, and then they won't get the dosage that is supposed to be for them. That's extremely important for omalizumab, because omalizumab changes the amount of dosage appropriate based on your total IgE level and your weight. Now, the results of those 3 studies say currently that because we don't have head-to-head studies, we can't say which one is best. However, the head-to-head studies in Germany are underway, including like the Everest study comparing dupilumab and omalizumab, and there are also subgroups available where you have had a treatment failure, for instance, with omalizumab, and where you can say that omalizumab has a problem if you have severe eosinophilic comorbidities. And now on the other side, dupilumab is able, especially in times of also asthma, but also smell dysfunction, to improve the complete situation. Sorry, there were more lines down there. I don't know what it did with a PowerPoint. Anyway. And to turn the table around, mepolizumab in the phase 3 study actually reported that the likelihood of working is higher if the patient is suffering from comorbid asthma, being not from the US, and having more than 150 blood eosinophil count, or even more than 300. So if you have a look at those specific markers, you may detect where the likelihood of mepolizumab working is higher. So, for instance, absolute number of eosinophils. Now, the effects seem to be slightly stronger based on a network analysis for dupilumab. So, and that's the reason why the market share is highest for dupilumab. But dupilumab doesn't come with a specific monitor to the best of current literature. We put forward a kind of algorithm which is slightly complicated, and that's why I put it down in this table, saying that if you have, for instance, a young female patient thinking about getting a child, for safety reasons you only have data with omalizumab, so that may result in prescribing omalizumab, sorry. Then you have to ask yourself with total IgE whether you can actually use it, because there's a subgroup where you can't use it. And if you have small polyps, because the mean polyp size diminishing by omalizumab is smaller than for dupilumab, and mepolizumab in certain conditions, you may end up with omalizumab as well. And because it's also prescribed for asthma, that's another point in favor of omalizumab. Mepolizumab, I already told you about eosinophils. It's also for asthma, and it's for hypereosinophilic syndrome and eosinophilic granulomatosis with polyangiitis. So whenever the eos are high, okay? Just to sum it up. So that's a really nice thing because it makes things quicker. You only have to have a complete blood count. And now if you have a low total IgE, and that means omalizumab isn't helpful, and you have low eosinophils, so mepolizumab isn't helpful, and you have large polyps, or you have atopic dermatitis, because that's also a possible prescription, so you will treat skin and chronic rhinosinusitis simultaneously. And now extremely new, I think about 6 weeks old, eosinophilic esophagitis is also approved for dupilumab. So those would be points to be taken into account, and with that, based on the literature and real-world data, the success rate is about more than 80. In Münster, with taking those points into account, we are currently at 93% success rate, meaning based on the UFIR criteria having, some kind of objective or subjective improvement. The problem with the effect is, how do you measure it, okay? And there are put forward these evaluation criteria, and if at least one criteria is fulfilled, so you feel better or the polyps are smaller or you have a better quality of life or whatever, then you're allowed to go on after 6 months of usage. And that's why you actually need to see the patients again, and you should control them even after the time point, because we know that there are antibodies built up against those biologics in about 3 to 5%. However, we don't know whether these antibiotics actually lead to a diminished effect of, for instance, dupilumab, omalizumab, and so on. And that's why we need to follow them up. And there's a subgroup of falling out so immediately, okay? But there's also people who after like 2 or 3 years have like diminished effect. And that's where you want to, be alerted to and then realize, okay, should we change something or not? Obviously, if you make fancy research regarding, all kind of cytokines into tissue with all those interleukins, you'll end up having, more impact on what you do. However, that's not going to happen in normal practice. That's for like university ebony tower type of thing. Nevertheless, it's nice to know that EL4 and 13, which are the cytokines attacked by dupilumab, are, for instance, possible monitors as well. Yeah, and other more. So to keep the long story short, and because I was afraid of taking too much time, it's only a question of severe chronic rhinosinusitis, and we have some labels from the European Medical Association, EMA, when we are allowed to use it, and there's a difference between omalizumab and the other two. However, in principle, we use surgery as a filter. So we put them on nasal drops and nasal spray. If it doesn't work, we do surgery. Okay, and we do have to have a real good reason why we skip the fact with surgery, because surgery is cost effective within the first 2 years, and also while polyps may come back after surgery showing recurrence, the polyps normally are not that big, and by this you eliminate quite a few patients out of the whole who have had sufficient benefit from surgery and avoiding, an unjustified increase of costs. The label means that you need to be able to improve the quality of life. The problem is because quality of life in SNOT 22 measured is as only point possible to prolongate the administration, that you actually could do a placebo treatment. Okay, patient feels the syringe is helpful, so we just score the way that the doctor gives it to me again. And that's a problem which we as a research community have to solve. Next thing is we do this on this orange type of piece of paper because our patients need to have the documentation available. If they come from Münster and go, for instance, to university in Ostrau and then they want to continue their treatment, okay, or within Germany. And that's why also between like private practice and university, we need to have a better exchange of data and a standardized way of reporting. And always pay attention to the need to evaluate the efficacy of your treatment, because some groups will skip out. If you follow, for instance, mepolizumab and the asthma indication, there's a subgroup after 2 to 3 years who experience a deterioration again, and then they will skip to something else. Having said that, for my patient, mepolizumab, no problem currently, but it's the youngest indication of all those three. And with that, I hope I've given you, you know, just a boost of information. I'm looking forward to your questions or also the impression from the other colleagues. Thank you.
Thank you for a very nice lecture. Do you think that it is necessary to perform some other studies where you want to identify effect of this biological? Because I think that in USA, I think that calculate everything, and they had to calculate it, and patients in USA are similar to European patient.
Yeah, well, I think they're not similar, because they have different like Caucasian descendants or Afro-American type of thing, and there are probably differences. And also in the paper Bahan regarding the synapses study, mepolizumab, they had a look at whether different like gene type of things, okay, to put it that way, has an impact on the treatment. And yes, for sure, we need to put together more data and make more like analysis regarding real world data. And that's why quite a bit of stuff is coming around the corner where everybody puts together, you know, the success rate, okay? And the one of the things that the companies are currently looking at, and some companies not so hopeful, is whether there is a first or a second line treatment with regard to the biologics, okay? You could say if one biologic is in 80% used, it's like the first line treatment. However, as I try to point out, there are facts like young females, you know, wishing to have a child, where you don't have any data for dupilumab in, you know, pregnancy and stuff like that. So yes, we need more data, and that's why we have a phase 4 study running from Sanofi and all the other ones, collecting data especially to this regard, and, you know, looking for like pregnancy and adverse effect and stuff like that. So yeah, and there's lots of more coming around, but also we as a university should put together our data as well.
You showed a list of criteria for this therapy. It is allowed in Germany to use this therapy in all offices, clinics. If the patient fulfill all these criteria, can he prescribe? Because in Czech Republic now were created some centers, and they are allowed to prescribe this medication, no other.
Yeah, no, in Germany, generally, if you're a doctor, you're allowed to write out a prescription. That's something you're allowed to prescribe, so in theory, yes. In practice, it's so that some health insurance companies are currently going into their data and looking who has written a prescription for this drug, because it's so expensive, and then they try to not pay you the amount of money, which we call regress, so getting the money back, stating that you haven't followed guidelines or whatsoever. So that's something which is under development. But presuming that you are able to fend off this kind of attack, yeah, you're allowed to, and there's no need to ask the health insurance first. But Jürgen raised his arm, I think.
Yeah, what you said is okay, Achim. We do this, but we are 5 practices. We concentrated in one practice, so that we do always. We have in our system. We work with tablets. There's a snot. They have to take a snot. We do a lung function test, and we do always video endoscopy at every visit in the practice. That's the best thing, and they have to say, yeah, then the snot and the subjective anamnesis, what they said, is it better or not, and smelling test, that's the same. What we always, this is the 4 things we do in every visit in the practice, and if is there a little bit of change so that the polyps begin to grow? Sometimes we see this, as you told, then we stop it at once, and. That you see, we can prescribe it, but I can tell you in the beginning, when this drug comes on the market, I was shivering every time when I have to sign this reset, because it's so expensive for an ET doctor. Normally, pneumologists, they have a high level of budget, but we don't have very low budget.
And what we also often see in our practice, and you will do the same, I believe, many doctors are still very afraid of prescribing it because of the regress calls from the healthcare insurance. And my father just mentioned the pneumologists. They often say, well, we can do this, go to the ENT doctor, they can do it, they have more money. So it's a sending them back and forth, and I don't think there's too many centers, especially without, I guess, university hospitals, but I think the others are a little scared still.
Well, it's in a way getting more and more prescribed, and patients start to wander off into, the surrounding area. And there are a few who do it in a way that we start the treatment as a university and putting the indication forward, and then they take over after, for instance, 6 months, and then from time to time they send them back to, that make us certain that it's still justified and stuff like that. Actually, from a medical legal point of view, that's not my opinion, but the one of my family, you're not safe if you do it this way. However, from a psychological point of view, you at least can put forward the letters sent by university of something, and that may be helpful, okay? And the health insurance that I came across is Viva Active, just, for you guys. So if you have a patient, just kick him out, okay? No, funny. I think we'll get there. The positive thing is when you look at dermatologists and allergologists, the mean amount of money spent per every 3 months in dermatology was significantly raised for all private practice after they introduced dupilumab for atopic dermatitis, okay? So it has the potential to improve the situation in private practice if everybody has 1 or 2 patients prescribing it. So 1 or 2. There's a practice in Krefeld, and they're praising themselves for currently prescribing 40 patients with some kind of, biologics. And I think, well, they should be really looked at. And I know that there have been, regress, so negative feedback to private practices as well for people who weren't, paying attention to the fact that you actually need to document that the patient has polyps. Without polyps, you're out, okay? And these are basic rules. So nevertheless, for somebody wanting to transport the documentation or helplines, including smell tests, and so this piece of paper may be helpful for you to justify why you prescribe this to this patient and not to the other one.
Any questions?
Yeah, there's.
Maybe one little question. When considering the indication of one of the preparate, how did you figure out that cutoff value of 750 absolute eosinophils to indicate MEPO?
In the Synapses study, there are subgroup analysis about 150 and 300. And whenever we use dupilumab in 750 and more, you get a transient eosinophil increase, okay, going to even 1,500, and that's why we stopped using dupilumab at all at this point. Okay, it may well be a transient phenomenon, but we have several patients looking every 3 months, taking a complete blood count and staying on this high amount of eosinophils for more than a year, and that's where I personally get itchy. Okay. I didn't like it at all, because we now have switched some of those to mepolizumab, even in the indication of hypereosinophilic syndrome. And I'm not saying that one is causing the other, but I'm not liking to risk somebody to get him into an hypereosinophilic syndrome. And because we only had those problems with patient being on 750 and more, we are stopping there and all of those getting on mepolizumab. And they are doing really nicely. Okay? But it's not too often as well. Well, it was, yeah, idea. It was, you know, we are monitoring all our patients. We have currently about 160, 180 somebody on biologics. And by this, we can, you know, analyze what's going on. Yeah.
Thank you. We can continue. I would like to invite Honza Vodička with his lecture.
I would like to thank Achim for this lecture, because this value is also for our department interesting point or cutoff point, because we also experience some hypereosinophilia, as Zdeněk told us. My main focus is on the sense of smell again, maybe. So we all know that there are some limits of surgery, so I first of all will show you some cases where when we were not just really successful with surgical treatment, and this is again this aspirin intolerance and also asthma and chronic rhinosinusitis with nasal polyposis. There is another comorbidity except asthma. We, as ENT specialists, we can follow up patients with eosinophilic otitis media, which is also, or which this disease can be also treated by biologics. So you can see that this patient, when she went to surgery, she had a huge amount of nasal polyps. Then the surgery was without any big trouble, but we also found in part of polyps here that there was a respiratory epithelioid adenomatous hamartoma, which is also a diagnosis which was not mentioned today, but sometimes you can see it. And finally, we couldn't reach really good olfaction. So you can see it here that that threshold was 0.5 at the beginning, at odorized markers test 0 point. Then after surgery, 3 points means that she still has anosmia. And you can see that also with the middle turbinate resection, but still there is some swollen mucosa. So the next step was to put her on biologics. And finally, she had olfaction back, so she was a normos mix. And this was she was on dupilumab, this lady. And another lady was on mepolizumab, so again to prove that both treatments are helpful. She also underwent surgical therapy, but because the sense of smell was very bad, so first of all, the surgery was helpful, but if you see after half a year, she was against anosmic, so she decided to take orally prednisone every day, and she was a young lady. So then we informed her that she could be treated by biologics. She had quite high eosinophilia in her blood, so then we decided to mepolizumab. And the effect on sense of smell was very well as on other symptoms. Also in this lady, we also treated very well conductive hearing loss. Only to point to omalizumab, we can prescribe it in Czech Republic, but we have no support for omalizumab. And we have quite very good support for these two medications, and we have quite good experience with it. So I am not aware of anyone who is prescribing omalizumab in ENT indications. I wouldn't go through all these just publications about olfaction, especially on dupilumab, because this was the first available medication for chronic rhinosinusitis with polyposis. It was, even after 2 weeks, there was clearly visible that it works on olfaction in average. Also the proportion of people with anosmia just decreased very well. But it's important to look at another picture, another table. What is important that from 80% of people who were anosmic, 29% still are without sense of smell. So it's we cannot imagine that all people will have normosmia or at least hyposmia, but still 30% of patients will stay with anosmia. Considering mepolizumab, in their study, there was no psychophysical test like APSIT in this situation. They had only visual analog scale measurement of olfaction. We have data from register in the Czech Republic. These data are quite old now, so we will have very soon, new data. So these are from November 2023. And I focus only on anosmia because we have a lot of interesting things, but this was very interesting for us, that this is week 14, this is day 0, week 14, and this is 1 year after treatment, 2 years. The thing is that enough patients are after 14 weeks. So you can see here that 2/3 of patients on dupilumab will improve their sense of smell so that they are not anosmics. Compared to mepolizumab, it takes quite longer period to reach better quality of sense of smell. But on the other hand, we have only 8 patients here, so we are really expecting the data from our register. So from this picture, you can see here that dupilumab is more effective on sense of smell than mepolizumab. On the other hand, there is really bias, so we put on mepolizumab a little bit different patients. So we still expect the comparison of the data. Another thing for us, for surgeons, is another aspect is that if we compare patients who just undergo 2 or less FES, or patients who have 3 or more than 3 FES, then we can see that patients who just undergone only 2 or less FES improve their sense of smell rapidly and better than these patients who were repeatedly operated. So again, maybe these were worse cases. So there is again a question of bias, but still we can see that when there are 1 or 2 surgical treatment for chronic rhinosinusitis with polyposis, considering anosmia and smell, it would be recommended to put them on biologics, because increasing the number of FES means that you can lose your sense of smell forever. Okay, so I can go to conclusion. So we think that biologics are highly effective in olfactory loss, and especially dupilumab. What is important, because it has to be cleared for the patients, that not all of them will respond to treatment. So some of them, as I said, 1/3 can stay anosmic even if the treatment is effective for nasal obstruction and other symptoms. And repeated surgery, I think it will be more and more difficult to do surgery in chronic rhinosinusitis with polyposis because of risk of orbital damage or frontal base. If we indicate repeated surgery, the patient should be aware of biologics. So thank you for your attention.
Honza, thank you very much, and I would like to continue now with other lecture. It's fantastic that you have data of one patient and for a long time that you have results of these questionnaires and so. We can discuss it after this lecture of Jakub Lubojanski from our clinic.
Good afternoon, ladies and gentlemen. I would like to talk a little bit about the questionnaires in rhinology. So if you think about nasal symptoms, sometimes it can be difficult to measure them or to put them in some sort of scale. If you don't have a rhinomanometry in your office, it's difficult to say how big the obstruction is or secretion or pain. It's difficult to put it in some sort of scale. So it will be beneficial for us to have something, some tool that can help us objectify these subjective problems of the patient. Some tool that can help us, let's say, when to indicate a surgery, when there's a deviated septum that it's not very much deviated, it's just a little bit deviated. Should we go for the surgery based on what patient says, or do we need another tool to help us? Or another example is indication for biologics. It's indicated for severe disease, a patient with severe disease. So how do you put the quality of life into some sort of a scale? Well, we have a tool for that, and it's a questionnaire. So let's talk about some of them. We use them every day in our rhinology practice, and I will talk about each of one of them. It goes like this. The patient comes into the waiting room, and nurse will hand him the questionnaire, and he will start filling the questionnaires. So he has something to do in the waiting room, so he doesn't complain about the waiting time. And even before we see the patient, we already have the results of the questionnaires, so we can prepare what's going on with the patient just by looking at the questionnaires. First one, in Czech language, you called it Rhino-VAS. In English literature, it's just visual analog scale, very basic. 0 means no problem, 10, I cannot live anymore with my nose. So it's very good just to have as a first glance about the patient's issues. Very useful for, let's say, chronic patients. When you see them once a year, you just look at the questionnaire and you know, okay, it's going to be fast checkup or something worse. And next one is nose score or nasal obstruction symptom evaluation instrument. This one is a little bit more complex. It focuses on nasal patency. And you have some questions about congestion, nasal blockage, but also trouble sleeping. And you have a score that you multiply by 20, so maximum is 100. Next one is SNOT 22. This is a questionnaire that gives you insight about the quality of life of the patient, but it's focused on patients with nasal symptoms. But not only nasal symptoms, it also counts like earfulness, dizziness, or sadness, embarrassment. So it's like more complex questionnaire. And this one is also one of the indications for biologics. SNOT must be over 40 points. Just be careful with this one. Some patients, especially with chronic rhinosinusitis, they have 4 polyps on each side, and they score SNOT 22 like 15, 20 points. And you ask them, how is that you score so little points? Not because I'm used to it, okay? I lived with it like 20 years, so it normally doesn't feel that bad for me. So sometimes you have to instruct the patient to be critical about the nose and to answer properly. Next one is not really a questionnaire, but it's a very useful tool that you can have in your office. I wouldn't say it can substitute rhinomanometry, but it's a good tool to have to compare before and after treatment. It's called nasal peak inspiratory flow. We had it in our presentation, the cases of the patient. It's called, shortenly, it's called NPIF. And you can also use it in the waiting room. So you just put it on the patient's face, and he inhales as fast as he can through the nose, and it gives you the peak inspiratory flow in liters per minute. It's not as complex as rhinomanometry, but it's very fast and very cheap. And here I would like to show you the usage of the questionnaires on some case reports. First one is patient 49 years old, and he had several years problem with nasal patency on the right side. You can see the endoscopy. There's just like a little bit of septal deviation, like this septal spur. He had no problem with nasal secretion, no nasal trauma, and he had local corticosteroids for years with no effect. The NPIF, or the nasal peak inspiratory flow, was 100. I forgot to say the norm is around 150, so it's not that bad, but not very good either. And in this case, the patient, actually, he wanted surgery. I didn't want it so much because I wasn't sure if it's going to help him very much. So we did questionnaires, and the questionnaires kind of put me towards the surgery because his quality of life was, let's say, bad, and the nose score was 75 out of 100. So we did the septoplasty, and as you can see, 1 month after surgery, everything improved. So it's another good example of why to use questionnaires, because you can very easily see the result of your work in numbers. And the second patient, it was a woman with nasal obstruction for 2 years. She abused decongestive sprays every day. Her NPIF was very low, and she also had local corticosteroids for months with no effect. In here, there's no hesitation about surgery. You don't really have to think twice about turbinoplasty. Here are the questionnaires before the surgery, 80 out of 100, no score, 61 points, SNOT 22. So we did turbinoplasty on both sides, and 1 month from the surgery, she's not happy. She's actually thinking about complaining that the patency is a little better, but not ideal. But she was complaining only until I showed her the questionnaires after the surgery, because they all improved. Okay, so she forgot how bad it was before the surgery, and she expected that it's going to be 100% after the surgery. And when I showed her the questionnaires that everything improved massively, she calmed down, and from that point on, she was okay. And actually, she's a lovely patient. I see her once a year, and she's very happy. And last one, we don't use this one very often. I saw this one in Switzerland, because they do, Professor Simon, they do a lot of cosmetic surgery, like septorhinoplasty and also blepharoplasty. And they use this body dysmorphic disorder questionnaire to identify patients who will be always unhappy with your surgery. Yeah, because in these patients with body dysmorphic disorder, it's not that the problem is in the crooked nose, it's in the patient, okay? It's a mental disease. So this patient will be always unhappy, it doesn't matter how good the surgery is. And they have this body dysmorphic disorder questionnaire, and by 4 questions, they can identify the patient who will be always unhappy. And for these patients, they have a special date for the surgery, and usually it's 4 years from the day that they see them in office. Yeah, so they will probably not operate on them. So to conclude, questionnaires in rhinology are a very good tool, rapid measurement of subjective complaints. You can see very well effect of your treatment. It's inevitable for indication for biologics, and sometimes when patients are not very happy, it's also very good legal support for you. Thank you for your attention.
Jakub, thank you. Any questions? What about situation in Germany? I start with Tanya. Do you use questionnaires?
Yes, we use the SNOT.
In all patients? Mm-hmm. In only special group of patients?
All of the patients that come into my rhinology outpatient clinic, they all get the SNOT 22 as soon as they enter the waiting room. We also do the VAS.
On paper, or do you have
paper.
Computer?
No, not yet. We're planning to, so hopefully next year, or I don't know. But still, it's paper. So they all get it on their first appointment, and all the biologic patients get it whenever they come in for reappointment. So every 3 or 6 months. We do the VAS score as well. So it's not the Rhino VAS, but something very similar. We don't do the nose score. Yeah, because there's a bit of, also in the literature, the question is if it's how reliable it actually is, the nose score. Yeah, so we do the two.
Achim.
Yeah, I'm extremely proud that since like the 1st of February we have an iPad solution. And we gave the iPad with like the SNOT and visual analog scale and some other stuff to the patient. And the first reaction was, well, I used to do this on paper. Why do you start now? You should have started 10 years ago. And I sent this patient to our IT department because they took about 2.5 years to get there. But nevertheless, we have it. Only
in all rhinologic patients?
In all biologic patients. Because that's like a certain defined set of questionnaires. The other ones, so rhinology patient, they get paper-based questionnaires. However, it's not the same pack, and it's different type of things. And that's why that's still paper-based. Okay, IT wouldn't be able to differentiate also.
Patient before septoplasty.
Yes.
Also.
Yeah.
Before turbinoplasty.
And there are only so few. I'm not sure. They're supposed to be there. Yes.
Before endonasal
anything. Yes. Yeah. And skull-base surgery and whatever.
What about Pardubice? Nicole Koblasová. Hradec. No. When I say Pardubice, I think Hradec. Nicole is here. Yes. So.
Well, in Hradec Králové, we do the questionnaires on patients with biological treatment also. And then before the endoscopic surgery and the surgery of the septum. But we don't...
In all patients?
Yeah, all patients. Yeah.
Yes.
But we don't do them on turbinoplasty doing on all patients. Like in local anesthesia, we don't do.
What about Praha, the most active doctor here? What about Praha?
It's almost, yes. I'm sorry for that. It's almost the same situation. They have the SNOT 22, and sometimes we use the VAS, Rhino VAS.
Yes, so you are able in all patients, before and after rhinologic operation, you can compare these questionnaires. Yes. What about you?
We have several tablets in the practice, so we since 1.5 years, every patient who gets biologicals, he put every time he visits in the practice. That means in the beginning every 3 weeks, and afterwards every 3 months they got the tablet with a SNOT, and we only look at the score. And the score is going down, it's okay. If the score is not going down, you can see it on the PC. It's very easy to control. But all this paperwork with this was awful because no one looks at the scores, no one looks at what is written there. So since we do it now with the tablet, it is no problem. But we have many tablets in the practice, and all patients get all the questionnaires in the beginning. When he comes in our practice, different questionnaires. All of the tablets. They have enough time when you're sitting in the waiting room.
You introduced last year or 2 years ago your computer system. It was fantastic because if you go to Jürgen, you have to fulfill many questions by computer at home, not in waiting room. Yes, and it separated it according blah 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 blah, and you have all this history of the patients. When he's coming.
Yes, that's it. Yeah? Because in former times we had all paper sheets, and then they say, yeah, it's done, put it away, scan it, and then no one looks at it. But now we have a score, and the score, you can get a score, and it's there, a list with the scores, and you can compare it. That's wonderful.
Can you, in Freiburg or in Hradec, can you see, if you see your screen, can you have the score, the developing? The patient is better, worse?
We don't, because we have still paper.
Paper.
Yeah, so we have paper for the scores, and we also have paper charts still. So no.
No.
We have a digital tool, so digital patient card, and we have to copy the result, and then we're taking this result as baseline in brackets throughout the time while we are treating the patient. So it could be better, and there is a IT solution available as a kind of diagnostic manager where you actually can see the change as well, and that's also sold to private practice. And so the problem is that university clinics tend to be extremely slow in, getting the access on the heaps of data that we are actually producing. So that's why we are probably on the back end. If I'm just in my practice, okay, it's much quicker to invest and get the decision done.
Honza Vodička, Pardubice.
Would have a comment. We have paper version, but we have to write it down in the documentation, but it's not that easy to find it. But if we prepare some case report, then we will find it. So
yes, if you prepare...
But really it's missing. The special table for just follow-up of patient, this is missing. But because I was in Germany many times, I think you always did a lot of questionnaires, and it was not that typical in Czech hospitals. So you are several years in advance, so we now start our paper form, but we should skip immediately to electronic, as Pavel mentioned. But another thing is that I think in the rhinology it's quite perfect. If I compare it with otological part of our patients, they have no questionnaires, even they are available and they exist and they are used, but we just started several months ago just ear questionnaire, and I think the rhinological, just European rhinological group is in advance, so.
Yes, but otologists, they have audiogram. Yes?
Okay, that's true.
And what about Brno?
We use questionnaires only for patients with biological therapy, not for patients after and before the surgical therapy.
Where do you see future of patient with chronic rhinosinusitis? In 5, 10, 15 years, will we operate and more, or will be operation reduced? What do you think? And what would you do if you have chronic rhinosinusitis? Would you like to go for operation or not?
I think surgery will still be important even within a few years, because it's not only that biologics are expensive, they are not without risks and complications, and we don't actually know what they can produce complication-wise in 20 years. There's some evidence coming up now that the cardiovascular risk might be, after long-term use, might be higher. And the thing is, we always, when we talk about biologics, we always talk about these recalcitrant, really hard to treat patients. And we forget to talk about the 80% that we actually can control well with surgery. So I would hope that I'm within these 80% that can be controlled with one single procedure probably. And I would definitely opt for a good surgeon to perform my sinus surgery.
Yeah. And you, Achim?
Yeah, I'm with her. So any chronic disease, and also the, when I told you about the side effects in omalizumab, which was a young lady, okay, and I was giving the stuff, and then next day I was calling okay, and it's unusual for me to give patients a call on the day after, and that tells you everything about the amount of, worry that I was putting in there, trying to become aware whether she's coping, whether I should get her off the stuff and so on. So I didn't like that. And with, the pregnancy, okay, I'm not going to become pregnant. Okay, sorry. But generally, it tells you a story about, the impact it may have, or the joint problems or conjunctivitis from dupilumab, okay? So there's lots of stuff going on, and we have patients we are really highly frequent now for hypereosinophilic syndrome. I didn't know that that was an issue before we started to look after them. So try to avoid medication if you can. And I mean, there are currently quite good surgeons available in the world, so why not?
And Victor, where do you see position of these biologics and future?
So as was mentioned before, so we should wait for some studies and we will see if we have better experience with biological treatment, but it's a little bit difficult for new surgeons because they will have low experience with the surgery.
But good experience
with biological treatment.
Biological treatment. Yes. Any other questions? Jürgen?
So my opinion is we are at the beginning of a great development now, and we cannot see where it ends. But I think that when you sit here, I hope that I can sit in 10 years again, that we will not discuss anymore about this kind of surgery we discuss now. So think of the times when we operate all the approaches from outside and from cultural look. When we start, my chief said, "Why did you do this? It's nonsense. No one will do this in the future." And within 5-6 years, we do all the endoscopic approaches. And why should it stop now? That's the first beginning. We have only 3 or 4 drugs now, medicaments now. And the industry is eager to develop more and more. I've just read that they also started to develop a spray with this type of medicaments. I will not rely on that we will operate furthermore in 10 years on specific cases, but normal cases, I think they will be treated conservative. That's it. That's the future. You cannot stop it. You can sail against the wind or you can take the wind with you. That's the only thing. But operation will go down. That's very clear.
Thank you. When I was younger, and we started with my colleagues some surgery. I don't know what kind. My boss, he said that be careful because medicine is going in circles. It was there 30 years ago. Be careful. Then they stopped to do it. We started to do it again with different equipment. But I think that never knows what can we expect in 10, 15, 20 years. We are now is shortly after 5 p.m. so our plan was fulfilled. I would like to thank you for being here so long. Nobody is at home. And I would like to invite you for gala dinner. Do you know where is it? I am not sure, so Vicky will introduce the place. It is not far from here. It is approximately 15 minutes walking, 15 minutes from here. We start at 9:15. 9:15. It is the name of this 1915. It is restaurant Radegostovna Aura. You can find it. And Vicky, try to explain.
I found a map. I think that the map is in your handout, so you can find it. So Mr. Professor said everything. So welcome to the gala dinner at 8 o'clock. It's
at 7:15. 7:15 p.m.
Okay. We are here, and the gala dinner will be in Radegostovna pub here. So you have a map. You can use the taxi, your legs, everything.
It's warm there, so you can walk.
Yes.
So
thank
see
you. Very
you.
much.
Thank you, and tomorrow we start again with 8 o'clock, directly at 8 o'clock.